వచ్చారు అది వెల్కమ్ నోటు స్టార్ట్ వచ్చారు
lifestyle management. So, I am the host for today's conference. Moving to the scientific sessions, we are going to start the session, and I introduce the chairs for this session. Dr. Venkat Swami Burgula. Dr. Venkaswamy Burgula, a distinguished trauma and orthopedic surgeon at Roma Hospitals, is one of few or only orthosurgeons trained in abroad in Kompally. Overall, 25 years of expertise to this field with a deep commitment to patient care and a passion for innovation. Dr. Swami is dedicated to providing exceptional orthopedic solutions. Trust in his seasoned professionalism and experience for your overall health and well-being. Next, I introduce Dr. P. Srinivas Rao, consultant endocrinologist, MD. He has done his MD from Gandhi Medical College, DNB in endocrinology. His interests are in endocrinology, growth, puberty, thyroid, and diabetes. I introduce Dr. Samantha Satyakumar, consultant endocrinologist at Apollo Hospitals, Jubilee Hills. She has completed a DM in endocrinology and senior residency at
Opportunity on that day, we had the opportunity to honor our senior endocrinology professors throughout India, late Dasu, who was the first endocrinologist in India, professor of PJ Chandigarh. He is a guru of my guru, Dr. Sudhakar Rao, late Sudhakar Rao, sir. This is the first conference without Sudhakar Rao, sir. So he's a great personality. We are going to remember him like a 10 o'clock, we had a small session about sir. So we are missing sir. This is the first conference after idea clinic formation. Without sir presence, it's a very, very sad event for us. So we are moving to an academic session. Dr. Kishore Young, pediatric endocrinologist practice in Hyderabad, who has experience of treating a growth hormone deficiency disorders. So we're lucky to have a speaker like Kishore, who has experience in disease.
Thank you, Srinivas sir, for kind introduction. Today I'm going to talk on weekly growth hormone in diagnosed cases of pediatric growth hormone deficiency. So before moving into my talk, I would like to thank organizer for inviting and making this to happen today. So I want to welcome you all. Next. So the journey of growth hormone started from last 7 to 8 decades. So the first time around 1950, it was extracted from the animals and human cadavers. around 1957, 1958. So first human growth hormone which was extracted from the pituitary gland was injected into the patient for the first time. So since then, growth hormone showing so much of miracles, especially in pediatric children with growth hormone deficiency. So isolated growth hormone deficiency is one of the most common pituitary hormone defect, and it is a rare disorder, and the diagnosis depends on combination of auxological, clinical, biochemical, genetic, metabolic and hormonal abnormalities. Short stature is a key in diagnosis of GSD. It may be congenital, acquired, or maybe idiopathic. It has a diagnostic challenge because there are no standard guidelines, and even as, diagnosing growth hormone predominantly depends on auxological criteria, but to support the diagnosis we need confirmatory test. So whatever the provocation test we are using, they are not gold standard. So at least two provocation tests should meet the criteria of failure to respond on two different occasions. Then only we can able to diagnose growth hormone deficiency. There are no standard cutoffs of IGF-1, IGF-BP3 level, especially in developing countries like in Indian children. But still, nowadays, there is a significant data is coming up, and low IGF-1 level are suggestive of GSD. MRI and X-ray hand, they will help us to reach our clinical diagnosis. So, which children should be evaluated? Any child whose height is less than 2 standard deviation. If the height is not meeting the mid-parental height or familial background, and there is a significant decrease or fall of growth velocity, they need evaluation. So, but still, auxological, accurate and repeated measurements are key for the diagnosis of growth hormone deficiency. And growth hormone is produced in a pulsatile manner, more predominant in night, and there are different provocation tests and different agents are used. In India, we use like a clonidine provocation test in children who are less than 1 to 2 years. In my practice, I may use insulin as a provocating agent for the diagnosis of growth hormone deficiency. And there are different guidelines, and they have a different diagnostic criteria according to the national guidelines. So predominantly we follow USA and UK guidelines. We usually take cutoff of 10, and also we use clonidine as a growth provocating test. So and we routinely use priming. So any children who's having Tanner stage of 1 and chronological age of 9 years for the girl and chronological age of boys, in those we will do priming. We use both testosterone and estrogen for the priming agent, and before doing priming and evaluation, child should meet the criteria where the height is less than 2 Z-score, growth velocity is less than 25th centile, and sometimes we may ask for the repeated measurement, so wait and watch may be required, and we do bone age assessment. At least it should be delayed by 1 to 2 years. Then we will go for the provocation test, and when the growth hormone level is less than 10, we confirm and diagnose as a growth hormone deficiency. So, like growth hormone therapy is an essential component for the treatment of GSD. So, as earlier said, the clinical implication of growth hormone journey started from last 30 to 40 years of timeline, and recently long-acting growth hormone is started and approved in 2022. First time in USA and UK in 2022. So there are different indications of growth hormone, like growth hormone deficiency, CKD, Turner syndrome, Prader-Willi syndrome, SGA, idiopathic short stature, Noonan syndrome, and chronic diseases. Skeletal dysplasia, but routinely in skeletal dysplasia, we are not using growth hormone. The growth velocity and final height outcome in children. It also helps to improve the quality of life. Cardiovascular problems will be minimized. Metabolic and endocrine parameters will be improved in children who receive growth hormone, and peak protein content in both muscle and bone will be achieved with the growth hormone. So when there is a possibility, you can continue growth hormone even in adults, but at least in children we use growth hormone supplementation at least they reached final height, or when the epiphyses are fused, till then we use growth hormone. So what are the challenges in growth hormone is presentation. So usually in Indian children, they present at the age of 2 years and 10 to 12 years of age, because around 2-3 years of age, they started going play school or primary school. Then when compared to other peer groups, they found the child will be short. And when there is a pubertal abnormality or a delayed puberty, and because of the alteration in pubertal spurt, the child noted that they have a growth hormone related problem, then they will come to clinics. And late diagnosis will give a late treatment, and growth will grow as a dynamic ICP model of growth curve. Infant, child and pubertal growth spurting will be there. There are different parameters which will influence the effect of growth hormone. So I'm not going in detail. So it is not a problem in developing countries where there are resource limited conditions are there, but even resourceful conditions like Germany, United Kingdom, Spain, the delay diagnosis is the problem. So the delay diagnosis result in delayed treatment, and like a mean age of presentation was around 5 to 7 years, whereas in United States it went up to 10 years. So we are not away from the Western countries. Even in Indian countries, the mean age of presentation, diagnosis and treatment is around 9 to 10 years, and sometimes it may go around post-pubertal age. So by delayed initiation of the treatment, final outcome will be impaired. So the final outcome will be, we want to increase the child. So near adult height should be reached. So if we start growth hormone early, the near adult height will be achieved almost like adult. If you started late, the near adult height percentage will be minimized. So not only reaching adult height, the change in height deviation score, if you started early, the change of height deviation score will be almost -2 to 2.5 Z score will be changed if you initiated early, especially pre-pubertal, before 8-9 years. If you initiated growth hormone, the change in height standard deviation score will be very minimal. It may be less than 1 Z score. So 66% of the children who missed 1 or 2 injection, the final height outcome will be minimized and compromised. So as shown in New Zealand study, so almost 66% of the children, they missed growth hormone. If they missed more than 3 injections in a week, so almost the change in height Z score will be only less than -0.5 to -1 Z score. If they continued at least 6 times injection in a week, the near adult height reach and height velocity change will be almost like a normal children. So missing growth hormone will affect the final outcome. So adherence. So why the children are missing growth hormone? Because of the adherence, because of the daily therapy, they are not comfortable. They miss injection, they may forget it. So it was like proved and confirmed in ECOS studies. So it is like EasyPod. There is a device. It is an electronic devices. It will have a injection calculator. So there is a pre-designed injection calculated doses. So at the end of week or at the end of 1 month, the children will be called for the follow-up, and they will ask for how many injections were missed and how many injections were given. So if they misses more than 75% of injection, so the adherence will be drastically come down. So the final outcome will be decline. So it is not only problem related to the caregivers and patient, even clinicians also facing a lot of problem. So 52% of the children, they miss growth hormone daily injection. The because is, especially in adults, they miss injection, fear of pain, and they are reluctant to seek the medical advice. So because of n number of reasons, they are not happy to take injection. So because of that, adherence will be compromised. And by taking growth hormone daily, the psychosocial outcome and the quality of life of a children with growth hormone will be compromised. So the another outcome, whenever we are dealing with any child with growth hormone deficiency, not only attaining final height, we should concentrate on quality of life and psychosocial adjustment. So it will be compromised. So in Japanese study, especially in GSD and idiopathic short stature, without starting growth hormone itself, the quality of life will be compromised. By taking growth hormone daily, there is no much change in improvement in quality of life. So now I'm moving to the long-acting growth hormone. As everybody know, growth hormone is a polypeptide protein. It contains 191 amino acids. So now I'm talking about the long-acting growth hormone. The structure is altered, but the function and efficacy of growth hormone will be maintained. How it will be maintained? So HCG, 3 CTP copies will be attached to the growth hormone. One will be at the 5 terminal and another 2 copies will be at the 3 terminal. The clearance of growth hormone will be compromised, but the potency, efficacy, and the duration, the action of the growth hormone will be maintained with the long-acting growth hormone. So is long acting we are trying for the first time in growth hormone patients? No. There are existing growth hormone alteration in another condition in other specialties. Like in hematological conditions, like in hemophilia, the routine regimen is prophylaxis of anti-clotting factors weekly, like daily, 3 times in a weekly or like that. But by introducing long-acting therapy like once weekly prophylactic dosing, greater adherence will be improved, robust homeostasis is maintained, low bleeding rates, no major safety concerns are noted. So not only in hemophilia, coming to our specialty like endocrine, in type 2 diabetes, initially we used to give GLP daily therapy with liraglutide, but now recently Trulicity, exenatide, which are weekly and fortnightly growth hormone, GLP-1 analogs are available. So significantly increase the incidence, adherence, treatment satisfaction is improved, there is an improved quality of life. So that's the reason we are also keen in introducing long-acting growth hormone in children where adherence, safety, and long-term outcome is questionable. So we want to move from daily therapy to weekly therapy of growth hormone. So by introducing weekly therapy, what are the advantage? So the injection frequency will be reduced so that adherence will be improved. Once adherence is improved, efficacy of the growth hormone will be improved and increased flexibility. So there are different efficacy and safety trials. I don't want to go in detail, elaborate, but just I want to tell about the crux of the studies. So it is Jelinska et al. Study, so which was published in 2021 and 22. So inclusion criteria are mentioned here. So the children who are at the time of enrollment categorically grouped into 2 groups. One is weekly therapy and one is daily therapy. And again, weekly therapy regimens, children are sub-categorized into different dose regimens, subgroups. One is 0.25 milligram per kg per week, 0.44 milligram per kg per week, 0.66 milligram per kg per week. So what was the final outcome? We want to compare is weekly therapy is comparable with daily therapy or not. At the end of 1 year, we want to know what will be the adequate dose of growth hormone weekly therapy, whether it is a 0.48 or 0.66 or 0.24. So we thought, they thought initially it was a 0.48 will be adequate, but subsequently for their knowledge, they came to know that 0.66 milligram per kg per week will support maximum efficacy at the end of 1 year. That's the reason after extended 1 year, they have subgrouped the daily therapy into weekly therapy, and at the end of 2 years, all children receive 0.66 mg per kg per week. And they continued the study for the 5 years. So at the end of 5 years, what they noted is 0.6 mg per kg per week of long-acting growth hormone is equally effective, non-inferior. There are no major side effects, and it can be given, and even IGF-1 level will be maintained even after 5 years of time. So whatever I've quoted, so these are the data available. The red bar diagram is indicating weekly therapy. So 12.5. So other weekly 0.6 is also mg per kg week efficacy is equally effective. And moving into the third study. So because in phase 2 study, only developed nations were included. Developing in, nations like India is not included. So in phase 3 study, developing nation like India is included. So in this study, so 2 groups are chosen. One group is 0.34 mg per kg per day of daily therapy, and another group they received 0.66 mg per kg per week, and they studied for 1 year. And at the end of 1 year, they noted that daily therapy and weekly therapy, there is no much difference. Weekly therapy is not at all inferior. So it favors. So demographic data, age, sex, ethnicity parameters, all are comparable. There is no statistical difference in efficacy of the weekly therapy of growth hormone. And even IGF-1 level, so after 1 month of therapy itself, when there is IGF-1 was very low before starting initiation of the treatment, 1 year of treatment itself, they achieved 0 to +2 Z score of IGF-1 level. Even at the end of 1 year, the final IGF-1 level, there is no much significant difference. We think that giving one more, just 2 minutes. So by giving weekly therapy of growth hormone, which is such a high dose, 0.66 mg per kg per week, we think that growth hormone may be significantly elevated. But after 1 year of therapy also, it will be readjusted. So there is no significant much difference of IGF-1 standard deviation difference. And the children who are receiving weekly therapy of growth hormone, they are more positively detected to be having positive antibody against growth hormone. So almost 80% of the children who received growth hormone for weekly therapy, they detected to have positive antibodies. Still, presence of antibody is not deciding the efficacy and side effects. So treatment emergent adverse events, there is no much difference with the daily therapy and weekly therapy. So it is also indicating safe, immunogenicity is good, safety efficacy is good, and equally competitively effective with growth hormone. Coming to the cost factor, yes, there are financial cost concerns, and interference burden studies are also telling that cost factor will be increased exponentially, but burden and interference of the parents on growth hormone and lifestyle will be improved with weekly therapy of growth hormone. So summary is, diagnosis and management of pediatric growth hormone is a challenging for both clinician and patients. Timely diagnosis and management are critical for improving the outcome in growth hormone. But diagnosis delays are common. If you minimize the delay in diagnosis, the cost concern and financial burden will be coming down to the children. So daily therapy is routinely advisable, but it's giving a lot of challenge to the patient and caregivers. Adherence to daily growth hormone is suboptimal. That's the reason we want to move to weekly therapy. So long-acting preparation of growth hormone have a potential to improve adherence and clinical outcome. With this, I'm closing my presentation. Thank you.
Thank you, Kishore, for making a time. I think we have to take questions from our audience.
Sir, thank you for the talk. When we change the patient from a daily regime to a weekly regime, is there a dose-to-dose calculation that we can have? Because they only give one dose. And two questions, sorry. So the first thing is how to convert a daily regime to a weekly regime. Is there a dose equivalence? The second thing is that there is only one dose that they are recommending. Generally, we see in our that some people, some children respond at 1 milligram, some people respond at 2 milligrams. So how is the up titration? Is there a scope for up titration? That's two questions. Thank you.
Yeah. Sir, as per the only monopoly is there in India, we are using, I don't want to name any brand, but somehow I need to name it. Generation is the only brand weekly therapy available in India. So as per them, only there is no equivalent dose. Their advice is only 0.66 mg per kg per week dose. But in my practice, I feel, because being a pediatrician, we calculate the doses with gram or kg per body weight or body surface area, unlike in adults. So every dose, millimole or milligram of dose is sufficient, is enough to cause side effects. That's the reason. So initially, I start with 0.24 milligram per kg per week. I'll observe for 1 month, and then I'll escalate to 0.45. But to achieve maximum potential and efficacy, standard guidelines data is more available with 0.66 mg per kg per week at this point of time. So over 3 months of line, I will move from 0.24 mg per kg week to 0.66 mg per kg per week. So there are, and even I know that 0.66 mg per kg per week is even more than 100 mg per kg per day of growth hormone. Because a 10 kg child require 1 unit of growth hormone. It may be 0.3 mg per day. So that equivalent will comes on almost like 0.15 mg per kg per week. But here they have suggested 0.6, but I'm using long-acting growth hormone since last 9 months to 1 year, but even after using 0.6 mg per kg per week, maybe anecdotal or 1 or 2 cases, I have 30 to 35 children who are on long-acting growth hormone because of logistic region, non-availability of noditropin, non-availability of daily dose of growth hormone. I need to move majority of my daily therapy children to weekly therapy. So I'm using them, but somehow after using 66 milligram, 0.66 milligram per kg per week, so few cases have raised intracranial pressure, or maybe like erythema or some rash, or maybe raised IGF-1 level. But majority of the children, they are doing good with 0.6 mg per kg per week of dose. They are tolerating it, sir.
Any questions?
Sir, there are 2 doses are available, sir, 24 mg and 60 mg. So 24 mg, it is available for 17,000 around, and 60 mg it will be available for 22,000. And because of some cost concern also, company people are coming and they are reducing the price also on needy basis.
Is the government helping out in some patients? Because
Sir, as of now for weekly therapy, I don't think it is supporting.
We started, we are requesting Telangana government to supply. We asked for one patient on Argosy. We have to see the response.
Yeah, in Tamil Nadu, government.
Telangana government to supply weekly once growth hormone.
Yeah, I think Tamil Nadu government is doing it in some patients.
Telangana still not there.
Not yet.
We started only 2 weeks back, initiation.
Even Jipmer is doing, sir. Pondicherry.
Cost-wise much to be worried, same cost-wise. Only thing is, we have to know the data of antibody formation, this thing, those things, data, long-term data, we need a long-term data. And we had an excellent audience like Hari Kumar, who is a endocrine All India secretary, and my guru, Dr. Rakesh, professor of endocrinology, lucky to have a Guru Purnima day to see my guru. So we have a lot of people who are experienced in treating a growth hormone deficiency disorders. So we are treating regularly. Luckily, government is supporting RGC program. ESI is there. Railways are there. So India is now a developed country. So nothing to worry about cost.
Thank you.
Don't think of cost. Think of patient, indications, this thing. And we did a lot of studies also, applications are there who are interested in Gandhi experience. Turner syndrome. In 2017, we had 16 cases of Turner syndrome, March 2017, IgM publication. And 2023, we had one more publication for a Kishore point of view, adult growth hormone deficiency, who has obese. There's a problem in cutoffs of growth hormone. How to, somebody has obese, hyperpit, then the cutoffs are no, BMI wise no cutoffs. We made some study, 20 patients with a control match. We 3.3 for Hari Kumar. I think you have seen the article IgM. 3.3 cutoff is the where we made a ROC curve. We had for a glucagon stimulation 3 hours. But adult growth hormone obese. So 3.3 is the cutoff to make a diagnosis. I think you have gone through the article February 23 publication.
Correct. Yeah. So whenever you diagnose with GSD, don't think about the cost. There are so many NGOs and companies, generic medication. So rather than taking nothing, at least taking daily therapy, maybe intermittently, once, 2-3 times in a week also, it have a placebo effect, or maybe because of the number of reasons, there will be positive influence. So early initiation, the final outcome will be much more expected, and they reach near adult final height. So the take-home message to be from this stage should be diagnose early, treat early. So don't think about the cost factor, initiate some growth hormone, at least intermittent therapy will give a fruitful outcome. Thank you.
Welcome to my one more guru, my HOD, Dr. Vijayshekar sir, to a audience. And thank you, sir. Thank you for seeing on Guru Purnima Day. I think time is short, so thank you for organizers to give opportunity. I think we move to second topic.
Thank you, sir. Thank you so much.
Dr. Kalyan Chakravarti is a consultant endocrinologist trained in UK. He's closely associated with Idea Clinics. His research interests are growth, PCOS, type 1 diabetes, pituitary and thyroid. He's got special interest in advanced diabetic treatments of continuous glucose monitoring and insulin pumps. It's Kalyan Chakravarti.
Thank you, sir. Slides, please. Raghav, slides. Yeah, okay. So I'm going to be talking today about discrepant thyroid function tests and some challenging cases. So case 1, we'll see a 36-year-old lady who was referred with an endocrine to an endocrine OPD with a diagnosis of thyroiditis. She had high free T3 level, a normal TSH, and a high, or you can say a highish free T4 as well, or you can say normal T4 but just a high free T3 and normal TSH with mild thyrotoxic symptoms. Now you would expect that if their patient is thyrotoxic, the TSH should be suppressed, but this patient has inappropriately normal TSH in the context of high T3 and clinical thyrotoxicosis. So a thyroid scintigraphy showed that there is reduced uptake in the right lobe with detectable nodules, and there was attributed to some silent thyroiditis. No further investigations were done for 1 year, and she had persistent high free T3 levels. And a year later, a TRH test was done and a T3 suppression was performed. These are dynamic tests to confirm whether there is a problem with the pituitary gland, not with the thyroid. And the results were consistent with the TSH-OMA, which is actually a TSH secreting tumor, which we see very, very rare. The only reason we highlighted this case is if you see a normal TSH in the context of a clinically thyrotoxic patient, it just means that the TSH is the culprit, the pituitary is not suppressing to how it should, and you should always suspect a TSH-OMA. And we did an MRI, and they found to be a 3 millimeter pituitary lesion. So these TSH-OMAs, they are not really very massive, they need not be massive, and even a small minor lesion can also produce a clinically thyrotoxic patient. So the diagnosis was TSH-OMA. It's a very rare condition, approximately 1 in million. There are it's around 2% of all the pituitary tumor. Pituitary tumors itself is very rare, and of all the pituitary tumors, it's only 2%. And most of them are macroadenomas, some are microadenomas. They sometimes secrete co-secrete prolactin along with TSH. The clinical presentation if there's a TSH-OMA, it just means that the patient is clinically thyrotoxic. So they may have a goiter because there's a constant TSH stimulation, and the goiter may be present, which may mislead you to thinking that it might be a Graves, but it's actually the TSH stimulation which is doing it. Obviously, you will do all other hormone investigations like growth hormone, prolactin, and everything to make sure that the pituitary is actually okay. It is just the TSH which is the abnormality, and you will also do a visual field examination and visual field checks to see if there is any mass effect of the pituitary adenoma. And fertility issues can be there with this TSH-OMA. The treatment is obviously, the first treatment will be surgery, but you have to the diagnosis is the main bit. Getting the clinical diagnosis may be difficult. Once we find it, it's possible that we may just image it, and then the patient might be treated with surgery. The only other differential diagnosis is a resistance to thyroid hormone, which I will discuss in the next slide. In the case 2, this is a 29-year-old woman who was already confirmed to have TSH-OMA, which was clinical diagnosis of TSH-OMA. Again, the same thing, inappropriate suppression of TSH with a clinically thyrotoxic patient. So normal TSH and high T3, T4. She was started on methimazole treatment, but after discontinuation of the patient from methimazole, she underwent an MRI scan, and there was some suspicion of pituitary lesion compatible with microadenoma. Now we always have to take these lesions into with a pinch of salt, because if you send a patient to an MRI of the pituitary to a radiologist saying query microadenoma, there will inevitably be some form of microadenoma, 2 millimeter, 3 millimeter. So all microadenomas may not be functional, and we have to therefore then do these tests which differentiate between these two lesions, which is the TSH-OMA and the resistance to thyroid hormone. So this patient, although the TSH levels rose normally after TRH stimulation, the patient underwent transpyramidal surgery. So they diagnosed as TSH-OMA, they confirmed it, he underwent transpyramidal surgery, but histological confirmation did not reveal any adenoma, and the patient continued to have inappropriate secretion of his TSH, and still continued to have hyperthyroid symptoms. So this patient has actually a mutation. He has a mutation which caused the resistant to thyroid hormone. So clinically very similar to TSH-OMA. It is also again very, very rare. I have yet to see a case in India yet, and it is actually a autosomal dominant fashion. The remainder 20% have to be a de novo mutation, and it is generally because of the end organs receptor.
specifically a pituitary-related thyroid resistance. Your T3 is not feeding back to the pituitary, and the pituitary continues to secrete more amount of TSH, therefore causing thyrotoxic feature, which happened in that earlier patient. And many patients with this thyroid hormone may be relatively asymptomatic also, only with mild symptoms, just like you have familiar hypercalcemia, where you have calcium sensing receptor mutation. The patient just goes unchecked. Or you have monogenic diabetes,
Slides completely.
where you have glucokinase mutations. So these are all very mild mutations which may remain unchecked. Generally, treatment is not required because the patient is very mildly hypoxic or hypothyroid. You don't require anything. If there is mild thyrotoxicosis, you can just put them on beta blocker. Other than that, you cannot do anything much because it's a receptor level mutation. Now, this is more important, how to differentiate between the TSH-OMA and the RTH. There's a lot of overlap. You can have a clinically thyrotoxic picture with resistance to thyroid hormone if it is a selective pituitary resistance, which may overlap with the TSH-OMA. And the TSH level is actually normal in both levels. So you cannot depend on this TSH levels. So the best diagnosis will be alpha subunit of the TSH. So the alpha subunit is much more higher if you take a ratio of alpha subunit to TSH. That the alpha subunit will be higher in production, which is diagnostic of a TSH. This is generally one of the most classical or most typical presentation of a TSH, where you have a high alpha subunit production, which confirms that this is a TSH. Almost 70% of patients with TSH have a high alpha subunit. There are other tests to differentiate between a TSH and resistant to thyroid hormone. It can be a TRH stimulation, it can be a T3 suppression, but we will not go into all those specialized tests. The other thing to do is to do an octreotide suppression test, where you have any tumor will actually suppress with an octreotide. Any neuroendocrine tumor will suppress with an octreotide, but if you have resistant to thyroid hormone, there is no change with the TSH. So I'll skip this case. The main thing to take from this case is that there is biotin assay interference. We just wanted to highlight the importance of assay interference. We do see a lot of patients who have slightly high TSH, slightly low TSH, continue to monitor, antibodies are negative, it doesn't go anywhere but just remains like a slight high TSH. It's possible that these patients have some antibodies in their system which are causing heterophil antibodies to TSH, which cause a slightly high level of TSH to be detected in their system. And just keep an eye out for these patients. You don't treat them. So not all subclinical hypothyroidism actually require for you to be treated. If the TSH is stable, not improved, not increasing, and antibodies are negative, you can actually wait and watch. The assays can arise because of different antibodies. It may be because to the TSH, it may be to the total T4 and total T3, and many different samples may also give you the same result. This is the same thing again. You see a lot of antibodies which interfere with your TFTs, and biotin specifically, biotin therapy can give you some disturbance with your thyroid function. So I just wanted to highlight about a few different scenarios and how to differentiate these for non-endocrinologists. If you have to differentiate the pathology based on the TSH, based
on the T4 or based on the T3. If you have a normal TSH, but if the TSH is normal and the free T4 and free T3 is high, it can be either resistance to thyroid hormone or it may have central hypothyroidism because of other possibilities. So if the TSH is normal and other T4, T3 are high, the suspicion is TSH-OMA and RTH. If it is low, you may have central hypothyroidism because of whatever reasons. Now, if you have a low TSH, the diagnosis varies. If you have a low TSH with a high T4 and T3, obviously you have Graves' disease. If you have a low TSH with are all a variant of the same thing. Graves' disease is in adults. Neonatal thyrotoxicosis is because of other reasons. Hashimotoxicosis is where you have Hashimoto's thyroidism, Hashimoto's disease causing a switching antibodies which actually give you stimulation of the thyroid at one point and suppression of it.
So you may encounter these patients in practice where you have hypothyroidism and suddenly they go into hyperthyroidism for no reason. That's because of these switching antibodies. And again, you have clinical diagnosis very similar to Graves, but it is just that it came from hypo to hyperthyroidism. The patient is very sick. Obviously, in central hypothyroidism, you have low TSH and low T4 and low T3. The next slide is not. Let's move to the next slide, please. Are you able to move to the next slide?
T3, ignore it. Just wait for the patient to come back. If it worsens, then you can always recheck again. Antibodies will give you a clear indication. So always check with TPO antibodies, antithyroglobulin antibodies, TSH receptor antibodies. These three will actually tell you whether there is any autoimmune disease or not. If not, you can actually wait and don't do anything about it. Total T4 and total T3 are generally not clinically viable tests. Only free T3, free T4 count as a test. Those are the actual clinically relevant, or clinically and biochemically it makes sense. But total T4 is not a relevant test. It goes up with pregnancy, it goes up with a lot of other conditions. Need to check total T3, T4, or if they are high, don't need to worry about it. If the free T3, free T4 is high, then yes, then we have to take it into account. In pregnancy, total T4, total T3, high total T4, T3 is very normal with a slightly low free T4 and free T3. So please take that into account. Always take that clinical picture and correlate with the biochemical findings. With that, I conclude.
Thank you, Kalyan. Sticking to a bell. That is a great speaker quality. Next speakers also should make a same bell time, because the idea is prone for a time bound. So we don't want to delay any program, and we had a good next Sudhakar Rao's program is there. So next speaker.
Yes. Thank you, sir. And I welcome Dr.
Samantha Satyakumar onto the dais and to chair the next talk. Dr. Samantha Satyakumar is a consultant endocrinologist at Apollo Hospitals, Jubilee Hills. She completed her DM in endocrinology and senior residency at CMC Vellore. And she did her MD in internal medicine at Stanley Medical College, Chennai. She also worked as assistant professor in Department of Internal Medicine at CMC Vellore.
Paradigm shift in type 2 diabetes management with combination injectable glargine and lixisenatide. It will be by Dr. Prabhami Reddy. It's my pleasure to introduce Sir, who's a senior consultant medicine in internal medicine. He's completed his MBBS and medicine from Sri B.M. Patel Medical College. He's an MRCP from the Royal College of Physicians, London, and he's the chief consultant in internal medicine in Aditya Polyclinic, Hyderabad. He has a vast experience of more than 2 decades in internal diabetes, medicine and diabetes management. Welcome, sir.
Thank you, ma'am, for kind intro. So today we are going to deal with the simplifying diabetes management with the combination injectable that's called Iglar-Lixi. So as we know that the type 2 diabetes is a chronic progressive disease which has got multiple pathological defects. So to address these multiple pathological defects, we have each agent right from insulin to the oral GLP, semaglutide. So despite evolution of many glucose-lowering therapies, still we have a challenge in diabetes management. So there are so many unmet needs to manage this kind of pathological difficulties. And not only even the pathological difficulties, we have the factors impacting the potential treatment burden of the complex treatment regimes. So the multiple injections, and with that, so reduced flexibility, then high risk of hypoglycemia and weight gain, and very erratic physical activities and erratic diet modifications and lifestyle adjustments. So with these unmet needs, we need a good molecule to address these unmet needs. So this is in the form of a combination injectable, so which contains a combination of insulin glargine U100 and lixisenatide. So it is recently approved for clinical practice in India. So this is a titrable 2 drugs. I would call it and one GLP-1 receptor agonist. We have GLP-1 analogs. Everybody knows that the pathological mechanism of action of GLP-1 analogs. What does they do? They increase the glucose-dependent insulin release, decrease the glucose-dependent glucagon release, and increase the satiety and decrease gastric emptying. On the other hand, you have a basal insulins which targets the fasting blood sugar, just mimicking the physiological insulin secretion. So what did they do? They do decrease the hepatic glucose production and decrease the gluconeogenesis and increase the glucose uptake in muscles and decrease the lipolysis. So with these two combinations, we have Iglar-Lixi. It is a potent synergistic combination to address the unmet needs of the type 2 diabetes management. So what are the potential benefits of the combination of injectable therapy? Number one, everybody has got, as we said, it is a multiple injections. So it is a once daily dosing, a single injection. So with this, we have a weight neutrality effects and also a lower rates of hypoglycemia and improved GI tolerability as compared to the mono components, and also effectively reduce the HbA1c, and also controls both the fasting and the post-lunch blood sugar, and address the multiple pathological defects. As we said that type 2 diabetes is a multiple pathological defects, omnious octet. Then, and the more people achieving glycemic targets with this combination of the injectable. So what do the different guidelines advocate? So we have ADA, AACE, and ADA and ESD position statements. The ADA advocates the combination of basal insulin and the GLP-1 receptor agonist has a potent glucose lowering action and less weight gain and hypoglycemia compared with the intensified insulin plans. So what about the AACE position statement? So the patients who are on the failure of OAD are the GLP-1 analogs. In this kind of patients, to achieve the glycemic targets, need to add the basal insulin should be added to alone or as a basal insulin with combination of GLP-1 RA. So what is the AD and ESD position statement in 2022 said? The combination of the basal insulin with GLP-1 RA results in greater glycemic lowering efficacy than the mono components with less weight gain and lower rates of hypoglycemia and better gastrointestinal tolerability than with the GLP-1 RA alone. So these are all the guideline recommendations on the combined injectables. Coming to the evidences of the IGLR-LIXI. So we have robust clinical evidence in the form of many trials. So especially the phase 3/3b trials named the SOLID and the SOLIMIC study. These are the two landmark trials which we are going to discuss today. So this SOLID trial, this is a randomized control trial, 24 weeks open label, done to compare the efficacy and the safety of IGLR-LIXI with premixed insulin idagasp in Chinese adults with suboptimally controlled type 2 diabetes and OADs. So the total duration of the trial is 27 weeks actually. The 2 weeks for the screening, and then exactly the 24 weeks is the week treatment period. And after the 24 weeks, the 3 days for the each arm, 3 follow-up days. And here, after the screening, the population are the adult with type 2 diabetes with more than 3 months on the stable dose of metformin plus or minus a second oral anti-diabetic, that is sulfonylurea, glycinates, alpha-GI, DPP-4 or SGLT2 inhibitors. And the inclusion criteria of BMI is less than 40 kg per meter square. And the HbA1c baseline is more than 7.5 to less than 11 if previously on metformin plus or minus SGLT2 inhibitors, and more than 7% to less than 10% if previously on metformin plus second non-SGLT2 inhibitors. So before screening, so before randomization in this trial, so the other second OAD were excluded except for the metformin and SGLT2 inhibitors. And here after the randomization 1:1 ratio, the IGLR-LIXI once daily and the idagasp once daily, and follow up for the end of the 24 weeks. So let's see the primary endpoint. The primary endpoint is the non-inferiority change from basal. So let's see the results. So also we have the other safety endpoints and the secondary key efficacy endpoints and the other secondary efficacy endpoints. So the secondary key endpoints are the superiority change in HbA1c and the body weight from baseline to 24 weeks, and the proportion of patients to reach HbA1c less than 7% at 24 weeks, and proportion of participants reaching HbA1c target less than 7% without body gain, weight gain, and without hypoglycemia. So these are all the secondary endpoints. So what are the other secondary efficacy endpoints? The change in FPG and SMPG from baseline to 24 weeks, and the proportion of participants reaching HbA1c target less than 7% at 24 weeks with no hypoglycemia. What are the safety endpoints? Safety endpoints in the form of the hypoglycemia. Any hypoglycemic event divided into 3. So ADA level 1, ADA level 2, and ADA level 3. ADA level 1 less than 70 and more than 54 milligrams per deciliter, and ADA level 2 less than 54 milligrams, and ADA level 3 severe hypoglycemia. So these are all the safety endpoints. So coming to the baseline characteristic, almost a similar baseline characteristic for the two each arms. So this shows that non-inferiority study and the superiority studies here. So with the ida gas in HbA1c reduction, in the first phase we have two molecules, that is the iglarlixy and the ida gas, have a non-inferiority in reducing the HbA1c level. So at the end of the 24 weeks. So if you compare with superiority, statistical superiority HbA1c reduction, so the people who are taking with the iglarlixy have a significant reduction in the HbA1c as compared to the ida gas. So benefit of ida gas in the solid study. So here the weight body reduction from the baseline 24 weeks with iglarlixy is superior as compared with the ida gas. Even the secondary key endpoints, the people who are taking the iglarlixy have reduced almost 72%, achieved HbA1c less than 7% at 24 weeks as compared with the ida gas, which is against the 15 almost 60%. And the people who are achieving the less than 7% HbA1c without body weight gain at 24 weeks are greater percentage in the iglarlixy, that is almost 40.5% of the people achieved this, and 26.5% of the people achieved HbA1c less than 7% without body weight gain at the end of the 24 weeks and no hypoglycemic during treatment. So therefore, the greater proportion of the participants treated with the iglarlixy reached HbA1c less than 7% and HbA1c less than 7% without body weight gain and without any hypoglycemia as compared to the ida gas. So this is the reduction in the 7-point SMPG values. So here it is the non-inferiority study at the end of the 24 weeks. Both ida gas and the iglarlixy have 7-point SMPG from the baseline to 24 weeks. But if you come to the LS mean difference, shows that the iglarlixy have a better 7-point SMPG scale as compared to the ida gas. So this shows that the statistical significant reduction in the both breakfast and the lunch and the all meals postprandial excretions, but they have a neutral effect of the both the iglarlixy and the ida gas during the dinner time. So comparing with the total insulin dose required in the both the arms, so the people who are taking the iglarlixy showed less number of insulin dose required as compared with the ida gas. So coming to the incidence of the hypoglycemia compared with the ida gas. So any hypoglycemia, so the in iglarlixy arm, so there is a significant reduction in the hypoglycemic risk. If you're coming to the ADA level 1 hypoglycemia, even the iglarlixy people have a less number of ADA level 1 hypoglycemia as compared to the ida gas arm. And coming to the ADA level 2 hypoglycemia, there is a 6.9% reduction in the iglarlixy people participants as compared to the ida gas. So therefore, any hypoglycemia, any event rate of hypoglycemia, so the incidence of nocturnal hypoglycemia between the bedtime and the walking was lower with the iglarlixy as compared with the ida gas. So there is another study called the SOLID study, so done for the non-inferiority and the statistical superiority in HbA1c reduction, and showed the superior body weight benefit, and more patients achieved composite endpoints and the lower risk of hypoglycemic events, no unexpected safety are the findings. Therefore, the iglarlixy should be considered as a valuable option for advancing therapy in people with the type 2 diabetes who are suboptimally controlled on the OADs. So second, we move to the second trial, that is the Lixilan-O study. The subjective objective of the study is the randomized open label to assess the superiority of the iglarlixy over lixisenatide and the non-inferiority of the iglarlixy over iglar in HbA1c change from baseline to 30 weeks. So here we have a randomization. So in one arm, we have a lixisenatide, 2 doses, 10 micrograms, 20 micrograms along with the metformin. And the second arm, we have iglarlixy with metformin. And third arm, we have iglar with metformin. So almost the similar number of participants with to achieve the meaningful HbA1c reductions close to the near normoglycemia without increasing either hypoglycemia or weight gain compared with the IGAR, and have low gastrointestinal adverse effects as compared with the lixisenatide. So, moving to the other trial with the bias 30. So we have two arms, that is IGR-Lixi once daily and the bias 30 twice daily. So the total number of participants 887 done in India. So the inclusion criteria: type 2 diabetes more than 1 year, 18 more than 18 years of age, basal insulin plus OADs, HbA1c more than 7.5% to 10%, BMI more than 20 to less than 40. Basal insulin starting dose screening is more than 20 to less than 50. So here it shows that the LS mean, the IGR-Lixi showed a superior to bias 30 in a change in HbA1c from baseline to week 26. HbA1c less than 7%, almost a 40% as compared with the bias 30. And the people also achieved less than 7% of the HbA1c without weight gain and without hypoglycemia, is much superior as compared to the comparator bias 30. So even the total insulin doses also very much reduced in the IGR-Lixi arm. So coming to the incidence of hypoglycemia is much superior in reducing the hypoglycemia, both in the any cause of any hypoglycemia, even ADA level 1 and the ADA level 2. And the incidence of nocturnal hypoglycemia is also very, very much less in the IGR-Lixi arm as compared with the other comparators. So finally, what we do, conclusion is the IGR-Lixi versus the bias 30. It has a better glycemic control with the weight benefit and less hypoglycemia, fewer daily injections, similar proportions of the side effects in both treatment groups. Therefore, the IGR-Lixi is an efficacious, simpler, and well-tolerated alternative to Premix bias 30 in uncontrolled type 2 diabetes. So let's see the make of the pen. So this is the pen right from the 10 to 40, and starting dose of the IGR-Lixi, we have insulin naive patients directly start with the 10 dose steps, and the patients who are on insulin glargine already, so they're taking the less than 20, so you can start directly to the 10 dose steps. And the people who are taking the insulin glargine more than 20, and you can equally substitute the 20 dose steps of the IGR-Lixi. And this is the ratio. We have 2:1 pen. This is a 3 ml pre-filled pen, contains 300 units of insulin glargine and 150 micrograms lixisenatide. And the dose ranges from 10 is the minimum dose and the 40 is the maximum dose. So dose titration, so should be usually if you have more than 140, you increase the 4 units. And when you with the blood sugar, fasting blood sugar, usually between more than 100 and the less than 140, you can make it to the +2. And when the blood sugar, fasting blood sugar reaches 80 to 100, there will be no change in the IGR-Lixi. And when there is a less than 80 milligrams per deciliter of the blood sugar, so you can reduce the 2 units. So weekly dose adjustment is needed with a median fasting blood SMPG. And what is the administration? The main administration is with the subcutaneous once daily within 1 hour prior to the meal. And preferable that if you miss a dose, it should be injected within the hour prior to the next meal. So what are the beneficiaries? The special population, elderly more than 65 years old, can be administered in the elderly patient also, and can be used in patient with mild to moderate renal impairment, and not recommended in patient with severe renal impairment, so whose EGFR is less than 30, and also used in the hepatic impairment, so can be safely used. For lixisenatide, no dose adjustment is required in a patient with hepatic impairment, and the pregnancy should not be used during the pregnancy. The risk of potential risk of human is unknown, And if a patient wish to become a pregnant or the pregnancy occur, treatment with Iglar-Lixi should be discontinued. And this is the combination injectable to treat the multiple pathological defects of the type 2 diabetes. The one injection once daily within 1 hour prior to the meal. So what of the take-home message? The combination injectables is a synergistic once daily combination injectable of basal insulin glargine U100 and the prandial GLP-1 RL lixinate that provides effective fasting and the postprandial glycemic control. And the take-home message from the SOLIDITY trial indicates that it's a simple, well-tolerated treatment that has shown better glycemic control with added body weight benefit and the lower risk of hypoglycemia events as compared to the IDA gas. And what is the take-home message from the SOLIDITY trial, Solimix trial? It's compared with the bias 30. The Iglar-Lixi is very, very efficacious and the simpler, well-tolerated, provide better glycemic control with the weight benefit and less hypoglycemia as compared to the twice daily bias 30. So these are all the take-home messages. So thank you, and thank you for your kind attention.
Thank you, sir. So it comes across as a great alternative for patients requiring step-up therapy from basal insulin. If anyone has any questions.
Sorry, not taking Kalyan questions also, thyroid questions. Suppose anybody in thyroid questions also will take up.
I have one question to the Dr. Kalyan. So nowadays, the recent introduction of the oral semaglutide. So even the patients are also hypothyroid diabetes having the oral semaglutide. Do you want to administer the dose at the same time, or do you do at bedtime with the oral semaglutide?
Thyroid tablet has to be taken on an empty stomach. So a lot of the times I ask the patient to, when they wake up in the middle of the night or something, just ask them to take it whenever. It doesn't have to be taken at any particular time, like 6 a.m. or 7 a.m. So I ask them, if you get up to go to the loo at 2 a.m., anytime 4 to 5 hours after their last meal, they can just take the tablet. So I do that if they are on, even if they are not on semaglutide, because a lot of the times they take tea or coffee immediately after thyroid. Now, if they want to wake up in the morning only, then thyroid first thing in the morning, and semaglutide, according to the literature, they say at least half an hour before your meal, half an hour empty stomach before your meal with minimal water. So you can probably still maintain a gap rather than taking both at once.
Still, do you want to give to the thyroid before the dose of the oral semaglutide?
Yeah, sure. Because any reservations for that?
Usually the injection semaglutide will be degraded. So not to degrade, they have a NAC technology.
Right, yeah.
So when with the NAC technology, the first absorption is on the empty stomach.
Right.
So if you give the thyroid, then if you give the oral semaglutide, so what are the interactions do you expect in that?
Any other panel that wants?
I'm really a senior endocrinologist. You can.
I have a talk on Ribel's semaglutide on the same thing, but nevertheless, since you have posed, the recommendation and the practice is to use semaglutide the first thing in the morning. At least give 30 minutes gap between your thyroid and semaglutide. Now the issue concerning, there may be a slight reduced absorption of thyroid if you partner it with some of the drugs, okay? But if you look at the efficacy, cost and side effect profile of thyroid hormone under treatment, then with the treatment, considering the cost involved, you would give the best possible position to the one which requires the clear absorption. So that is why the recommendation is first semaglutide, give at least 30 minutes gap, you can take thyroid hormone, or as what he has said, rightly, you can take it any point of the time. You pop in any time thyroid, maybe in the afternoon where you are just in that fasting state, or in the evenings. There are plenty of studies which said that you need not be only sticking to the morning time. So as long as you are, there may be a slight 10%, 15% additional reduction of increase of the thyroid hormone. Beyond that, you're not going to have any effect on it.
Thank you.
have a habit of forefathers waking up at 4 o'clock, 3 o'clock. So why can't we advise our youngsters to wake up at 4 o'clock, 5 o'clock, have a thyroid tablet, then have a easy, no? So we are making a simple way. Why to complicate this thing? So we have to remember our forefathers so that easy to plan, it will be easy, no complication, right? Thank you for, and actually my heart, I want to thank all the audience because coming at 8:30 Sunday, Guru Purnima day with Bonalu, it's not a small thing. Really, really, really appreciable. That is the greatness of our Bharat. That indicates that how Bharat is moving forward. So thank you, and on behalf of, I think, all the co-chairpersons, my classmate, Dr. Swami, who for Bharat Love, he came from UK to practice in India, orthopedic surgeon, senior orthopedic surgeon, and Samantha. So great to have a interaction with all the people. And good speakers, good time maintenance.
Thank you, sir.
We are concluding this session, and I would like to thank all the chairs and speakers for the wonderful session. Now, we are moving to the next session, and I would like to introduce the chairs for this session. Dr. Meher Prasad. I welcome Dr. Meher Prasad onto the dais. Dr. Meher Prasad is a consultant endocrinologist. He has done his MRCP, CCT in diabetes, endocrinology, and internal medicine. He is a professional member with World Obesity Federation, and he is also a member of the Task Force Education and Management Task Force of the International Association for the Study of Obesity. He also established a comprehensive bariatric surgery unit in Chennai in 2011. He is one of the first bariatric physicians in India. I welcome Dr. Sunil Reddy, leading onto the dais. Dr. Sunil Reddy, leading neuropsychiatrist. He has done his MBBS, MPH in USA and MD in psychiatry. Dr. Reddy is a consultant neuropsychiatrist based at Idea Clinics. He holds an MD in psychiatry from Government Hospital for Mental Care at Vizag. He is also a civil assistant surgeon or chief medical officer for the Telangana state. I welcome Dr. Ramakrishna Janapati onto the dais. He has done his MD in general medicine and DM in cardiology. He is a cardiologist with a decade of experience, currently affiliated with Apollo Hospitals and Idea Clinics. Dr. Janapati presented cases and papers in various national and international conferences.
Good morning, everybody. It's a great pleasure to be here. And I would like to introduce Dr. Chandana Merugu, consultant endocrinologist, for our next talk, premix insulins in Indian context. Dr. Chandana Merugu completed her MBBS in AFMC, MD General Medicine in JIPMER, and DM Cardiology in JIPMER. She is a consultant endocrinology in AIG hospitals, Gachibowli. Her research interests include diabetes, bone endocrinology, she's a member of Indian Medical Association, Endocrine Society of India, Indian Thyroid Society, and RSSDI. She's published she's had 10 publications in national and international journals, received prizes in oral poster presentations in ASMBR conferences, and a research grant from Endocrine Society of India. I welcome Dr. Chandana to your lecture.
Thank you, sir, for the kind introduction. Good morning, all. First of all, I would like to thank the Idea Clinics for inviting me for this conference. And after that intense discussion on Igla Lexi, I'm going to go back to what we have been using all these years, that's premix insulin. So, is premix insulin still relevant? We're going to talk about it and how relevant it is in Indian context. Okay. So, I'm going to talk about why Indian population is unique and what are the risks associated with the postprandial uncontrolled glucose levels, and how do we use insulin in Indian context? What are the guideline recommendations worldwide and Indian guidelines also? And we'll have a couple of discussion on cases. So why are Indian diabetic patients different? If we look at the diabetic survey which was done in 2014, this was a START study. This was a dietary survey which was done looking at patients how they take carbs. We see that the carb content of the Indian population is pretty high. Most of us take about 64% of energy from the carb. This is not common in the Western population. This is more relevant to the Asian and more in Indian population. And Indian versus Caucasian, multiple studies have done, and they have looked at the HbA1c, which was, as the HbA1c goes higher, they looked at which component, whether the fasting blood glucose levels or the postprandial blood glucose, which contribute more to the A1C. If you look the studies from Indian population, as the A1C goes up, it's the postprandial glucose which is the main contributor, whereas in the Caucasian population, it's the fasting glucose which is the main contributor. So we understand that the postprandial glucose levels are much higher in Indian population. And why do we need to be concerned about this? We know that postprandial glucose levels have a lot of risk factors, mainly the cardiovascular risk. They can increase the carotid intima media thickness. There's a risk of increased myocardial blood flow reduction. There can be a decreased diastolic function. There's increased oxidative stress. The inflammatory markers increase. There's also an increased risk of pancreatic cancer with this. So we need to be concerned about this postprandial hyperglycemia. And not just because of these risks which increase, there's also a risk of mortality. The risk of mortality also increases as the postprandial glucose levels increase, but the same fasting glucose levels. As the postprandial levels increase, the mortality risk worsens much more. And this is an independent marker for that. And when we are looking for the glycemic control, when we are looking at a good HbA1c control, only controlling A1C does not bring the A1C. Sorry, only controlling the fasting blood glucose levels does not bring down the A1C. But when we are concentrating on the postprandial glucose levels, when we try to bring down the postprandial glucose levels under control, that's when our A1C levels also come under control and they come less than 7. And how do we use insulin in our Indian context? So, as you all would have experienced, initiating insulin is very difficult. There is one inertia from the doctor's side, and also not just that, there's an inertia from the patient side also. Most of them are very reluctant to start that. So usually what we try to do is we just try to intensify the OADs, increase the doses of OADs, increase the number of OADs instead of starting the patient on insulin. Unless the A1C is very high, we do not go for insulin initiation. This is not right actually, because early initiation of insulin when needed can prevent a lot of complications. There are multiple insulins which are available in the market. I'll be just talking about few formulations. The human insulin, which were there earlier, then we have the analogs. The human insulins were the short acting, the regular insulin. Then we had the intermediate acting, which is NPH, then the long acting. Then we have the premix in the human insulins. Then the analogs. We commonly use analogs these days. There could be either rapid acting or the long acting or the ultra long acting, and also the premix. So I'm sure you all know about all these. So how do we go about using insulin? What are the guideline recommendations? Do we start insulin as a basal insulin or a premix or a basal bolus? How do we start insulin in type 2 diabetes specifically I'm talking about? So most of the guidelines suggest that we should start with basal insulin alone in addition to OADs when the patient has A1C more than 9. The ADA, the AACE, the IDF, the Canadian guidelines, all this suggest that we should start with basal insulin alone and then escalate, intensify as needed. Whereas other guidelines like the National Institute of Health and Care Excellence or as the RSSDI India, some guidelines from Australia, these all suggest that we can either start the patient on basal insulin or a premix insulin or co-formulations like what we were talking about just now, as we can decide upon the particular patient. So this is again the guidelines which they suggested, the ADA, ASD, and the Canada guidelines. All these suggest that we should start with basal alone. But the AACE, they say sometimes we can consider a premix. So when do we think of premix? Let's look at the NICE guidelines. What do they suggest? They suggest that we can start the patient on premix if the patient prefers taking insulin just before the meal, if the patient has glucose levels which rise markedly after the meal. So in such situations, we can consider putting the patient on a premix. The RSSDI guidelines, these also suggest that we can start the patient either on a basal insulin or we can start the patient on a premix. The other guidelines also say that we can start on a combination. Okay, so when do we choose a premix? What exactly are the conditions where we choose a premix? The premix we usually choose if the increment, the post-meal increment is more than 54 mg per dl. That means the is low, but when some patient has a meal, which usually in Indian population is a high carb meal, then the postprandial glucose levels are very high. That means the patient needs a bolus dose at that time. The basal will not take care of it. So we need to add on a premix for this patient. If the fasting and HbA1c ratio is less than 20, that also means that controlling the fasting glucose is not taking care of the HbA1c. And sometimes we have the psychological factors also. Patient, like if we want the patient to be on basal bolus, 3 times bolus with a basal, most of them would be very reluctant to start on it. So making it more simpler, although it's a fixed ratio, we can have a better control with that. We can put the patient on premix, especially elderly. They won't prefer to take multiple injections in a day. So in such patients, putting them on a premix might be a wiser decision. And this is again the repetition of that. So again, depending on the patient's lifestyle, the choice, and how the postprandial glucose levels are. And usually, as the duration of diabetes increases, most of the OADs, the sulfonylureas, do not work well in such patients. So we usually try to replace the sulfonylureas with the premix insulin. So as I was saying, when the increment is very high, more than 54 mg per dl, if the patient is not able to manage on basal bolus, if there's a very high carb intake, usually in one meal of the day, and we know that yes, patient has a routine. This is the normal routine the patient takes meals, fixed routine, instead of putting a premix and adjusting the doses as needed. So there were multiple studies which were done, this meta-analysis which was comparing premix with basal insulin. They showed that the difference in A1C was not much. The patient would do well on premix also. So choosing again depends on what are the patient's requirements. We look at the patient, see what patient's medications are already there, how high is the A1C, what is the postprandial glucose levels, and then we decide whether to put a patient on a high mix insulin, that is more of bolus compared to basal, or a low mix insulin which is less bolus with high basal, or only basal. So let's discuss a couple of case studies. So when do we start premix in a patient? So this is a 52-year-old lady who was type 2 diabetes for the past 12 years. A1C is 9.3, which is uncontrolled, and other parameters are decently fine, and with a little hyperlipidemia. She's already on multiple OADs, and she has a history of UTI. So if she has a history of UTI in the recent past, we usually avoid SGLT2 inhibitors. So what else can we do? She's already on sitagliptin, glimepiride, and also on metformin. Already 3 OADs are going on for her. And how do we go about deciding what to do for her? And she's an Indian homemaker who usually takes more high carb diet. So the studies with premix versus insulin glargine plus metformin, they have shown that there's a better reduction with the premix compared to glargine. Also, the risk of hypoglycemia is lesser compared to the basal, even the overall hypoglycemia or the nocturnal hypoglycemia also. So this patient was started on a premix along with whatever medication she was taking, and later once she was stabilized on the premix, her sulfonylurea was also stopped and she continued to have a very good glycemic control. So putting a premix in the morning and evening, especially when they take the high carb diet, that helps in bringing down the glucose levels. So how do we go about intensifying insulin in patients who are on premix already? So this is another patient who is 68-year-old male, for diabetic for the past 15 years. He's on metformin, vildagliptin, glimepiride, and also a low mix, the mix 25, premix 25. So again, in spite of being on a premix, his glucose levels are not controlled. His A1C is 9.2. What do we do for this patient? If you look at the glucose charting which was done, the 6-point glucose charting which was done, we can see that the excursion which is happening at the breakfast time is about 100. So in spite of taking a mix which is 25 with 25% of bolus with 75% basal, there is high glucose levels post-meal. That means he needs more of bolus in the breakfast time. And if you look at the before dinner versus the after dinner values also, there's a high excursion in the glucose levels. So he needs another insulin at that point, but the excursion is not very high. So what do we do for this patient? So let's look at how we can change. So the mix, we can put premix of 50, which has basal 50 with bolus 50, and we can see that the glycemic control is much better. And the nocturnal hypoglycemia risk is also not usually much high with these patients. So in this patient, since we realize that the glucose excursion in the breakfast time is much higher, we can put a premix 50 in the morning and premix 25 in the evening, because we don't want a hypoglycemia at night, and titrate the doses as needed for the patient. And once the patient is stabilized, we can continue that, and this patient after 3 months was found that A1C had come down to 7.4. So we understand that yes, Indian population premix has still a major role, although basal is the one which is usually recommended, but in case we understand because of postprandial glucose levels, it's better to start a patient on premix at least once a day and then escalate it to twice a day as needed. To summarize, the postprandial glucose levels have a significant contribution, especially in Indian population. Premix are very simpler to use compared to basal bolus, and patients who are already on OADs, multiple OADs, initiating on a premix will add on to the glycemic control. And it's usually simple enough, even the elderly, we can explain them and it can initiate easily. And it's very convenient. Thank you all for patient listening.
Thank you, Doctor. It was a very appropriate and excellent presentation. As you said, the Indian population and also the Caucasian population are very different, both in the dietary aspect and also in the body structure. So and you eloquently highlighted that. Thank you. Any,
lot of South Indian population consume lot of rice, like
Yes,
especially Andhra, Telangana, Tamil Nadu. When compared with the rice and other diets like wheat-based diets, which has produced like lot of postprandial surge.
So it again depends upon the quantity they take in. We usually say that if patient is already on rice and they do not want to change to a wheat-based diet or they have gluten sensitivity, then we say continue the rice, but the quantity needs to be controlled. The carb content needs to be reduced. So, but if you look at the normally ratios, how it works, that when the patient usually is on rice, they usually tend to take more amount of rice. The carb content in the meal is much higher compared to one somebody who is taking wheat-based meal. So that way the postprandial glucose are much higher, especially when they are taking rice. But if I have seen many of my patients, most of my patients are from West Bengal, most of them are rice eaters, they would not change to wheat or rotis. So in such patients, we say that reduce the content of the rice. At least that way, and increase the other vegetables or the salads in the diet and reduce the carb content.
Do you have any experience with the millets and other?
Pardon, sir?
Do you have any suggestions about millets or other low GI foods?
Yes, sir. I have seen that millets usually have low glycemic index, especially jawar and bajra. So once most of my patients who have changed from a rice-based diet to a millet-based diet, the requirement usually comes down. That works.
Thank you. Any questions from the audience?
Good morning. Thank you. Sure.
Post lunch,
Yes,
or
ma'am.
post dinner, or post breakfast, but they eat good amount. Do I need to start any treatment, or usually I say like control with diet and walking. If the HbA1c goes up 6.5, then you can consult a diabetologist. That is what I'm advising.
Yeah, I understand. So usually you're talking about a pre-diabetic stage.
Yes,
So
ma'am.
usually in pre-diabetic stage is when they start developing the insulin resistance, and usually in this stage the fasting glucose is the one which starts increasing. So in case the patient is already obese and you understand that the patient has a lot of high fasting insulin levels.
No, not obese, madam. Like BMI is under control. Like it's like a 25, 26.
Yeah. So first thing we again suggest is a dietary change, because you're saying she's been taking high carb diet in the night. She can change that. That's ideal. In some situations, we add on metformin.
Okay. So do you suggest like treatment should be started before 6.5 HbA1c, madam?
And that is what I'm saying. So you start a patient, or if the patient has, in spite of her best lifestyle changes, if she continues to have A1C which is on the higher side, which is almost near 6.5, and you want a better glycemic control for her, she has other complications, other risk factors, that's when we start the patient on metformin, even in pre-diabetes.
Okay. Is a single dose, madam? 500
Yes, single dose,
milligrams?
usually a single dose of 500 mg.
Okay. Or do I need to refer her to the endocrinologist?
You can always refer to us.
Okay. Thank you, madam.
Thank you.
Just a comment to that question. Basically, pre-diabetes, we do consider it as a patient with diabetes. If you look at the pathophysiology,
Yes,
it's the
sir.
same,
So usually
very
that's what
same, and also the complications are also already started.
That's why we try to first the initiation is on lifestyle changes. If it is not working, we add on metformin.
Thank you very much, madam.
Thank you so much.
We'll move to the next presentation.
Next is Dr. Vijay Shekhar Reddy, HOD, Department of Endocrinology, Gandhi Hospital. And Sir has special interest in diabetes in short stature with growth, pituitary and thyroid disorders. Sir has immense publications, 37 on 44 presentations at various national and international conferences. Sir is involved in drug development programs and phase 3 clinical trials at national and global levels. and he's a scientific chairman for National Conference of the Endocrine Society of India 2023. Thank you, sir.
Thank you very much. Very good morning and namaskaram to all the respected chairpersons, the distinguished guests over here. It's nice that you people are conducting such sessions, conferences on a Guru Purnima, as Srinivas was wishing me. Guru Purnima. Yeah, it's good. We know that this is actually, for these, who are really striving for the transcendence. Actually, this Guru Purnima is a day which comes the first Purnami after the summer solstice. We make use of it for transcendence, those who are meditating. That's one. And the second thing is that today is the day where Adiyogi has turned to south and dispersed his knowledge to the Saptarishis. So it's good that you have conducted. And secondly, Raghav told me that you come at 9:30. I thought that, it's like, my daughter called me today morning. Nana, first dose Anike. The first dose, how it will be. When you have So after coming here, I was surprised to say at 8:30, so many people are there. It's good that you have started early and we can have that. Can I have, yeah. To introduce you a bit, as many of the diabetic patients are treated by the primary care physicians and not by the endocrinologist. So my lecture will be focused for the primary care physicians. And when you choose choosing the insulin regimen for initiation and intensification is not an easy job, and it's lot of there's a lot of debate even among the specialty clinics and also from the primary clinical settings. So when you initiate insulin, there are three important things which are required. One thing is the number of injections you are using when you are initiating, the complexity of the regimen, and flexibility of the regimen, which are three which are very important. And consideration for this is the available, you have the basal insulins, you have got the premixed insulins, you got a premixed analogs, you got premixed, I don't say premixed, premixed co-formulations, and then the bolus insulins, basal bolus insulins, basal bolus. So what it is important is you have to know about the pharmacology and pharmacodynamics of the insulins rather than all these things. Yeah, we'll go to next. Where is this is the one? Oh, it's already there, right. So here, this is, no. For the, okay. These are my disclosures, no potential conflicts of interest. So let's go to this case. Here is Ajit, 50-year-old male who is engineer, diabetic for past more than 11 years. He's also hypertensive for past 7 years, and also got dyslipidemia for more than 2 years. He also, he also gives a family history of diabetes. He takes alcohol more than 2 drinks per week. He smokes, he's non-smoker, and exercise very regularly. He gives history of hypoglycemia. And on examination, he's found to have his weight is about 77, the BMI of 27. And blood pressure is normal. His glycemic status is shown over here. A1C is 8.3, fasting is 188, postprandial is 218, relatively inadequately controlled. He's got LDL cholesterol is elevated, 124, eGFR is 55, and this is his, these are the findings from this patient. So he has got increased atherosclerotic CVD risk and also got a microalbuminuria. Okay. There's a problem. Yeah, fine. Presently, is on antihypertensive, statins, and cardiac drugs, along with the other OADs, metformin, empagliflozin, and liraglutide injectable drug. The primary challenges identified in this patient: uncontrolled hyperglycemia. Subject has hectic work life and fears insulin initiation will affect work life due to hypoglycemic risk. He frequently travels and unsure about taking insulin on a fixed time day. This is, yeah. No, back. Yeah. Okay. So what is the next step in this patient? You know, we know that most of the patients do not have a glycemic control despite being on multiple OADs. And we come across the use of multiple OADs, which is really driven by the convenience to the patients, acceptance by patients, and because of limited consultation times, most of the people will be using many OADs. Now people are going for, earlier we used to use 2 to 3 because of the availability at that point of time. Now people are using 4, 5. You know, the studies have shown that, you know, those patients on one OAD, adding a second OAD can reduce an A1C to an extent. And those patients on 2 OADs, adding another third drug can decrease the A1C to an extent. But after that, patient already on 3 OADs, adding the another OAD will not make any difference. And if you can see that, you know, the successive OADs provide lessening effect in these studies. And you can see that there is a substantial benefit from initiating insulin, those who are already on 2 or plus OADs. So what insulin would you consider in this patient? Okay. These are the ADA 2024 guidelines. As you all know, those patients who are not under control, their recommendation is to start with the GLP. And then not under control, then you go for adding a insulin, especially a basal insulins. But there is also most of our patients also, we most of the time, I think it's more than 90% of the time, GLP-1 injectables are not started after OAD failure. And we go with the insulins. So their recommendation is to add a basal insulin. Sorry, this was not projected. Okay. So why the basal insulin in this patient? Here I like to tell about one thing. You know, there's a long back, there was one study published in an EGM 2007 by Holman et al. That is a 4T study wherein he has compared injection basal insulins with the prandial insulins and also premixed insulins. In that study, what they found was, in fact, when the insulin was initiated, the premixed insulins and the prandial insulins had a better control than the patients who were started on the basal insulins. But the only problem was there was more of weight gain and more of hypoglycemias. In the same study, when they looked into when the HbA1c was less than 8.5, even the basal insulins were comparable with the prandial insulins and the premixed insulins. So the message is that if the A1C is near to the normal, less than 8.5 or 9, it's better to go with the basal insulin. If it's more than that, it's better to go with the premixed insulins, analogs, or co-formulations. That's one thing. In the same paper, they went on to discuss, where all the premixed where all basal insulins cannot be given and where the premixed insulins can be given. So when you think the adherence to with the patient is poor, that means when you start a basal insulin, you have to start next, after a few years, at least months or years, the another bolus, 1 plus, 2 plus, and 3 plus. So if you think the patient cannot adhere to the so many injections, there's an option that you can start with the premixed insulins. This is one. And the third option is when the fasting is near normal, that is say about 150, 160, A1C is around 8, and the postprandial is around 300. It's better to go in these patients with the premixed insulins or analogs. So, okay. So this is one aid for making insulin, what insulin to be given. This article by Carla et al. In the journal Diabetic Metabolism Disorders. He has written in that how the insulin can be initiated, whether the basal insulin or the premixed insulins. He has taken the cutoff point. If the postprandial glucose excursions are less than 40, the first choice will be to add a basal insulin. If it's more than that, you can go with the premixed insulins or the co-formulations. So next thing, which basal insulins? We got a lot of basal insulins, first or second generation. Now, first generation, we know what are the problems with that, and let me just tell you about what are the unmet needs of the first generation analogs. They are not truly once daily injections because their duration lasts for only 22 to 24 hours. And there was a higher variability in that with the older, the first generation basal insulins. And fixed time dosing, since the duration of action is only 22 to 24 hours, we have to give on a fixed time the next day. Now, suppose if you give injection today at 9 o'clock, tomorrow also we have to give it by 8 to 9, which means we cannot delay it. This is very useful, especially in the type 1 diabetes. Sometimes, patients goes out, they come late and all, they're prone for hyperglycemia during that time. They're not truly peakless. They have peak at around 12 to 14 hours, and they had very high nocturnal hypoglycemias. So how to initiate just insulin degludec? Yeah. Simple initiation of degludec is either, recommended daily starting dose is dose of 10 units per day and requires subsequent individual dosing adjustment after initiation. And those who are on, the already on a OD or BD basal insulin therapy or a basal component of the prior basal bolus regimen or a premixed insulins, you can switch to unit switch. And if the patient is on glargine U300, you can reduce the dose of the basal insulin when you switch to degludec by about 20%. So just let me talk to you about what are the differences in short between degludec and what does the evidence say very quickly. Yeah. This is the data from the CONFIRM study. CONFIRM is this data was collected from the real world effectiveness comparing the glargine and the injection degludec. What they have found was insulin degludec has shown a significantly lower risk of hypoglycemia versus glargine U300 in evidence from the real world practice. Yeah. If you look into the pharmacokinetics of the drug, this has got you can see that onset of action also is little faster when you compare to the glargine U300, and its duration of action is also prolonged more than about 42 hours when compared to the glargine U300. Yeah. So because of this increased duration of action, 42 hours, there can be, you know, it's there will be better flexibility with the use of this injection degludec. Say I told you, if somebody has taken yesterday injection at 9 o'clock, he is supposed to take today at 9 o'clock or 9 p.m. Suppose he has gone somewhere else, he can still as well take next day morning also. That amount of flexibility is glargine U100, we have to take it a fixed time, whereas with the glargine U300, we got that flexibility for 2 to 3 hours, plus or minus. Still, we can take 3 hours later. But with the injection degludec, you can take as well the next day morning also, till the afternoon. See, this is the now, if this is the data showing the area under curve glucose infusion rates when injection degludec and glargine was given. What you can see is that the glucose lowering effect is more stable in those individuals where injection degludec was given when compared to glargine U300. So that means there is lower day-to-day variability with injection degludec when compared to glargine U300. Similarly, from the same set of studies, it was shown that, you know, it's not only inter-day variability, even day-to-day variability is also very less with injection degludec when compared to the glargine. From the similar data, it was also shown that the glargine U300 has a 30% lower potency when compared to the degludec. So in conclusion, it has got a very flat peakless activity profile, minimizing the risk of hypoglycemic events, long duration of action more than 24 hours, and a minimal variability with injection degludec. Let me go to the case 2. Here is Amit, 53-year-old businessman, who is diabetic for more than 7 years and has also got hypertensive hyperlipidemia with a family history of diabetes, no alcohol intake, non-smoker, but exercise irregularly, with a previous history of hypoglycemias. Comes to you, on examination you find his BMI is 25 and blood pressure is normal. A1C is 9.2, fasting is 206 and postprandial is 288 with LDL cholesterol mildly elevated and eGFR 60 with the microalbuminuria. I think that was not showing there. So he has also got the increased atherosclerotic CVD risk and the microalbuminuria. So this man is on antihypertensive therapy, statins, cardiac drugs, is on metformin, sulfonylureas and dapagliflozin. The challenges identified in him were, you know, he believes taking insulin will be difficult because of his hectic daily routine. He's got fear of hypoglycemia, uncontrolled hyperglycemia, has an erratic dietary patterns, travels often, so unsure of taking insulin and fixed time. These are his problems. So what to do with him? Earlier case, in that, when the A1C was around 8.4 and the fasting was around 188 and 2 hour postprandial, based on the previous studies and the diabetic, the aid, you know, we have started him on basal insulin. What to do with this individual? The same thing which I told you, don't want to repeat the slide. So once he's already on 3 drugs, you have to start an insulin. So what insulin would you consider in this patient? Okay, same thing, taking the help of the aid, his excursions, postprandial glycemic excursions are more than 40. So as a first choice, you can either give a premixed insulins or analogs or co-formulations can be started him. If it's extremes, you can also go with the rapid-acting insulins. So this is what both the FPG and PPG contributes to the HbA1c, and PPG has very stronger correlation with HbA1c than the FPG, especially when the A1c is near normal, as shown by the Monier's hypothesis. So which premixed insulin? Analog premixed versus the human insulins. The studies have shown that when you compare both analogs as a conventional human mixed, it showed the premix has shown the faster absorption, higher peak concentration, more rapid and pronounced glucose lowering effect, so significantly lower rate of major hypoglycemia compared to the human insulins. I think I'll go skip many slides. The Bell has already ranked. This was a paper from Evans who has shown that because of the better glucose control, reduced burden of hypoglycemia, the premixed analogs were better than the premixed insulins. Yeah. So now coming to whether to go with IDEC as per insulin glargine, what does the evidence say? We have, if you look at the efficacy, safety, quality of life, and flexibility attributes of IDEC ASP, you can see that, I'll just go fast. Oh, very slow to move. Computer slow hai. So, yeah, as Sin was telling that, So, this is the data provided in the 2019 IDF, where we can see that, when you compare all the basal insulins, FPG, PPG, and A1C was better controlled with the IDEC ASP rather than the other basal insulins. I'll skip some of the slides over here. It's not moving. I'll just skip the slides over here. Just talk on the slides. Yeah. This was actually the data from the meta-analysis by Moon et al., who has shown that, though the efficacy was almost similar, or not significantly better than the other insulin, but when it comes to the safety aspects, in reducing risk of nocturnal hypoglycemia was better with the IDEC ASP, even with the co-formulation when compared to the basal insulin. Yeah. I'll skip this. If you look at the quality parameters, switching to IDEC ASP was associated with the improvement in the quality of life. The same thing, if you look at the other parameters of quality of life, patients with diabetes willing to continue treatment with diabetes was 78%, and people with diabetes prefer IDEC ASP for previous therapy with glargine was more than the glargine U100 and U300. So if you look at the flexibility in dosing, as I already told you, don't want to again stress, the glargine you have to take fixed time. With U300, you got the time period of 3 hours plus or minus can be taken, but with IDEC ASP, you got a administer with any major meals of the day can be. You can start today in the afternoon, tomorrow, late dinner also you can start. That is the flexibility with the IDEX ASP. So how to initiate IDEX ASP? I'll go a little faster. You initiate with 10 units IDEX ASP VD with the most carbohydrate heavy meal of the day, and then if you want to start, administering IDEX ASP VD with 2 most carbohydrate heavy meals of the day, meal size and postprandial glycemic response should dictate the ratio of 2 doses. So what is most important is main meal concept. We start, usually the dinners are more, so we always start with the dinner when once a dosage is given. But if you have the post-meal intake is more with the lunch, you can as well start with the lunch and dinner. But usually what happens in the practice is we end up with giving with breakfast and with dinner. We'll miss the lunch. Though he takes more of the carbohydrate with the lunch. Yeah. So when and how to intensify IDEX ASP OD to BD? Yeah. See, when to intensify if the postprandial glucose excursions are more and which is not responsive to the diet, or if the dose is more than 30 to 40 units, you can intensify and make it twice a day. A total daily dose split over 2 meals with the greatest carbohydrate content, ratios based on a relative carbohydrate content, and PPG excursions. So use of IDEX ASP in the special situations. This is the approved, CDSCO approved package insert version is kept here. You can use this IDEX ASP in elderly individuals, type 2 diabetes, elderly individual renal impairment, type 2 with hepatic impairment, type 2 individuals during religious fast. Though it is encouraged to be given type 1 diabetes, we usually don't encourage. So in summary, IDEX ASP is an ideal choice at insulin initiation backed by the evidence and guidance recommendations. And IDEX ASP, both the efficacy and safety is backed with robust evidence, as I told you. There is a positive impact on the quality of life, and most important is there is a flexibility in dose administrations. Unlike the type 1 diabetes, type 2 diabetes is very different. Most of the people are reluctant to start the insulins. So thank you. Any questions I'll be taking? Or
any questions? We'll keep the questions at the end.
Thank
you very much for this excellent presentation, and we'll move on to the next.
Yes, very good morning. I introduce KVS Harikumar. Yes, sir. He's a consultant endocrinologist, Magna Centers and Fernandez Hospital, Hyderabad. He got list of awards like Shakuntala Amir Chand and MN Sen Variation Awards from ICMR New Delhi, Dr. J.S. Bajaj Variation Award from National Academy of Medical Sciences, New Delhi, Dr. A.R. Seth Gold Medal from Endocrine Society of India, Thyroid Rising Star Variation from Indian Thyroid Society, Young Investigator Award from RSSDI and API and UPDA. He's a Best Referee and Best Article Awards from Indian Journal of Endocrinology and Metabolism. He peer-reviewed 225 publications, PubMed Index Journals. I welcome Dr. KVS Harikumar, sir. Yes, sir.
Thank you, sir. Good morning, everybody, and thanks to IdeaCon for the invite. You have heard a lot about injectables since morning, so we will move from the injectable spectrum to an oral spectrum, treating the trinity, pioneering optimal outcomes with the oral semaglutide. This is my financial disclosure, and the topic will be covered under the following headings. First is a couple of slides about what trinity we are talking about, some evidence, and what does Pioneer look at, and some future studies concerning the molecule. So if you look at decoding the trinity, 2 sets of molecules have actually put these 3 things together. There is CKD also is missing there, but definitely if you look at the GLP-1 RS and SGLT2 inhibitors have brought the diabetes, obesity, CKD and CVD all together, because with one drug you can actually achieve lot of benefits in all these spectrums put together. Initially we were working in compartments of each other, but now there is lot of overlap. You need to know why it is beneficial in another segment, all those things. And it is important to understand the pathophysiology, because most of these things coexist. I am sure you would see 50% of your patients who walk in with diabetes will have obesity, they will have dyslipidemia, some 30% will have CKD, 80% will have CAD. So there is a whole host of data, whole host of patient groups falling together in this spectrum of people. And if you look at the pathophysiological links, by and large, it is the inflammatory stress, oxidative stress, and which culminates driven by both obesity, driven by diabetes, leading into the CVD. Diabetes so-and-so is equivalent, considered as a cardiac disease equivalent of past MI or CAD. So how do you address this trinity together is what most important. You obviously look at lifestyle changes, you obviously look at glycemic, lipid, blood pressure management, weight management, and what do the guidelines say. So all whole host of management options which you should consider in addressing this combination together. So we will look at the evidence, looking at established guidelines, how they have proposed to manage this. I am sure nobody can read this, but nevertheless, this you have seen plenty of times. The issue is, you look at what is the atherosclerotic cardiovascular disease. You look at the presence of CKD. You look at any history to suggest that you need to prevent the progression of this disease in a given individual. So that is how you would choose your drugs based on the proven efficacy of a particular molecule in establishing reduction over other existing molecules. So that is why SGLT2 inhibitors and GLP-1 RAs have been proven to be beneficial in across the board spectrum. And in all of them also, there is some difference as to what particular molecule which has been shown to be much benefit. Multifactorial approach, the fourth pillar, all of us are familiar about ABC goals of diabetes, but the fourth pillar of about agents with cardiovascular and kidney benefit has started only in the last couple of years, not decades. ABC was there last couple of decades, but now you have, in addition to your A1C, blood pressure and cholesterol control, you need to control using drugs which are going to reduce your cardiovascular events, which are going to reduce the progression of your chronic kidney disease. So those are the class 1 recommendations, that you should use these drugs in an optimum setting for the given patient. That is important. Heard something about GLP-1 RS from morning, and it is like, this is one particular agent which is going to target almost 5 to 6 core defects of diabetes. So you have improvement in the glucagon secretion, you have reduction in the glucagon, you have increase in the insulin, you have peripheral uptake, and you have a central mechanism of action, you have delayed GI absorption. So a lot of benefits which will translate because of this GLP-1 RS, which target multiple pathophysiological defects of diabetes. So it translates into reduction in A1C, reduction in body weight, reduction in blood pressure, reduction in inflammatory markers, and cardiovascular benefits. So you have a plenty of things what you are looking for with different molecules are given by a single molecule. That is what these drugs look at and give you that option. And if you look at the spectrum of GLP-1 RS, it is by and large divided into a exendim based or a human GLP-1 based. Most of the available GLP-1 RAs are actually injectable. You have only one oral GLP-1 RA available, that is the oral semaglutide. You will see why it can be. This is the first peptide which has gone across the gut barrier and still has good effects. So it gives a lot of motivation that you may actually get a insulin also sometime in the future, because this has showed the way that you can actually push through your peptide from the gastric barrier. The Pioneer is the one which is the acronym which stands for different spectrum of studies which looked at the oral semaglutide. And the oral semaglutide, it is co-formulated with what is known as the SNAC. That SNAC is the one which keeps it stable and prevents the hydrolysis in the gut enzymes. And this 1% of semaglutide in the drug tablet is absorbed across the gastric epithelium, and the SNAC facilitates this. So people, whoever wants to break the tablet, please don't break the tablet. You are not going to gain any advantage by doing it. It has to be taken in toto. Okay. So this is a Pioneer program which looked at different subset of diabetes patients, active comparator, placebo, cardiovascular event, all those things. So different spectrum of patients, and Pioneer 2 is with SGLT2 inhibitors, 3 is with DPP4 inhibitors, 4 with GLP-1 RS, and 6 is looking at the cardiovascular safety. So if you look at across the data of Pioneer, the A1C reduction across, be it a placebo comparator or active comparator, you have a significant improvement in A1C up to a tune of 1.5%. And if you look at the weight loss, because you are going to get a A1C reduction in addition to weight loss, so which is going to give you a further cumulative benefit to the patient, which is to the tune of another 5 kg. So you are going to get reduced A1C, reduced weight, which will translate it into a compounding benefit to the patient, which translated possibly into some of the CV data and other benefits. The Pioneer 6, which looked at the CV safety or CV superiority of this. CV superiority was not described with the oral semaglutide, but it shows that it is at par with the placebo. There is no increase in the events, and they are both comparable. The Pioneer Real India, where some in the across the Pioneer segments, where the real world evidence in the Indian subset, if you look at it, A1C 8.9% when they have started with the drug, and 90% of the patients achieved better control, and 1 in 5 patients were started in first year of their diagnosis of diabetes, and 1 in 2 patients had a cardiovascular related history. So you are, as per guidelines, as per the ideal conditions which the drug has to be selected, it is being met. So you would give the maximum benefit to the clinical spectrum. So oral semaglutide addresses risk factors beyond the A1C and weight. As I've said, because of their mechanism of action, you will reduce inflammation, reduce waist circumference, reduced in the lipid profile. Some of these things will translate into cumulative benefits which are accrued to the patient. So reduction in waist circumference of about 4.7 centimeters by virtue of their mechanism of action, reduce in the calorie intake, 35% reduction in the energy intake, and about 3 to 5 millimeters mercury of reduction in the systolic blood pressure, some improvement in the blood lipids, and reduction in the vascular inflammation. All those things are the extra benefits which you would get with these drugs. So after seeing that the background, trial data and mechanistic benefits and usage, what happened in the India and across other outside world, the future course ahead for oral semaglutide, some of it I will tell you in a couple of slides. When you compare the GLP-1 RA and SGLT2 inhibitors, both work complementary to each other as far as reducing your cardiovascular events, reducing your chronic kidney events, in addition to their glucose reduction, in addition to weight reduction. So you have mechanistic benefits which are driven by both these molecules together. So it makes sense that most of the recommendations do look at combining these two whenever you are aiming to treat diabetes, especially with a view of reducing your micro and macrovascular complications. So they address the residual risk, beta myocardial salvage, reduction in the risk of EGFR worsening, lower risk of end-stage renal disease, and more cardiovascular free life. Some of the ongoing trials with the semaglutide, the SOUL is the one which is looking at only the cardiovascular event with the oral semaglutide, and Ascent is again primary prevention. These are the two oral ones. The FLOW has been published very recently. The other trials, the FLOW, STEP-HF and STRIDE were looking with the use of the injectable sema. The SELECT was the one which was published few months back, which looked at only cardiovascular outcomes in obesity. Okay? And the FLOW was published just last week. It is injectable semaglutide in reducing your chronic kidney disease production. Both of them have shown significant superiority over the placebo, but both of them were concerning the injectable sema than when compared with the oral semas. Okay? So to conclude, GLP-1 RA based therapy improves the trinity of cardio-renal metabolic syndrome. Oral GLP-1 is a novel breakthrough because till now we never got a peptide going across the gastric acid barrier. So it's a breakthrough as far as management of type 2 DM is concerned. Benefits extend to patients even without diabetes, a simple obesity. They are as of now approved drugs, and now you have got evidence to say that they will reduce the cardiovascular events even in the obese patients. Superior benefits if you combine with the SGLT2 inhibitors because they both have complementary mechanisms of action, and good option of oral semaglutide in patients with diabetes, obesity, CKD and cardiovascular disease. I have finished here. Any questions or comments I shall be happy to take.
Excellent presentation, very clear, sir. Any questions from the audience?
Many diabetic patients are obese, so this is the ideal molecule for many patients, but the side effects, GI side effects are predominant for many patients. So that's the reason many patients are discontinuing after 3 months or 6 months. So
Yeah,
is there any
the GI side effects, that is why conventionally the dose up titration is there to prevent the GI side effects. But 10 to 15% of patients, because of other reasons, are intolerant to GLP-1 based molecules. So in them you cannot actually look at. But if you want to circumvent gradual up titration, giving them about, pre-warning them about your nausea and gastric discomfort, all those things, use of prokinetics for some time, and possibly delayed up titration also will work in some of the patients. So if you are looking at, as I said, the molecule has a lot of benefits. So if you want to pass on the maximum benefit, you need to look at how best this can be used. If somebody cannot tolerate it, obviously there is no point daily vomiting and then continuing this. That is not the case. But you should give the maximum possible try with all these other measures where the patient can tolerate. But as I said, 10 to 15% may not tolerate. But conventional, most of the trial data have shown that nausea and vomiting are described in about 30 to 40%, which is not in the clinical practice. So it is definitely difference what we look at.
Considering the so much of benefit, when would you consider starting it, sir? When the how early would you consider starting it?
How early is a big question. It is like if the patient can afford it, it should be started right from the day go, the moment you're diagnosed with diabetes. Because don't look at only the, say, obese or anything. It is a plain and simple type 2 DM. The best you control for a longer duration, all your vascular complications will go down. So that is what is our aim. But there is obviously most of the patients whom we see are the pocket paying. So there it's going to be an issue. So in that perspective, maybe you should have some pre-selected criteria that I will give maximum benefit to some. So that is how we say. But given an option, it's like a standard indication for a type 2 DM for anybody.
Yeah.
As soon as possible, because that's what the Pioneer India data also shows, that within 1 year of diagnosis, most of them have been started.
Yeah, considering metabolic memory, I usually think about
Absolutely.
starting it.
That's why I said the early you start, the better you will get the benefits in a long run.
Thank you. Any questions? Okay. Thank you very much, sir. We'll move on to the next session.
Another
one second. Yeah. Please go ahead. Please use the mic.
Absolutely no. Even Metformin is not per se indicated in pregnancy. Okay. Okay. For pre-diabetes, technically there is no approval, first point. Okay, even metformin is not approved. Whatever we are using is a off-label indication. Okay, so there are some subset of patients in the pre-diabetes whom you can consider these drugs. Say if somebody is progressing from 5.8 to 6.2, somebody who has got obese pre-diabetic, somebody who has got a cardiovascular disease with pre-diabetes, history of cardiovascular disease. So these are the subset of patients whom you would want to translate or give that drug so that he remains either pre-diabetes or comes to a normoglycemic range. But technically no drug is approved for pre-diabetes.
So what is the cutoff level for HbA1c, like when we have to start the medication? Like is
See,
it
the
6 or
definition of
6.5?
pre-diabetes starts from 5.7 to 6.4. Okay, so anybody 5.6 and below is considered as normal, 6.5 and above is considered as diabetes. So as I said, say today you have seen a patient, he is at 5.7. You have explained lifestyle modification, you call him after 3 months, he has come with 6.2 A1C. Maybe he has followed lifestyle, he has not followed, whatever, leave it aside. If you feel that he has done enough focus there, and if he is still progressing, he is obese, you can safely consider, but as I said, these are going to be off-label indications. Okay.
And like if the patient is progressing in 1 year time, like HbA1c 5.7, after 1 year she is 6.2, and no risk factors except like she is having a gestational diabetes, that is also controlled. She didn't take any medications in gestational diabetes, but her HbA1c is progressing in 1 year time, and she is not obese, no risk factors, except her father is a diabetic, that is also type 2 diabetes after 50 years age. So do I need to consider any treatment in this patient, sir? If her fasting sugar levels are occasionally high, depends on her dinner.
See, by and large, the disease process of diabetes starts a decade before the diagnosis date. Say today you're diagnosed with diabetes, the disease process of insulin resistance is a decade old. So what you are describing is in that decade old. So if a lady has got family history, progressively worsening in the pre-diabetes spectrum, even a non-obese, I would still consider giving, in addition to lifestyle, some drugs. Definitely, that will help.
So what do you suggest, sir? Is it metformin?
Depends on, as I said, if it is non-obese, I would consider metformin. Okay, you can do SGLT2 inhibitor, you can use GLP-1RA, all these three, depending on the comfort, depending on the benefit, depending on the affordability. All these three are possible.
Thank you, sir.
A lot of trials are going on in heart failure with this molecule, like the STEP heart failure trials. But even though the trial population is only around 600, but still with weight reduction, with heart failure, with preserved ejection fraction, there is a lot of improvement in quality of life, not
correct.
It comes as a...
Yeah, that's why actually till date, there were not many drugs which are recommended for heart failure with preserved ejection fraction. With reduced, there are plenty of drugs.
Only empagliflozin is approved.
So SGLT is the only thing which has made that breakthrough, and very soon the semaglutide also will get that breakthrough.
SGLT2 is becoming more a cardiac drug than a...
As I said, it is the boundaries are not there. It is everybody's drug. So,
starting stages.
If you are looking at neuropathy, 30% of patients at the time of diagnosis will have peripheral neuropathy, that is type 2 DM. Now, burning feet, commonly you should look at alcohol intake, smoking, vitamin B12 level, vitamin D, and if all these things are addressed, explained, and if still patient has got still burning feet, possibly you can use topical gabapentin, if not a systemic gabapentin.
If B12 deficiency is there, by giving B12, will there be any cure or regression? Or?
It is like if you have known condition which aggravates a neuropathy, you need to do that checklist and keep eliminating one by one. It is not that B12 elimination will eliminate the neuropathic pain, but if that is a common cause, you need to correct that before you search for some other cause underlying. So traditional teaching is first you should see what is in front, eliminate all those risk factors, then go for and search for some other risk factors depending on the persisting of the pain. Any time of the day.
Thank you very much.
Thank you,
Excellent,
sir.
excellent talk and very informative. With this,
can I just ask a question? Okay. Sorry. So they say that there's an increased risk of thyroid cancer with semaglutide in long-term use, maybe 1 to 3 years is what they're saying. Like, how far is that true? And how long is semaglutide advised? Because it's very new clinically.
The issue regarding medullary thyroid carcinoma started with a GLP-1 RS right from the original exenatide molecules itself. That was described more in the rat studies, have not been translated it into human studies. Initial recommendations were to screen with calcitonin in somebody who is looking at, but subsequent there is so much of data which has come with the GLP-1 RS, enough thousands of patients, I would say lakhs of patients, so no more that recommendation holds good. It has not been translated into humans. Some key differences being the rat thyroid has got a higher GLP-1 receptor expression in the thyroid. So that was possibly translated into a more cancers in them, but not translated into humans. So that MTC, which is GLP-1 RA based, is already dead. It is no more a cause of concern in the clinical practice.
Is there a point at which we need to stop semaglutide in humans? Like,
Intolerance.
other than that, there's no other end. Like, no
It's
other
a standard type 2 DM drug.
Can be continued currently. Thank you.
thank you very much, sir. If any further questions, please talk to him out of the dais.
Thank you, sir.
Thank you.
We conclude the session. Thank you so much, all the chairs and speakers, for the wonderful presentation. Now, a tribute to late Sri Dr. Sudhakar Rao, former president of Idea Clinics. I would like to invite Professor Rakesh Sahe for obituary onto the dais. I also request Professor Vijay Sekhar Reddy, Dr. Harikumar, All India ESI Secretary, onto the dais. Dr. Srinivas Rao, Dr. Shyam Kalavalapalli, Dr. Durga Bhavani, onto the dais. Dr. P.V. Rao, sir. Dr. Professor P.V. Rao, sir, onto the dais.
Hello. Hello. Sir, Dr. Sudhakar Rao, sir, is a true, very personality, very difficult to describe him. We are missing first time Idea Clinic Nation Conference, sir. We know people who are attached to, sir, how much we are missing, only God will know. Only I have a God given opportunity for me in December 2024. Sorry, December 2023, there is a nation conference in Hyderabad, ISICAN. God has given him some idea to facilitate a guru's program called Gurudeva Bhava. In that Gurudeva program, sir was the one of the guru who facilitated him. So I can understand his life is that he always thinks that the other person is greater than him. any other person who may be a driver or maybe a uneducated, always he thinks that he is a superior than sir. But sir doesn't know that he is a superior to all the human beings. That is a true, that's what my heartfelt feelings.
Dr. Sudhakar Rao was the second DM endocrinology in Hyderabad. I know him from 1980s. So he did his DM endocrinology from Chandigarh. And then we were very close with RSSDA. So RSSDA is he is the major, one of the pillars of RSSDA. Most of you know about RSSDA. Now he is the president. Dr. Rakesh is the president. So 1972 it was started. From 1983 we were running the organization. I was running the organization, and Dr. Sudhakar Rao was my backbone. So he has supported me through many problems, and he was the treasurer for about 25 years for RSSDA, and I was the secretary. And he has helped me a lot in going through all the troubles. So other colleagues will talk about his endocrinology issues, but I am talking about his other non-endocrinology issues. But he was a great support to me, and in many difficulties in meetings, in executive meetings, general body meetings, there were always comments against me in meetings, and he was very boldly and strongly supporting me for about 25, 30 years in RSSDA. And it's a great loss to me. He was my sort of elder brother all these years. And I was looking after all his family members and his friends. So while he was in politics for 2 terms as MLA, he was referring all his friends, relatives, and classmates from Mulugu, Warangal, and his native place. So like that, I was very close to him, and it's a great loss for me to know that he is no more. Thank you for giving me this opportunity to give the tributes to a great man.
Dr. Sudhakar Rao was, as Dr. P.V. just mentioned, he was the professor of endocrinology at Gandhi Medical College in Secunderabad for almost a decade. He established the department of endocrinology there. He was the second endocrinologist from the state of Telangana, or maybe the erstwhile state of AP. And he was, in 2000 he resigned from the Gandhi Medical College and then got into active politics. He was served as a member of the Legislative Assembly for 2 tenures and was again back into the practice of endocrinology after that, and has been associated with Idea Clinics. He was very active, as Dr. P.V. said. He was active with the RSSDI and the Endocrine Society of India. He was also went on to become the president of RSSDI also, and I think in 2006 or 7. And then he was also conducted the National Conference of Endocrine Society in 1999, and then he was also the president of the Telangana chapter of Endocrine Society of India for a long period, and till his demise in June this year, June this year. He was the president of the Telangana Endocrine Society, and he was also, he held many positions like the chairman of the Arogyashri Trust also in the Telangana government in the previous tenure, till December 2023 he was holding that tenure. So he has been very active. He has, but more important was that he was a very humble person who did not, who treated everybody very nicely and was always smiling. Took up any problems in a very affable and smiling way. So that's why he was liked by everyone, and one and all, whether you look at his students or whether you look at his colleagues or others, everybody liked him and went along. He got along with everybody very nicely. So it's a great loss for all of us that Dr. Sudhakar Rao is no more. And even in his final illness, he did not let anybody know that he was going through illness, and we only came to know after his demise that he was going through a serious illness, and when we heard about it, he had expired by that time. So it is indeed, we pay tribute to such a person who was very humble, always dedicated to his work, and was active in all fronts in the society. So we pay our respects to him.
Dr. Sudhakar Rao was the person who has initiated Department of Endocrinology at Gandhi Medical College in 1989. And till 2000 he was there. He took a voluntary retirement and went, for the personal reasons, he left it and joined the politics. And it's now 2014. In 1999 only there was one more Endocrine Society of India conference, and he has conducted that in 1999. And then again in the recently 2024, 23 December, and I was associated with him there. And he is one person who has also taken interest to continue the academics of the Endocrine Society of Hyderabad and Telangana, where we used to have monthly meetings in the evening, where I used to see him regularly. One thing is that he's down to earth man. That's how I know him. And to my department at Gandhi, he's, in mid-90s, that Hyderabad has got radioimmunoassays in his department. That was the greatest thing. Those days we used to do all the hormones at Gandhi Hospital. We're somewhere in the mid-90s with the older RIA technologies. So, a lot of things to be learned from him. And he's a really great personality, and we miss him. Thank you.
Professor Sudhakar Rao sir, as what I know is punctual. Whenever endocrine clinics, he is maybe the first one or the next one after the resident who comes. And we always used to admire sir for his inquisitiveness and possibly the keenness to learn despite all his other works which used to take a lot of time, but still he would never miss the events, especially conducted by Endocrine Society of Telangana. So in that sense, actually we lost a actively working president for us, and he is the one who put Hyderabad on the national map twice, and SECON 2023 under sir's guidance still remains the benchmark where most of the across pan-India faculty appreciated that this is best ever conference organized. And we used to trouble him plenty of times at odd hours for a lot of things, but he never ever uttered anything even impolite way also. He would always be supportive, he would always be hand-holding for all of us in conducting that, and that shows the result what has happened. And I'm sure the legacy of sir will continue in the form of idea clinics, and we would remember him forever in our lives. Thank you.
No, thank you. I think Professor Dr. Sudhakar Rao garu has been like a father figure for idea clinics, and we dearly miss him, and I would like to request a few moments of silence in his remembrance.
thank you. I think we'll move on. Thank you very much.
Thanking all the doctors for sharing your experience with late Sri Dr. Sudhakar Rao sir. Next, we are going to start interesting trilogue sessions. First trilogue session is on clinical pearls in thyroid and parathyroid by Dr. Siddharth Chakravarti. I welcome Dr. Siddharth Chakravarti sir, endocrine and breast surgeon. He did his general surgery MCH in endocrine surgery. He has 8 years of experience as an endocrine and breast surgeon. He was affiliated with Idea Clinics and Apollo Hospitals, Jubilee Hills. He was a consultant in the Department of Endocrine and Breast Surgery at Christian Medical College, Vellore from 2015 to 2018. And he was awarded first prize for poster presentation. Is it necessary to perform a routine preoperative laryngoscopic examination before thyroidectomy? 11 postgraduate endocrine surgery course in 2013 at Lucknow.
Thank you. Now I request the panel members, Dr. Rabindranath Mehrotra sir, Dr. Meenakshi Swain and Dr. Vrinda Agarwal to please come onto the dais. Dr. Rabindranath is sir is a senior endocrinologist from Apollo Hospital, Jubilees. He has published several papers on diabetes, growth and osteoporosis. I also call up Dr. Meenakshi Swain. Madam is a senior consultant pathologist in Apollo Hospital, and she's a lifetime member of Indian Association of Pathology and Microbiology. Now I request Dr. Vrinda Agarwal. She's an endocrinologist from Care Hospital, Hyderabad, and she's board certified. So today we will be discussing some important topics on thyroid and parathyroid. Next slide, please. Can you switch the next slide? Yeah. So first is the update on the new WHO classification of thyroid tumors from 2017-2022. There have been a lot of discussion and new additions and renaming of the tumors. So I request Dr. Meenakshi Swain to give a small overview of the WHO classification. Ma'am, please.
Good morning. Thank you, Dr. Siddharth, for having made me a part of this wonderful academic event. I'll quickly, in the next few slides, give you a brief overview of changes between 2017 and the 2022 classification. Can I have the first slide, please? Does this work? Yeah. Can we go to the next one? Yeah. So traditionally, thyroid tumors have been named depending on the pattern, and I think most of you would be familiar with these terms. Follicular, when you have these ring-like, oh, I don't think this is working, but the ring-like structures are basically follicular cells arranged in this kind of follicular pattern, give the name to all the follicular patterned lesions, whereas this is to contrast with the papillary pattern which you have on the right side. Papilla essentially meaning finger-like processes, as you can see, finger-like processes, and any tumor or lesion which has papillary processes are the papillary pattern lesions. But this changed with molecular pathology coming to the fore. Like in most tumors, with molecular pathology, we know that these tumors have distinct molecular signatures, and they're not necessarily just papillary or follicular by architecture. So on the left side, we have the follicular pattern, the typical prototypic multinodular goiter, you have the follicles containing colloid, and that extrapolated to cytology, when you pull them out with a needle, you get these little follicles, microfollicles or macrofollicles. Same thing with the papillary, there's a finger-like process there, and that is just a frozen section. This is a permanent section to show you the finger-like processes, like the schematic picture on top, and that extrapolated to cytology gives you again finger-like processes when we aspirate them. So this was the traditional or conventional definition of thyroid lesions. Now we have moved on with molecular pathology playing a big role, all of us learning a lot more about the molecular genesis behind these lesions, because they also fall into groups which either behave well because they have a particular molecular signature or behave badly. And that from there comes up the, I don't know, this pointer is working. You can see in the box, the malignant neoplasms have now been categorized basically depending on the molecular abnormality, which have BRAF-like mutations into the papillary carcinomas, and those which have RAS-like mutations into follicular carcinomas. Now, in this is also included the invasive encapsulated follicular variant of papillary thyroid carcinoma, because it behaves like a follicular carcinoma, and I'll come to that in a while. So coming to some new terminology, you have to be familiar with this jargon because you will have your pathologist reporting. So we have the introduction of thyroid follicular nodular disease, different as we call it. In short, essentially to include all those lesions that you find multinodular goiter-like appearances clinically, because that is not a pathologic term, but that includes the entire spectrum of mostly benign lesions from hyperplasia, multinodular goiter, thyroiditis, to even some follicular adenoma, so hyperplastic to neoplastic, which have multiple nodules. Now, the next change is that we have now categorically known that the commonest thyroid tumors are derived from the follicular cell. So we've concentrated in this classification on the follicular cell-derived neoplasms, where you have benign, low-grade, and malignant, and this is different from the earlier classification. This helps you actually follow up the low-grade a little more stringently, because you know that though they are low-grade, they have a propensity to late metastasis. So that is the whole idea behind dividing it into these three categories. Then we have another big change is in the high-grade group. There's a third point that I've enumerated. The follicular-derived carcinomas, high-grade, can be of two types. We have only known them traditionally to be poorly differentiated, which was the traditional poorly differentiated carcinoma. But we have now also a differentiated high-grade thyroid carcinoma, which are slightly different, and I have elaborated that in the next slide. The most important change is also with grading of medullary. There are criteria now for grading based on necrosis, mitosis, and Ki-67. So an IHC is required to make the grading easier and more reproducible. There's a new entity, thyroblastoma, which is seen in dicer mutation-associated lesions, predominantly in children. This was not there earlier, and now with more and more molecular coming up with the dicer mutations, we know a lot of blastomas, like even pituitary blastoma, which is dicer mutant-related, so also thyroblastoma in the thyroid. Then we have the last very important group. Squamous cell carcinoma of the thyroid was an entity by itself until 2017. But now, again, because we've studied them extensively molecularly, we know that most of these which have squamous differentiation essentially behave like anaplastic carcinomas. And there are big series to support that. And therefore, there's a reclassification now. The thought is that all squamous, or anything that looks squamous in the thyroid, actually behaves like anaplastic. So it's equal to anaplastic. And that's a very important point that you need to remember. This is just from the paper to show you that we have these three categories, like I mentioned, benign, low risk, and malignant. The low risk is a new addition, which includes those entities like non-invasive NIFTP in short, thyroid tumors of uncertain malignant potential, and hyalinizing trabecular tumor. Very important because long-term follow-up is required. They are benign per se, but they have a propensity to late metastasis, so you have to keep them on follow-up. Malignant, of course, hasn't changed too much, but I highlighted the group that I just mentioned. The high-grade can be either differentiated high-grade or the traditional poorly differentiated thyroid carcinoma. Now, we have some criteria pathologically to differentiate between what was the traditional poorly differentiated thyroid carcinoma from differentiated high-grade, mitosis and necrosis, which may not interest you, but that is really important for us pathologists to give you that diagnosis. And just to remember that this group of high-grade follicular, which includes the poorly differentiated and differentiated high-grade, falls in between anaplastic on the bad side and the better differentiated ones on the left-hand side. So it is intermediate in prognosis. That is what is important to remember. This is just to highlight that medullary carcinomas are now graded, and there are criteria to grade them depending on these three morphologic features. This is the rest which has been reorganized a bit. You have a mixed medullary and follicular, then you have salivary type carcinomas, and you also have the new entity highlighted in blue, which is a thyroblastoma, and I've already told you. Just to reiterate this point, if you find squamous differentiation, it's an anaplastic carcinoma. So that's about the important changes from the 2017 to the 5th edition of the WHO.
Earlier, follicular variant of papillary thyroid carcinoma was also a variant of PTC.
Right.
Now, I think it has been taken out from papillary thyroid, and I don't know where is it now. Can you please explain?
Yeah, correct. So again, the basis is molecular. Follicular variant of papillary was called so because it didn't have those finger-like processes, but it had nuclear features of papillary. So all of us know that traditionally papillary carcinoma has certain nuclear signatures, internuclear inclusions, nuclear grooves, overlapping, clearing. Now, when there is a tumor which does not have papillae, is arranged like follicles, but it has nuclear features of a papillary, it used to be called follicular variant of papillary carcinoma. But now we have two subtypes in that. There is an infiltrative type of follicular variant where there are no papillae. It is in follicles, it has the nuclear features of papillary, but it tends to infiltrate. So that is traditionally again BRAF mutated, and it is still classified with papillary carcinomas, PTCs. But then there is that group of follicular, which actually is called invasive encapsulated follicular variant of PTC, meaning there's a capsule, and if it invades like a follicular carcinoma. So it goes across the capsule, goes into the vessels, and it's not typically infiltrative like the regular PTC. And that is actually has a molecular signature of RAS-like mutations. So it identifies actually with the follicular carcinomas, because again, molecularly they're similar, they also behave similarly. So that group is now actually the follicular variant of PTC. So which is different molecularly, behaves differently from the regular infiltrative follicular variant of PTC. And that's the reason, again, a molecular basis for separating these two entities.
And also the confusing thing for the clinicians is when you come to the fine needle aspiration cytology, it is the category 3 FNAC. Now they have said you have category 3A and 3B. So which patients to actually keep them on follow-up with category 3 FNAC, whether, it becomes a big confusion. So a lot of the patients, even though they have papillary thyroid carcinoma, they've been kept on follow-up. Thanks to the biology of the disease that it's not an aggressive one, we are still okay with it. But how to, select the patients and refer them for surgery?
Right. So category 3 is actually a relief for the pathologist, but I know it puts you into a quandary because you don't know what to do. Do you follow them up? Do you excise them? What is the best option there? So basically category 3 is one which is intermediate between benign and malignant. So we do not have frank malignant features, and we are not able to clearly call it a benign lesion. That is what falls into category 3 for a cytologist. Now, I understand that the implications are different and difficult for you, but we tend to therefore push things like, I have a few images if I can just share with you. This was the original TBS system with 6 categories, which has now undergone 3 modifications, with the latest one in 2023, which is the 3rd edition. There's not too much of change as far as the category 6, which is malignant, is concerned, and suspicious for malignancy, because there you are actually considering a malignant lesion. But the problem comes in categories 3 and 4, because what do we do? How do we follow up? Do we actually subject all of them to a lobectomy or no? So to make things easy, I'll just show you what we call category 3. Essentially, category 3 is, and in this era of guided FNACs, what happens is often we just get the smears, which are not always the best. Their smears are not of good quality. You can see on the top 2, there's a lot of blood, and all those cells are caught up. And we really can't see the morphology. So we need to see the cytoplasm, the nucleus, and all the features to give you a clear-cut diagnosis of malignancy. When we are not able to do that, and you say it's a solid cystic nodule, then we are worried about a cystic papillary. That's when we would probably put it in category 3, which is otherwise known as AUS, or atypical atypia of undetermined significance. It was also called follicular lesion of undetermined significance. That has now been dropped out. That's why I have sort of put it in gray. That is dropped out in the 2023, so we are going to call them only AUS, atypia of undetermined significance. And you look at the second picture on the left. There's so much of nuclear size variation. So that is concerning for a malignant process. Not always. And there is also what looks like an internuclear inclusion, but that's not a diffuse change. So there is some atypia, but not enough to call it a PTC. That's when we would dump it into category 3. But we are certainly concerned. So it's often the nuclear features which are worrisome, rather than cytoplasmic features, and we don't see architecture in cytology. So we rely heavily on nuclear features to make a diagnosis of papillary CA. Excuse me. And if you look at the picture on the left, again, there is some variation in size of the nuclei. So when there's variation in size, you're worried, concerned about a malignancy, but we probably do not have access to the radiologic findings. We do not know where to put it. Then we actually put it in category 3 to alert you that please follow this. I mean, we are trying to reduce the number of this wastebasket category, basically, to try and aid patient management. Now, I'll quickly cover category 4, though Dr. Siddharth hasn't really asked for it, because this is one where we suspect a follicular neoplasm. But now the current trend is to drop the word suspicious. Just look at this picture to show these are repetitive microfollicles, which the cytologist relies on for making a diagnosis of a neoplastic lesion, usually in the absence of too much colloid. There's a lot of nuclear overlapping and there are tiny follicles. Then you're worried about, and nuclear features of PTC are not seen. Then we are worried about a follicular neoplasm. Again, neoplasm, not adenoma versus carcinoma, we can't tell you, because those are architectural features which can only be done on permanent sections. So we can tell you that yes, probably this is a follicular neoplasm. There is a caveat there, and a major limitation is a dominant nodule of a colloid goiter. You have multiple nodules, and you have actually sampled the one which looked solid. You don't obviously sample all of them. And the solid one, if we do not know, is part of a multinodular picture, can be mistaken for follicular neoplasm. It would look identical. And there's no easy way of telling the two apart. So that is when we need your input. We need the radiology. We need to know, is the patient hypothyroid? What about the antithyroid antibodies? Are they positive? Then it could well be a nodule in a Hashimoto's. So that's why we sometimes bug you, which to your annoyance, I'm sure, but we really need those findings to try and tell you whether we are dealing with something malignant, something neoplastic versus something benign. Okay? Yeah, sure. Thank you.
So now we move on to the next topic, that is the ultrasound and thyroid. Ultrasound for the endocrinologist and thyroid surgeon should be like the stethoscope of the cardiologist. So it's very important, everyone should be familiar for using the ultrasound. Now I request Dr. Vrinda to give an overview of the ACR thyroid scoring.
Hi, good morning everyone. Like Dr. Siddharth actually already mentioned, that thyroid ultrasound is something I think is like the stethoscope for all of us. We use it basically to confirm if there is a thyroid nodule, how does it look, and is there any concern about it. So does it need further assessment in terms of fine needle aspiration cytology to confirm whether it's benign or malignant. As the data says, most are benign, and even malignant nodules, mostly are say less than 1 centimeters. And again, the role of the ultrasound is to help delineate like which nodules would actually require further assessment, further management. Do they require cytology? Would they be malignant? What would be the further ramifications of these nodules? So, this is just a brief overview of how like TIRAD system came around, and currently what most commonly we talk about is the American College of Radiology TIRADs, which came out in 2017. Well, what essentially is TIRADS is that ACR proposed that there should be a standardized way of, presenting these thyroid nodules, to anybody to essentially understand, a numeric system to understand, which ones would be categorized as concerning, malignant, and which ones would be categorized as more benign. And this could further, help with management recommendations. And this would essentially prevent unnecessary biopsies and, help the physician to talk about prognostication. So when we talk about the TIRADS system, it goes on from TIRADS 1 to 5, and essentially 1 to 5 also signifies worsening risk for malignancy. So when we talk about the malignancy rates for TIRADS 1, it's very minimal, 0.3%, and when we go on to TIRADS 5, we're talking about 35% risk of malignancy. And this, a very common slide, I think a lot of us might have already seen, but this is essentially, what TIRADS does. So certain ultrasonography features of the thyroid nodules, we look at them and then we give them points. So if, let's say, there is a completely cystic nodule, it will have 0 points. And then if it's a completely solid nodule, then it will be 2 points assigned to it. So similarly, we talk about echogenicity, hypoechoic being 2 points, very hypoechoic being 3 points. We talk about the shape, taller than wide gains 3 points. We talk about margins, and irregular margins get 2 points, and then we talk about the echogenic foci, we talk about presence of microcalcifications, macrocalcifications, etc. So we add on these points from the ultrasonographic picture of these thyroid nodules, and we calculate a cumulative score, and that is how we categorize them as TIRADS 1 to 5. So TIRADS 5, as it's mentioned here, highly suspicious. We propose for FNA if the nodule is more than 1 centimeters. If, for TIRADS 1, essentially no FNA is recommended. So a few assumptions, essentially if the rim calcifications are present such that they obscure a very clear view of the nodule, then we choose the composition to be defined as solid and the echogenicity to be isoechoic. If the margin cannot be determined very clearly, we choose to use the term ill-defined margin. If echogenicity cannot be determined, we choose the term isoechoic. And if composition cannot be determined, we choose the composition to be solid. I'll just move on, so just a quick word about doing FNA, which nodules essentially would meet the criteria for doing FNA. So when we define these nodules on the ultrasound, we are looking for essentially a few features. So remember, not one ultrasonographic feature defines benign versus malignant. It's usually, a group of features coming together which may make a nodule more suspicious or less suspicious for malignancy. So FNA is the tool we have in hand to prevent unnecessary surgeries and to identify nodules which may benefit from surgical removal. So those which we categorize as highly suspicious nodules are the ones which are solid, hypoechoic, they have irregular margins, they have microcalcifications, could be taller than wide, and have any evidence of extrathyroidal extension. They would carry a risk of more than 70 to 90% of harboring a malignancy. And so we do recommend an FNA if the size of the nodule is more than 1 centimeters. For those with intermediate suspicion, hypoechoic solid nodules with smooth margins, and without any further features, those were with microcalcifications, extrathyroidal extension, irregular margins. So the high risk features are not present, so they would be called as intermediate suspicious nodules. And again, FNA is recommended for those for more than 1 centimeters. Those with a low suspicion are the ones which are isoechoic, hyperechoic, partially cystic nodules without any high-risk features. For those, we recommend FNA at more than 1.5 centimeters. Purely cystic nodules are essentially benign. We do not recommend FNA of those nodules. And then the low suspicion ones are the spongiform nodules, which we usually say more than 2 centimeters would be considered for biopsy. Thank you.
Thanks, Dr. Vrinda. So now we move on to the most dreaded complication, like hypoparathyroidism following total thyroidectomy. It's one of the most common complications, and rates of postoperative hypocalcemia. Temporary hypocalcemia can be up to 35%. Permanent hypocalcemia defined as even after 6 months, if the patient is having hypocalcemia, it is permanent, seen in 1 to 6%. So as a surgeon, we regard every parathyroid as the last surviving parathyroid. So it's very important, and you have to handle it very delicately, and it is very difficult to treat this permanent hypoparathyroidism. So I request Dr. Mehrotra sir to talk about the postoperative management of hypoparathyroidism.
Thank you, Dr. Siddharth and Dr. Idea Clinics for calling me here. This is an important thing that normally we see in our practice. The post-op hypopara and how to prevent it and how to... The main thing is to anticipate the problem. When you see a patient that patient is planned for a bilateral neck exploration, patient has got CA thyroid with bilateral lymph nodes, or patient with Graves' disease going for thyroidectomy, these are the patients which are going to be at more of risk for hypocalcemia. Then come the patients who are basically being operated by low volume surgeons, or patient having history of malabsorption or bariatric surgeries. These patients are more prone to have hypocalcemias. If you look at the workup of post-op hypocalcemias, the most important thing to look at is initially the magnesium first. If the magnesium is low, you treat the magnesium, the calcium becomes normal, the problem is solved, you need not evaluate further. If magnesium is normal, the problem still remains, then look at the phosphorus. If the phosphorus is high, that means the other damage to the parathyroid blood supply. Then the question comes, it could be transitory, which is less than 6 months, or could be permanent, that is more than 6 months. Now, how do we evaluate further than this? Can we predict who will be needing long-term admission or who can be discharged in a day or two? Then comes the role of the post-op PTH. We do intra PTH for hyperpara patients, but becoming more recognized now that we should do a post-op PTH for thyroidectomy patients. If the PTH is more than 20 and the calcium is more than 8, patient can be discharged very safely on oral calcium supplement. Nothing more is required. If the PTH is less than 10 and calcium is less than 8, definitely he'll require a calcitriol, 125 vitamin D with calcium supplements. If the borderline PTH is 11 to 19 and calcium is between, say, less than 8 or around 7.5, they will need a calcium supplementation and a calcitriol and a close follow-up to decide when to discharge them. The management basically depends upon the patient's symptoms. Patient, if symptomatic, will require IV calcium initially, and then they can be put on either on an oral or an IV infusion. The problem comes, you give them one dose, you give only calcium the infusions like 6th hourly or 8th hourly. That will not maintain the calciums. You give an initial bolus dose of calcium supplements, IV calcium, maybe 1 ampule or 90 milligram of calcium in 150 milligram of 50 ml of dextrose over a period of 15-20 minutes, and then put them on a low dose infusion. Now, infusion basically is critically prepared 1 milligram per ml and start at the rate of 30 to 50 ml per hour, then titrate the dose accordingly. In the meantime, you can put them on 125 vitamin D, calcium, look at the magnesium, put them on a low phosphorus diet and manage it. But they will require at least 2 to 3 grams of calcium and 125 vitamin D of say 1 microgram per day to maintain the calcium for some time. The question comes when to start the PTH injection. That is sometime a question to be answered. If sometime we have reached the oral calcium of say 5 to 6 milligram and a 125 vitamin D of more than 2.5 to 3, and still patient is having symptomatic hypocalcemia, then we have to consider putting them on a teriparatide, which could be a transitory one. And in last 6 months, we had 3 patients who required teriparatide, but they luckily went off the PTH injection within 2 to 3 months. So post-op hypopara is sometimes difficult to treat. The question comes to choose the high volume surgeons. They are more experienced in looking at the parathyroid, preserving the blood supply, preserving the stem, and giving you a note in the pathology report that parathyroid has been preserved. That is quite assuring.
So before we go on to the normocalcemic, the another entity when we do a parathyroidectomy, and it sometimes becomes very difficult. If you have a tertiary hyperpara, and I know it definitely will go into severe hypocalcemia. But some patients we also had, I mean, like after doing a parathyroidectomy, the BMD was low, and they go into this spasms. And I remember for one patient, I had to give 5 calcium gluconates slowly over a period of 1.5 hours. Then only it got relieved. The spasm got relieved. So how to predict which patient following parathyroidectomy can go into this hungry bone syndrome? Anything?
Yeah, if you look at the Indian parathyroid patients who have been picked up and treated, they tend to have larger parathyroid glands. They tend to be having more low vitamin D deficiency. They have high alk phos. A patient with high alk phos and a bigger parathyroid nodule will definitely go into hungry bone syndrome and will require IV support for some time. So the basic thing is to look for and some patients say look at the pre-op calcium. The calcium, the higher the calcium pre-op, most likely he will fall post-op. So high calcium, high alk phos, low vitamin D, large gland size can to some extent predict your patient who will go into hungry bone syndrome.
Now everybody knows how to manage this primary hyperparathyroidism. You have a elevated calcium, elevated PTH, you know what to do. And then you got this asymptomatic primary hyperparathyroidism where there is no end organ damage. Now with the health-seeking individuals and the software people, too many health tests being done, and you come up with this entity called normocalcemic primary hyperparathyroidism, where the calcium is normal and the PTH is high. And when you see there is no end organ damage, and when you image, you may or you may not find, and the patient is quite anxious. It's a new entity. I think it came out in 2008 in the Bilzikian conference of the parathyroid. Can you please update on the management of this normocalcemic, sir?
Yeah, this basically the term comes when patients' calcium is normal and the PTH is high. We know that the calcium measurement can be affected by the low albumin levels. So first we say the definition means the albumin corrected calcium should be normal and the PTH should be high. It's not that the patient has a low albumin, low calcium and the PTH is high. So first you correct the albumin for the values for the calcium for the albumin. If still the calcium is normal and the PTH is high, then you can entertain this entity of normocalcemic. Remember, this entity is basically a diagnosis of exclusion. So before we go ahead and say that it is normocalcemic, look at the vitamin D levels. Anything vitamin D, if you look at the vitamin D levels are low, you may have a calcium which is normal or low normal and the PTH be high. So before we go ahead, we should maintain the calcium at least above 30 for 3 months. Relook at the PTH and then say, if we have given vitamin D for 3 months, the PTH becomes normal. This is not normocalcemic hyperpara. It was only secondary hyperpara. In case despite 3 months, calcium being the adequate vitamin D supplementation, the PTH is still high, then you can enter into this the terminology of normocalcemic. Then the second important cause is the patient on bisphosphonates and denosumab and diuretics. Now we know that bisphosphonates and denosumab decreases the bone turnover, they decrease the bone calcium resorption, so they tend to elevate the PTH patient on therapy. So it's better always to look at the PTH and calcium values before starting them on therapy, so that the confusion doesn't arise. Okay, today my patient is on a bisphosphonate, I have given them 2 injections of zonotic acid, then he comes with a calcium of say 9 and a PTH of 120. But if you go back and look at the start of the therapy, if the calcium PTH was normal, then we do not consider this as a normocalcemic hyperpara. But sometimes you may have a situation where we don't have the pre-starting therapy of PTH. Now you have a PTH high and a calcium which is normal, vitamin D is normal. Then the authors say you should look at withdrawing the bisphosphonate denosumab. Now, but they do have a long half-life. Bisphosphonates stay in the system for more than years. So there, I'm not very sure how to withdraw it. There, the decision has to be based on a case-to-case basis. If patient is on therapy, look at the BMD values. If BMD is stable, we do not interfere further. If the BMD is falling, then you may consider doing imaging after that. The third important cause could be to look at the diabetics or the hypercalciurias. Somebody having hypercalciurias will have a high PTH. So they will have normal calcium, high urinary calcium, and high PTH. So in that case, you can give a trial of Thyroid. If Thyroid normalizes the urine calcium and the PTH comes back to normal, it was hypercalciuria, we need not investigate or treat further than that. Then come the patients having impaired renal function. Then this is the elderly population. At the age, the GFR will decline. As the GFR will decline, PTH is bound to go up. So you will find a lot of situations where creatinine is borderline, GFR is around 40 to 50, calcium is around 8.5 to 9, and PTH is around 79 to 100, somewhere between that. So in that case, you can give a short trial of 125 vitamin D. If it is because of CKD, the PTH will go down. You can stop evaluating from that point of view and treat the patient as a part of CKD, follow up. Patient undergoing bariatric surgeries or malabsorption, they will have low vitamin D, to treat that problem first and then look at the calcium and PTH. Once you have done that, and then follow up these patients for the manifestation that primary hyperpara may have. So the follow-up becomes like this. We know that the PTH can affect symptomatically your patient's mental, the neurocognitive functions, anemia, cardiac vascular functions, BMDs, renal functions, and urinary calcium or your kidney stones. So a patient has got normal calcium, high PTH without any secondary cause of hyperpara have been ruled out. They have been in the follow-up. You go for an imaging like any other primary hyperpara patient. If the patient meets the criteria, then you go for a surgery. But remember that these patients tend to have multi-gland disease. They may not always have a single adenoma. They may tend to have more of multi-gland disease, where you may find discordant imaging. So these patients may require a bilateral exploration. So before you make a decision of bilateral exploration, be confident that you are treating the correct entity. Even in the intra-op, the PTH will tend to decline a little slowly. Normally, we look at the PTH values of 10 to 15 minutes or 20 minutes. But here, been advised, look at the PTH value post-op of even 30 minutes to define the criteria of cure. If they don't meet the criteria for surgery, you can put them on a follow-up, treat with bisphosphonates to preserve the bone density. You may use senacalcet, but senacalcet is not shown to have so much benefit. What is shown to have a bisphosphonate which can preserve the bone density. In case patient is developing hypercalcemias or developing the declining renal function or declining BMD, then we are sure that we are planning for a surgery. Follow-up is basically based on calcium every year, DEXA every year, and other tests for the requirement of the symptoms every year. The yearly follow-up is the most important.
Thank you, sir. To lack of time, we close this session. Any questions? Yeah, you can ask us as we have lunch. Thank you. Now we move on to the next session. Thank you.
Hi, good afternoon, everyone. So we'll move on with the next session, essentially a little panel discussion on what we can learn more in diabetes. I would like to invite our chairpersons for this panel discussion up on the stage. Professor Dr. P.V. Rao, sir. Um, Sir is the former senior professor in HOD Department of Endocrinology and Metabolism at NIMS. Welcome, sir. A pleasure to have you. I'd like to call upon Dr. Rakesh Kumar. Um, Sir is the professor of endocrinology at Osmania Medical College and Sahai's Endocrine and Diabetes Center in Hyderabad. Welcome, sir. I'd like to call upon Dr. Meher Prasad, sir. Welcome, sir. Sir is a senior consultant, diabetes, endocrine, obesity at Idea Clinics and at Chettinad Hospital, Kaveri Hospital. Welcome, everyone. So without further ado, I'd like to move on with the session. Can I have the slides up on, please? Thank you. A few topics of interest. I thought this would be something we'd all like to learn from our experts. And so it's going to be a more of question answer session. So this is not working, is it? Can we just request the next slide, please? There's no computer. We all understand that I think over the years, learning more about diabetes and pathophysiology, that, our patients present to us, with different clinical presentations and disease progression stages. So we've understood not one size fits all. And to move beyond just talking about, or categorizing our patients at type 1 and type 2 diabetes. So more recently, we've understood that diabetes could be a heterogeneous disease with patients experiencing, various contributions from a mixture of, like, say, beta cell dysfunction, defective insulin secretion, and insulin action. So very recently, there was a Swedish study, like the Andes cohort, which kind of helped identify diabetes subgroups beyond just talking about type 1 and type 2 diabetes, which may help risk stratify these patients, optimize or direct
looking at these parameters, understanding, dividing our, or classifying our clustering our patients into these different clusters and doing it. Although we are looking for, better sort of clustering tools, which may we do it sort of. Looking at these characteristics, we often use these characteristics to understand how to stratify our patients.
That's great, sir. I think future holds a lot for us in store. But building up on the same, Professor P.V. Rao, sir, so do you see any benefit in then checking for indices like HOMA-IR or checking for beta cell function?
So I will start my discussion with the history of HOMA. Sometime around 1983-85, they have introduced this HOMA. Those days it was very simple, just blood glucose and millimoles into insulin, microunits divided by 22.5 over. So we were very curious, how did they come to such a simple equation for IR? Those are the days when there were no computers and only Apple computer was there. So we were very curious to know. So I'm not from Oxford, but we have visited Oxford to know the statistics part of it. But since then, they have been revising it. They have made it log conversion, standardization, so much of thing. Now it is not possible for anybody to manually calculate HOMA-IR or HOMA-IS or HOMA-BF. Even beta cell function was so simple in those days. Blood sugar, blood glucose millimoles into insulin, blood glucose minus 20 into insulin divided by blood glucose minus 3.5. It's very simple. But now it has become so complicated, we have to use the Excel sheet or you have to use the pull down menu. So it is not possible for people in the clinics to go by HOMA-IR or HOMA-IS like what they are describing in this cluster classification based on a small group in Scania from Sweden. So Mohan has sort of revised it as inspired study. So India, Scotland participation for precision medicine. So he has sort of removed the GAD antibodies. GAD antibodies is not being routinely done in India, so that's why he removed GAD. And instead of calculating added lipids, and instead of doing this HOMA, he said one fasting C-peptide should be okay because we can use C-peptide and calculate HOMA-IR. Similarly, without doing any calculations, without going for higher statistics, you can just take C-peptide, fasting C-peptide. And he has made, in INSPIRED is only 4 groups, not 5 groups. So it is insulin deficiency, insulin resistance, plus combined insulin deficiency and resistance. Like that, age related. So they have made it sort of a simple classification. But in my opinion, it's not possible for people to calculate HOMA-IR and HOMA-IS. But I want to tell one example of how this is being done in smaller clinics. It's only example I'm just giving. It's not routinely being practiced because we have developed a point-of-care device for C-peptide where you can do C-peptide tests within 20 minutes. So with our point-of-care device, now it is no more popular, but at one time we were doing it in filter paper, dried blood spots, and point-of-care devices. So point-of-care device in capillary blood, C-peptide, was used even in a small place like Khammam for his own satisfaction or for his own explanation. So HOMA-IR, HOMA-IS, and HOMA-BF was written on the in the K sheet, in the prescription pad of one doctor in Khammam. He's a world practitioner. So he, based on C-peptide and fasting glucose. And then he was telling, he was actually using that particular prescription pad to show his patients that with Pioglitazone, with Metformin, SGLT2 has also been introduced. With all these things, they are not, we don't consider them as a strong insulin sensitizers, but he was showing some benefit in IR by taking C-peptide fasting with our point-of-care device and glucose. So like that, people have been experimenting a lot with IR, but it is not possible. We do a lot of clamp studies. So even now, mostly clamp studies are being done by gastroenterology people now. So there is going to be a huge phenomics research coming up, phenomics research. So huge phenomics research taking into account some 1,000 parameters. So that study is coming up in by Asian Institute of Gastroenterology. So, but they will not use this HOMA-IR and HOMA-IS or HOMA-2-BF and all these things. They go by clamp studies. It's very difficult studies. That's why these are all for research purposes, but I don't think we'll be able to use this HOMA-IR, HOMA-IS, HOMA-BF for cluster classification.
Sure, sir. No, that's very insightful, sir. You're right. I think it's going to take some thinking about it. Dr. Meher Prasad, sir, so, again, if we talk about patients with, say, severe insulin deficiency, severe insulin resistance, obesity related, so, how does it help you identify, like, okay, which drug would benefit the other patient more, say, compared to the other? So is there any therapeutic implication of also, like, categorizing our patients into these subcategories?
Well, I mean, as you alluded, the diabetes management is becoming more and more precision diagnosis. It's more aimed at specific subgroups and the specific agents. So it does, these things does help, but it will take some time, and also more genetic studies coming, both in type 1 and also in type 1 also. It is going in that direction, and it's going to become more and more useful, the studies and also the investigations in tailoring it to individual patients.
That's right, sir. Thank you. Thank you so much, sir. So moving on to the next topic. So something I think very commonly seen in our day-to-day practice topic, I think hotly debated topic as well, metformin use in pregnancy. So over the years, of course, we've realized that, the prevalence of course, GDM is there. It's pretty high in our Indian population, and I think for the ease of using metformin, we've read multiple surveys, read multiple studies. There are many doctors who are comfortable using metformin in pregnancy in GDM patients. So we do have data to support maternal safety for metformin. Less chances of weight gain for obese patients and less chances of hypoglycemia. Then we talk about short-term benefits with lesser incidence of large for gestational age babies, less hypoglycemia. But, of late, a lot of research and data is coming about, talking about adverse fetal programming with this drug and a higher incidence of, childhood obesity in kids born to mothers using metformin for GDM. So essentially, when we look at the guidelines across the world, most of the guidelines actually endorse insulin as the first-line treatment for GDM, and usually metformin is reserved as like the category B or the second-line drug. It crosses the placenta. There are these concerns. So I wanted to know from experts here, what do they think about metformin use? So first question for Meher Prasad sir. What is your experience using metformin see, say, the guidelines changing or not changing?
Yeah, so I
endorsing?
think if you look at all the guidelines today also, all of them speak of insulin as the first choice. And, metformin comes in as a close second choice because of the ease of use and the fact that, the studies done till now have not shown any adverse impact. I mean, because it freely crosses the placenta, we all know that it freely crosses the placenta. And, but since there's no data on any adverse fetal or maternal outcomes, because of that, it has been recommended for use. Particularly if you look at the Indian guidelines also, they have not mentioned this on the table. On this table, the Ministry of Health of India, Government of India has also suggested the use of metformin in the second and third trimesters. They have, in fact, put it equivalent to insulin in the second and third trimesters, whereas they still haven't spoken about the first trimester use of metformin. So I think that's where it is today. And you have very rightly put up the points that we had the mixed study which did show that metformin was quite safe in terms of having lesser incidence of large for gestation age babies, but there was a slight increase in preterm babies, and you also said, you spoke about the small for gestational age, and that has been a concern because follow-up of these individuals. So I think there was a recent publication in BMJ which brought out, the data on 9,000 odd women who were, some of them treated with metformin alone, about half of them, 3,000 odd treated with metformin alone, some of them with both metformin and insulin, and another group which was insulin alone. And they have, again shown that slight increase in terms of the small for gestation age. But the implications of that are not very clear, long-term implications of that. But the data that they have shown in that study has sort of given a go-ahead for metformin for use in pregnancy and has not highlighted any adverse impact. But these are points that need to be looked at, because when you look at the follow-up of the MIG tofu also, we realize that those babies who are born to mothers who are using metformin have a slightly higher body fat percentage. And what is the impact of it in terms of the long-term risk for cardiovascular disease is something which needs to be further looked at before we are very putting metformin higher up in the management of gestational diabetes.
Are you concerned about this thing, the fetal programming?
That's also some of the data which was presented, recently, as recent as in the last ADA last month. I was hearing a few of these studies which have looked at, these studies which are particularly the molecular studies which have looked at the effects of metformin on the liver and how it is changing the programming towards on the fetal liver and the adipose tissue and producing a little bit of adverse impact, which the clinical impact of that has to be still understood. And so I think that is something which we need to still look for. But for that, it's a very good molecule which is easy to use and makes it very comfortable for the women keep them at their glycemic targets.
Sounds great, sir. Professor P.V. Rao, sir. So, would there be any clinical situation where you'd consider stopping metformin in pregnant women?
To be frank, I don't start metformin. Today, Hari Kumar was very strongly talking about metformin being contraindicated in pregnancy. At one time, some years back, some 35 years back, when I landed in Hyderabad, I was also so strong about metformin. But British trained and American trained, you have different versions. We are all Indian trained, so we have mixed versions. So British people say and European people say metformin can be used first line of drug, don't care in pregnancy. You are from America, so American people don't like it. And we are Indians, Rakesh is also Indian. So we are all trained by mixed population of professors. I came from outside Hyderabad, so when I came here, I was very strongly against metformin, but Dr. Shyam Sundar was there. Dr. Shyam Sundar was the boss of Vijay Sakhar, first endocrinologist. DM endocrinology from Chandigarh. So he was very strongly opposing me. He said, who are you to say metformin should not be used? No, sir, I think it is not to be. No, who are you to say? Like that, he was very strong. So anyway, we have molded down. Now we say, okay, you want to give metformin, you give. You want to give metformin, you don't want to give. But you see, I'm happy that at least younger generation are going by the stronger mood. Okay, metformin, the question what you have said is, when do you stop metformin? Okay, metformin, I don't like metformin, but if somebody is using metformin for PCOD or for something, and I tell them at the time of pregnancy, please stop. But Indian mentality, Indian doctors say no, continue it till the end. That is one thing. So it is not stopped even when the PCOD lady becomes pregnant. Second point, ketonuria. Ketonuria or ketosis is much worse than hypoglycemia in pregnancy. So any small amount of acetone in the blood or any small amount of pH drop in the blood is detrimental to the fetal growth. That is another issue where we have to stop metformin. Then third point is any weight loss. Metformin known to be anorectic as well as cachectic. So there is some weight loss. Weight loss may be because of metformin, but for obstetrician, any weight loss during pregnancy is amounting to IUGR. So it's an impending IUGR or impending fetal loss. Metformin is the presenting weight loss is the presenting symptoms. In that situation, you have to stop metformin. Of course, our ladies with pre-existing, and I'm talking about Indian context, pre-existing diabetes is not diagnosed before pregnancy. During pregnancy, if they have nephropathy or retinopathy, it gets worsened during pregnancy. In those situations, more than 50% of the diabetic children or diabetic women in Hyderabad are on metformin. With pre-existing, without pre-existing diabetes is not known. I'm talking about Nayapur, Sultan Bazar, and this kind of population. Please be aware that nephropathy and retinopathy worsens if you continue giving metformin. So these are all mixed way of dealing with things, but nowadays people may not like metformin at all.
I'll just add one more situation is, I think pre-eclamptic toxemia also, hypertensive disorders and pregnancy also, metformin is not to be continued or used in that.
True.
Dr. Sir has already given the other scenarios, I think.
No, that's very insightful, sir. I think you're right. We've grown so used to like the ease of prescribing metformin, but I think we do need to weigh the pros and cons. Moving on to the next, topic. I think it's a very day-to-day topic too. Pioglitazone. I think in the surge of all the new medications on board, I think somewhere, I'm not sure, but have we forgotten the drug? And I think it all started with the Avandia debacle, the rosiglitazone debacle back in 2007, 2008, where a cardiologist from Cleveland Clinic was concerned that rosiglitazone was probably increasing the risk of cardiovascular events, more heart attacks, and patients using the drug. So in 2007, FDA issued a black box warning to rosiglitazone, and ever since, Rosie has pretty much become a history. But I think, of course, those effects have kind of spilled over onto the use of pioglitazone also over the years. And so the real question is, do we still need pioglitazone? Well, and then, what are the advantages, disadvantages? We do have, of course, data over the years to suggest that it's a good drug for insulin-resistant patients, has benefits in terms of decreasing stroke risk, decrease in the risk of, reinfarction in those with previous MI, etc. So I'd like to learn from the panel here. Professor P.V. Rao, sir, what's your experience with pioglitazone?
I have a large experience with all I started with troglitazone, then rosiglitazone. I was in DREAM project. So I followed rosiglitazone patients for about 13 years in DREAM project. Then I used pioglitazone. Then we have used glitazars also, because one of the first earlier glitazar was made in Hyderabad, Raga glitazar. So we have done clinical trials for Ragaglitazar. Balaglitazar, I have not done clinical trial. Muraglitazar is from UK. I have done clinical trials. So I think, in my opinion, since Troglodytazone was not marketed in India, but it was used in India by some VIPs those days. So I have not seen any major adverse events being described in the literature all these years. So these things are not just glucose regulators. Glitazars or glitazones are not just glucose regulators. They are also lipid regulators. So you have to give importance to the lipid regulation, because there are PPR gamma, PPR delta, PPR alpha also. So they have effects in different nuclear receptors. So in that case, actually pioglitazone is very good in not only diabetes but also in lipids. Recently, I've been watching these gastroenterology people treating these MASH, fatty liver. So they say pioglitazone is, they are telling me that it was published somewhere, I have not really checked for it, but they say pioglitazone is a better drug than saraglitazar in reducing the fatty liver, the amount of fat, because they are all measuring by fibroscans or by MR elastography, they are all doing, right now all big investigations are being done. I think pioglitazone, I have never seen a patient having osteoporosis or eye problem or waterlogging, congestive heart failure, and all these things are being told to us, but even for rosiglitazone, I have not seen anybody having these problems with the cardiovascular morbidity. But anyway, things are differently. But now pioglitazone is being used by all diabetic subjects. There is no harm in it. It has an added effect of lipid regulation. Maybe it also reduces fatty liver, which is almost 100% seen in all our diabetic subjects.
Absolutely, yeah. Rakesh sir, question for you. So the rosiglitazone was, tied to the increased risk of cardiovascular events. What is your thought on, say, pioglitazone and cardiovascular disease, mortality? Like, what's your take on it?
Yeah, so I think one that there was a benefit, there was no harm with the pioglitazone. So clearly what was seen was whether there was any harm with the use of pioglitazone, because it has these benefits in terms of reducing insulin resistance, having a favorable effect on the lipid parameters, and having many surrogate markers like reducing the carotid intima media thickness and reducing atherosclerosis in general. But I think we don't have any study which has looked at the overall cardiovascular MACE outcomes. So that MACE outcome looked at in that one study which did show that there was no harm with pioglitazone. Certainly there was no harm. It may not have shown the benefit that was seen with the SGLT2 inhibitors and the GLP-1 analogs which we have today, but there was no harm with pioglitazone. I think one of the recent studies has been where DiFronzo has done this triple combination of pioglitazone, GLP-1 analog, and Metformin. I think that was used right from the onset of diabetes. People right at the time of detection of diabetes were randomized into this versus single therapies, and he has shown that those on the triple combination have a much greater degree of better glycemic benefit and a longer duration to failure of any of the therapies of this combination, in terms of the HbA1c going up and all that. So I think those benefits have been shown with pioglitazone, but I think the best benefit is in terms of the lipids, MASLD.
Right. Thank you, sir. Dr. Meher Prasad, sir.
Including 4 textbook chapters, and he's a recipient of the Abdul Kalam Award for Excellence in Field of Endocrinology. And he was an excellent organizing secretary for the SMR23, which was mainly his next panelist is Dr. Ravikumar. Ravikumar is a consultant endocrinologist who practices at Madhava Super Specialty Hospital in Nizamabad. He worked as a registrar in various hospitals in the UK. He has multiple papers on diabetes management, endocrine disorders, and he has presented at national conferences all across him. Many interests in many various fields of endocrinology. So with that, let's move on to the panel discussion slides. So we've picked out very clinically relevant topics in endocrinology that general medicine or general physicians may come across. Next slide. Okay, fine. So first thing is hyponatremia. We see hyponatremia is a common presentation. It's a very incidental finding in our OP and IP. It's usually not evaluated before treatment. Hyponatremia means SIDH, start of tolvaptan. That is what we see in clinical practice. What we have seen is excess water is very common in the elderly. People drink 4 liters, 5 liters of water, especially elderly, and they end up with
And second thing is, as the name suggests, inappropriate. That means there should not be any cardiac, renal, hepatic, adrenal or thyroid problems. Simple. Very simple. In presence of absence of diuretic use. Even though, and also absence of whatever there is a stimulus to the ADS, that is the hypotension, nausea, vomiting, stress should not be. These are the criteria for SIDH. These things are not that we should think of SIDH. So okay, then how do you go about it? The first thing is what we do in practice is we have to find out whether it is hypotonic, normotonic or hypertonic. Hypotonic, we know that hyperglycemia, this is which use mannitol and other things. So there is what are called pseudo-hyponatremic conditions, hyperproteinemia and hyperlipidemia also. But nowadays there are various methods we can measure that. Even hyperglycemia. Yeah. And then the other aspect is the hypotonic, the hyponatremias. So how do you go about further? What we do is clinically, we see just simple, BP, pulse, skin turgor, moistness done, then the measurement of the CVP will tell you whether you are dealing with the euvolemic, hypovolemic or hypervolemic, the hyponatremia. So based on that, that's what measurement of CVP is very important in the ICUs. And then based on that, further segregation will be dependent on based on simple. Urinary sodium more than 20 or less than 20. Then we can have a variety of causes. That's a simple way to go.
Sure, sir. Thank you. So, Dr. Santosh, can you take us through how to evaluate a hyponatremia?
So, evaluation of hyponatremia is a difficult subject, but we will try to simplify it. So, number one is the clinical parameters, as Dr. Vijay Shekhar Reddy has already told, whether the person is falling into hypervolemia or hypovolemia. Hypovolemia, you have certain clinical findings like decreased skin turgor, reduced capillary filling time, reduced central venous pressure, you have postal hypotension, etc. So you must think of more of those conditions which can cause hypovolemia, for example, use of
150 ml of hypertonic saline. Because this can go the other way, and I think sometimes leaving the body and correcting it is what is very important. And if this is an emergency, but if in a non-emergency case and you don't know what is causing the SADH, if the patient is slightly symptomatic, and while you're looking for if there's no obvious cause, as to say you ruled out adrenal disease, you ruled out the drugs that's causing hyponatremia, then again, there are drugs that can cause, tolvaptan is another drug that you could use to try and correct hyponatremia. But these are the drugs that needs to be very vigilant. You can't just prescribe it and leave the patient alone on these. You need to monitor it, and these are the not drugs. You can't give it away like chocolates away to the patient, so it's very, very important. Overcorrection, over-heroics is going to be a more problematic, but I think a steady, slow, vigilant observation is what I do in my practice.
Just to add on to that, we see in the wards that, a lot of the time 3% NS is added and tolvaptan is also added on top of that. Could you just tell us what is the actual risk of getting the sodium up too quickly?
So what we tend to do in the wards is like fluid restriction is a good way to get your sodium up. It's an easier way to do it. I know patient may shout at you in the initial phases, but then again, what we do is with fluid restriction, if you're able to get the sodium up, fine. If the sodium is not coming up and you're thinking it's a euvolemic hyponatremia, use tolvaptan, monitor the sodium, and hopefully you would see that because the tolvaptan will act on the V2 receptors, that's your vasopressin. As Professor Vijay Reddy said, it's the inappropriate ADH secretion. So what you want to do is to block the action of vasopressin on the collecting ducts of the nephrons. That's what tolvaptan does. So you could start off with 15 milligrams, see the response in a couple of days. You can go up titrate or down titrate based on the response. Most of the patients do respond very nicely unless the patient has got something like a non-small cell lung cancer and things where the hyponatremia is going to be a problematic till they have the treatment.
Thank you for that. And just to add to that, you shouldn't use all together, either fluid restriction or tolvaptan or 3%, but not all together because that will raise the sodium too quickly, which will cause central pontine melanosis. So next we move on to hyperprolactinemia. This is something that we see in regular practice because the prolactin is being done in packages. All the lab packages are doing prolactin for no reason, and sometimes we see that the values are high. There is a very high use of prokinetic agents like levosulpride, domperidone and all that can actually lead to high prolactin, and it is being used both by the doctors and the public. And prolactin is also being done in a lot of fertility screenings. It's important, actually it's an important test to be done pre-fertility workup. And with these in context, how do we interpret these values? What is the threshold for female fertility and male fertility as well? How do we treat this hyperprolactinemia? So with these points in context, let me start with Dr. Ravi Kumar first. Dr. Ravi Kumar, can we ask you, what are the different causes of, other than a prolactinoma, what other causes can lead to hyperprolactinemia?
The things have changed in the practice from UK to India. As you said, most of them are coming to my clinics with the reports, and I think first is to try and speak to the patient, why did this report be generated? And with a lot of commercial packages across, it's challenging for me to, we all have to change the practice because they're coming with 50 pages of tests. And we have to interpret that, is it clinically significant or not? Smoke. So let's talk about the physiological causes. As we all said, is the patient pregnant, postpartum, is she breastfeeding? These are the causes of raised prolactin. Simple things. We always see prolactin and they miss the... That's the first question. Second, as you rightly said, using domperidone, levosulpride across all age groups have been seen, and everyone are on PPI unless proved otherwise. Now, the question comes to the clinician is the macroprolactin. If you're seeing prolactin levels, but the patient has got no clinical signs, what do? Is it necessary for you to treat or not to treat is the question. All prolactins are not necessarily treatable, or you don't need to treat. So I'm going to mainly concentrate on macroprolactinoma. So you're seeing patients on who's got raised prolactin, but asymptomatic as a part of a routine test. What we've got to do is, we do something called a dilutional technique with PEG, polyethylene glycol. We ask your biochemist. So the best friend for an endocrinologist is a biochemist. So I make sure my biochemist is pampered throughout the year because that's why he gives me the answer. And what you tell to do is, with the prolactin of dilutional techniques, you can make out that is the prolactin normal. High prolactin with no symptoms, speak to the biochemist. Is the problem with the assay? Can you do these to rule out a macroprolactinemia? And if that, with the dilutional technique, if the prolactin comes to normal, then well, you've saved the patient to go through MRIs and all the drugs. So that's very, very important aspect when you see prolactin. And the other essential part is to make sure that the patient who are on they don't have hypothyroidism, because hypothyroidism, another condition which is commonly seen, can cause a raised prolactin. So these are the two things that I will tell.
Thank you. So once we've ruled out that there's all these extensive reasons for high prolactin happening, it very, very rarely, if in 100, maybe 2 or 3 or maybe 5 will turn out to be a microprolactinoma or a macroprolactinoma. So once we confirm that this is a microprolactinoma or we have ruled out other causes, Professor Vijay Shekhar Reddy, how will you then go about, how will we treat a micro or a macroprolactinoma, and what are the actual indications for surgery? TSS, because a lot of the times TSS, the transfemoral surgery is done for microprolactinomas, which is not indicated.
Yeah. Usually the presentation is for the, they can either be due to hypogonadism or problems due to hyperprolactinemia leading to galacturia, and you have a hyperprolactinemia. To relieve that, beat straight. And the second thing is that either impending or having a presence of some neurological signs and symptoms of the tumor, let it be anything. And thirdly, for the infertility and sometimes even with the normal menses with mildly elevated prolactin, sometimes they'll have a luteal dysfunction. They also should be treated. So these are the conditions where we treat them. So fortunately, we have a dopa agonist to treat these conditions, and these are the tumors will, they melt away, we can say. So what are the indications? Even when there is a impending neurological problems, that is even for the, you say visual disturbance also, we can treat even in the macroadenoma also. So size is not the criteria for the micro or macro. Both the conditions you treat with the dopa agonist. In fact, okay, there are, in the textbooks we see, or in the guidelines, they say that the tumor more than 3, just who is presenting, young lady going for a pregnancy, you operate. Even them also, we have treated them with the medication and they have recovered very well. And even with the pregnancy also, we can give the medication. To tell you, obviously, there is absolutely nowadays, becoming lesser and lesser indications for the surgery. So then who are the people who should receive? The people who are not responding to your therapy. Usually, though more the size, more the secretion, they respond well. Some of them does not secrete, they doesn't respond, the tumors. That's one. And those who have got intolerance to the medication, or neurological things are not coming down, the size is not regression. Or there are conditions where we cannot use the medications, like in those patients who has got psychological problems and on antipsychotics, giving both the things may be a problem, then surgery is indication. Then the not responding, intolerance. The other thing is patient is not preferring for a surgery is another clear indication. Patient is not preferring for a surgery, you can go for it. Why all this thing is because, it is easy to scoop away microprolactinoma. Everything will go away. Recurrence rate is less. But it's a macroadenoma, it's very difficult to remove. The excise all the tumor. There will be some remnant. So, but the various studies have shown that, the recurrence rate is somewhere around 18 to 20%. Again, you have to treat medically. You cannot go for a resurgery and other things. So only indications for surgery is the characteristic preference. Even if there is an obstruction causing visual disturbance also, you can give a medical like that. Preference, not tolerating, not responding is the indication. Or psychiatric problems, both the drugs posing a problem is an indication for surgery. Other than that, we don't use.
Thank you.
And we got the drugs like, as you know, earlier we used to use bromocriptine. Now we're no longer using, now only cabergoline is the drug of choice. A simple drug, very easy to use. Side effects are very less,
and that is the used drug.
Fine. Thank you, sir. So, Dr. Santosh, you have a large referral base from gynecology and obstetricians, and I'm sure you come across a lot of, we'll focus only on female infertility with raised prolactin, and a lot of the times the obstetricians already start them on the cabergoline. So, what is your experience in this? I just wanted to know about.
So, if my genuine request to everyone is, if the prolactin is high, especially if it is above 50, please put an endocrinology consultation before starting on cabergoline, because the patient might be having certain other things which can be picked up. But yes, so for fertility treatment, especially as Dr. Vijay Shekhar Reddy has says, even if the prolactin is above 30, the periods are regular, no galacturia is there, and we have ruled out hypothyroidism as a cause of high prolactin, we still do treat with cabergoline because it helps in improving the luteal phase defects. So the luteal phase defects are lesser. The chances of becoming pregnant are higher if you use a low dose of cabergoline in these cases, even if they don't have any other apparent cause for this thing. PCOD per se causes high prolactin, we know that. And estrogen use during fertility treatment also increases the prolactin per se. So giving a cabergoline in this setting, I think we should go ahead because it's a harmless drug has been eluded.
Thank you for that. So we'll move on to the next topic, which is precocious puberty. We are seeing a lot of girls especially having early puberty. I wouldn't say precocious, but early puberty. The definitions of the age are changing. There is different age at diagnosis, for diagnosis recently. And this is important because early puberty also sometimes we tend to treat to affect the final height of the child and the psyche of the child. You know, you don't want an 8 or 9-year-old girl to have periods, although it is considered physiologically normal now. And so what are the definitions and when do we actually start to treat, and what is the guidelines and what is the normal practice that we do? So let's hear from the experts about these things. Dr. Santosh, I'll start with you first. What is the current age for diagnosis? In practice, when will you start treating this?
So by definition, still in India, we are following this cutoff. That is a girl who's developing breast budding before the age of 8 years, and a boy who's developing a testicular enlargement before the age of 9 years, we consider it as precocious puberty. So there were initial concerns whether we should actually lower the age for diagnosing precocious puberty. But there has been a study which has shown that if you lower the age too much, we may be, almost 12% of them might still be having some organic cause for GDPP. So less than 8 in girls and less than 9 in boys is what we still use for cutoff for the treatment for diagnosing early puberty. So increased incidence of early puberty is there now because of, the main reasons are in fact insulin resistance and increased obesity in young girls, leading to a premature activation of the hypothalamo-pituitary gonadal axis, and that's why the early puberty does occur. Now, most of the concern is now whether to do an investigation, whether not to do an investigation, all that problems will start there. But as Dr. Kalyan has just said, more than the final height. Now, suppose somebody develops a precocious puberty at the age of, say, 7.5. Very unlikely to have an organic cause for precocity, but still we go ahead and investigate and treat this child because we are more worried about the psyche. The child getting a periods at the age of 9.5, 10 years disturbs the child psychologically a lot, and obviously sexual abuse is another major concern for these children. Therefore, we still stick to that 8 and 9 as the diagnosed age for cutoff.
Thank you. Yeah, please go ahead.
Sometimes, most of the times we don't take that exact criteria of 8 and 9. But most of the times it is, what is important is the how tall, how can be, whether she remains as a short adult, sometimes is also important. A second thing is most of the time it's the parental concerns. And there is psychosomatic disturbances because of the body growth. All those things, to attend all these things we treat, sometimes at the age of 9, 10 also, we like to treat.
Yeah, absolutely. So please go ahead and further, once we've confirmed this is we want to treat, how will you then evaluate and and investigate and confirm precocious puberty?
The first thing is, the simple, the parameters which are important. The clinical parameters are important. We should stage the SMR staging should be done. Staging of if it's a girl and a boy, that should be done. And then the detailed examination, height is very important. Examination of the height is important. Then the look for the other secondary signs of any, associated, the heterosexuality, so okay. They should be seen sometimes, acne, hair growth and all those things, sometimes strain, all those things also should be seen. And the fourth thing is go for an X-ray of the left hand, that is more important. How advanced is the bone age, what we see. And then we should have a baseline LH and the sex steroids, either estradiol or testosterone. And then if you think that it's anything borderline, LH is 0.2 to 0.3, then you are still doubtful. You can stimulate with the GnRH analog and then see. The idea is to differentiate whether you are dealing with a gonadotropin-dependent precocious puberty or gonadotropin-independent precocious puberty. And then, based on that, the further evaluation. If it's dependent, then the evaluation is different. Independent, then the evaluation is for the matching with the other things.
Thank you. So Dr. Ravi, let's say this is a gonadotropin dependent. So it's just a early puberty. What are the treatment options available? Just in a nutshell, what is the treatment options available? Only one.
The question is here whether the precocious puberty is because of central or peripheral is the first question. Second is, as the panelists have clearly said, that even if the patient is having at 9.5 or 10 years, what is it the patient want? What do the family want? And sometimes reassurance and monitoring will always be helpful, because if the mother is too worried for her not to have her periods, then I think we need to address that. So the two causes that what we say is, what we use is, if it's a central cause, we use a GnRH leuprolin is what we tend to use to try and block the gonadotrophins and the peripheral actions, whether it's estrogen or testosterone. You could use that either a monthly, 3 monthly, or 6 monthly. If there are peripheral causes, like causing tumors, that needs to be taken off. Again, hypothyroidism is commonly being seen, and that needs to be addressed. So the key things is what's causing it, maintaining the height chart, checking for LHFSH suppression, and speaking to the parents again and again is the key in the success of precocious puberty. There is a lot of anxiety in the clinic. That needs more addressing than the physical. That will come later on. But people understanding precocious puberty from where they're coming from, remote villages, is far, they don't get that. So I think that's where counseling starts first, investigation second, start the treatment, and what is their expectation, and where we can go with the treatment is what I would say.
Thank you.
More or less.
You please answer.
Yeah, just sometimes the most important is some isolated events should be differentiated. This is what is most important. That can be done by the bone age, and then also by the evaluation of the uterine sizes and ovarian volumes. They are also important in the evaluation.
Yeah. So what Professor was saying is there is isolated thelarchy and isolated thelarchy, isolated adrenarchy, which means axillary hair, breast bud happening, but without the advancement of bone age is not considered precocious puberty. And we can wait and see. Only if the bone age is advanced, then we can start to evaluate for the precocious puberty. Thank you, sir. So next topic is about adrenal incidentalomas. We all know that there are a lot of CTs and MRIs being done for whatever reasons. And as endocrinologists, I think you will agree, sir, the surgeons do it for a CT of the abdomen for pre-surgical workup, and they find that there is an adrenal incidentoloma. They stop the surgery, send it to us. And these are being found more, especially before surgery, whether to investigate this or not, and if so, what investigations should we do? What are the biochemical and what are the radiological investigations to do? So with this in context, let's ask Sir Professor Vijay Shekhar Reddy. Yeah. In routine practice, what is your are you seeing these incidentalomas regularly? And if before surgeries, what is your context?
Yeah. When we actually want to look for the adrenals, nobody used to report about the CT of the adrenal.
And when there is tumor detected, then there will be a referral to you. And usually, as per the definitions, more than 1 centimeter is the definition for the incidentaloma. So there are two things which are important when we see a tumor. One, people are concerned about the malignant potentiality. And second thing is the functional potential. whether they are functioning. These are the because these are the two things where we have to intervene and give the treatment. So as you know, they're very commonly seen. Now the incidentalomas prevalence is anywhere from 7 to 12 from various centers at various settings they do. And among the incidentalomas, again, the malignancy is only 2 to 5%, 2 to 4% or something, very less. So our ultimate aim is to find out whether you are dealing with whether it has, how much is the malignant potential depth. Of course, clinically also that is very important. Clinically, if they have females have a signs
androgenation, then we should also think in that line first of all, and then start investigating for the
testosterone, DHEAs for a female. And in a male, we have to look into the other things. Imaging, both the male and female. So the imaging modalities will tell you whether you are dealing with a benign or the malignant condition. The most important is the size. What they say is 4 to 6. More than that is a malignant. But we have reported long back to me and Sudhakar Rao in 2011 in the endocrine conference, European Society of Endocrinology. 13 centimeters mass, a benign lesion. So that alone criteria may not be a thing. Size is always taken, but size more than, you don't know. You are dealing with a malignancy of 2.5 centimeter also. It's growing. You don't know. You're just seen at that point of time. So what is most important is the monitoring. Then the borders of the mass. Then the homogeneity or heterogeneity. Any calcifications are there. Then the most important, the washout. The absolute washout and the relative washout. It should be washed out. And if it's washed out, it's a benign lesion. If it's not washed out, then it's the malignant lesions. This is one thing which we go about. And the second thing, as I said, is the functionality. Hypercortisolemia, sometimes subclinical hypercortisolemia will be there. Then do the, as usual protocol, what you do for the Cushing's, you should do to detect, the hypercortisolemia state. Dexamethasone suppression tests and all those things. Then usually aldosteronomas are very small tumors. They're not big tumors. They're usually less than 1 centimeter tumors. We can easily, in presence of things, we can easily find out. Clinically also we can make the difference. Yeah. Usually they're not big tumors. So this is how we go about, and our aim is also to find out functionality and this thing, so that we can take an appropriate manner. Sure. Then usually sometimes we get a bilateral things. Only certain conditions where we have a bilateral, sometimes metastatic, sometimes rarely fungal lymphomas, or usually in a macronodular hyperplasia, SCH, and all those things, they'll have a bilateral.
Sure. Thank you, sir. So, Dr. Ravi Kumar, so if, let's say, first of all, do we have to investigate all adrenal incidentalomas? If so, how do we start biochemically? First, biochemical, right?
Yeah. So, I think with the invention of adrenal adenomas, endocrinologists have become more active. So we got to look for, as to say, is that are we looking at something benign? Are we need to be worried or not is the first question. As Professor Vijay Shekhar Reddy said, I like to do it in 2 ways. If the adenoma, what's the size, what's the washout, and what is the functioning? So we've talked about the size and washout, and we're talking about whether it's a functioning one. So is this going to cause problems? So there are 3 or 4 endocrine causes that needs to be, the general practitioners or anyone need to be aware of. First is Cushing's. So you could do by doing an overnight dexamethasone suppression test. If the patient has got Cushing's and adrenal adenoma, refer to the endocrinologist. Second, hypertension. So a simple test of hypocalcemia and hypertension and adrenal adenoma, it could ring bells that it could be a primary hyperaldosteronism. So do a renin-aldosterone. Third, someone with hypertensive crisis with an adrenal adenoma, could this be a fear? You would think of doing serum metanephrines or urine. And 4, if you've got a virilized female with adrenal adenomas, is these functioning tumors? So if you put these 4 classically, these basic investigations will try and divert you where these patients could land up to. If none of them, then most of them will need annual monitoring of the adenoma if it's non-functioning. How long would you follow up? Is there a data? But usually what we do is up to 5 years. But after that, what happens? If there's no growth within the 5 years, it's less likely not to cause any problems. But then mind you that we are subjecting the patient to CT radiation as well. So there's always a chance that you have to pick up as to say, what is it important in this patient? So that's what I would investigate and monitor in my patient with adrenal adenomas.
Thank you. So that is the biochemical aspect of it. Dr. Santosh, if we then look at the radiological, I mean, a lot of the CTs are done as a plain image without very much focus on adrenal. So what should we ask the radiologist? What would an adrenal protocol CT involve?
So to tell you that in 2007, this was a 10-mark question in my DM. So now I have to answer that in 1 minute. So yes, so first thing we look for the size. As has been said before, a size greater than 4 centimeter is more likely to be malignant. So we have to be more proactive in investigating these cases. The second is the Hounsfield units, or the intensity of the signal that's coming. Anything which is of low intensity, 10 HU or lesser, will be more likely to be a adipose tissue rich tumor. So it's less likely to be benign basically. So if anything is having less than 10 HU, it's likely to be an adenoma, adrenomyelolipoma, etc. Now the third thing that we look for is a contrast washout. So what does a contrast washout means? After giving contrast, you do a CT scan in the first minute and then you do it again in the after 15 minutes. If there is a contrast washout, that means if the contrast has taken up by the tumor in the first minute, but after 15 minutes it's not there, it's more likely to be adenoma or benign. If the contrast gets stuck onto the tumor even after 15 minutes, it's most likely to be malignant, especially pheochromocytoma seems to be the major part, and other malignancies, adrenal adenomas, etc.
Good, well done. 1 minute. Thank you. So in the interest of time, we'll not take the fifth question. And thank you all the panelists for answering these questions. Thank you very much.
Thank you, doctors. It was a very wonderful, informative session. And here's the end of Trilog sessions. And one announcement, we have quiz competition at 5 o'clock. I request all the PG students to enroll for the quiz. It is with a team of 2 persons. You can register at the last desk, which is present at the entrance of the conference hall. And we are moving to the next session. Next panel discussion is on Towards a Healthier Nation, Integrating Prevention into India's Healthcare Landscape. I invite panel moderators, Professor Dr. Rakesh Sahe and Dr. Shyam Kalavalpalli onto the dais.
I invite Dr. Shyam to join me here. So we have great pleasure in inviting the panelists, Dr. Hemlata, who is the director of NIN, National Institute of Nutrition, which is an important organization of the Indian ICMR, and she's also currently the president of the Nutrition Society of India. She's an executive committee member of FANS, and she's also the chairperson of the National Committee for International Union of Nutritional Sciences. And more than everything, she's also been the chairman of the recent guidelines that were brought out, the nutrition guidelines that were brought out by NIN. So welcome, madam. Then we have with us Professor Sarang Dio, who's Professor of Operations Management at the Indian School of Business at Hyderabad. He is also the Deputy Dean, Faculty and Research Executive Director at the Max Institute of Healthcare Management. His research mainly focuses on healthcare delivery systems and their impact on health outcomes, including the work on vaccine supply chains, ambulance diversion, and TB diagnostic pathways. He holds a PhD from UCLA Anderson and MBA from IIM Ahmedabad. So welcome, Dr. Sarang. We also have with us Dr. Santosh Kumar Kraleti, who's a senior public health specialist. He's the founder and CEO of Foot Soldiers for Health. He's professor and associate dean at the School of Healthcare, Rishi Hood University. He holds several honorary positions also. Welcome, Dr. Santosh, to this panel discussion. And then we have with us Dr. Vikram. Mr. Vikram, rather. He's the founder of NephroPlus, which has been founded with the aim of transforming healthcare in India. Vikram is, before NephroPlus, he was a strategic consultant at McKinsey and Company in New Jersey and founded an internal consulting group at Abbott Laboratories. So he has a MBA, Master in Computer Sciences from University of Illinois and MBA from University of Chicago. So welcome, Mr. Vikram. We also have with us Dr. K. Sambasivaya, who's a medical oncologist who was graduated from Tirupati, did his post-graduation at AIIMS, New Delhi, and did his specialization in oncology from Chennai. He's founded the Cancer Center at SWIMS Tirupati, and he was also the professor and head Tata Cancer Hospital at Varanasi. Currently, he's the professor and head of Tata Cancer Hospital at Varanasi. So welcome, Dr. Sambasivaya. So I'll invite Dr. Shyam to join me here, and probably we'll start off asking to give a brief overview of the journey of diabetes and its foray into preventive healthcare. Because we are trying to focus in this panel discussion on what should be the direction for preventive healthcare in our country.
Thank you, Rakesh. Welcome all. We are expecting the IT minister to join us shortly. But briefly, let me explain what Idea Clinics is all about. So we started Idea Clinics a few years ago. We are into preventive healthcare space. So end of the day, when you look at human life, quantitatively and qualitatively, our life expectancy is increasing, but however, compared to the Western counterparts, we are exposed to premature deaths. Life expectancy is reduced by almost 10 years. So Idea Clinic's motive is to help people live longer and also quality of life. We should, as long as we are alive, we should be healthy. So the problem right now is healthcare is predominantly very reactive. We are damaging our organs, and it's hospital-based. Hospital-based is nothing but real estate-based. With changing times, with lot of technologies taking over, the future is more of technology replacing real estate. So it's more of proactive, preventive health. That is where the future is. In that context, I thought we'll have a panel of experts, some from, people from nutrition side, people who are experts in management, somebody who has a lot of experience in cancer care, somebody with entrepreneur skills, scaling up, dialysis centers. And after all, we have none other than Professor Rakesh Sahai. We are proud that he belongs to Hyderabad. He is the president for RSSDI, the biggest research society for study of diabetes in India. He is also a professor from Osmania. So under his leadership, we are trying to talk about this concept called how can we keep the nation healthy. Thank you.
I think, Dr. Shah, we all know that from the recent report of the ICMR INDAB study, we have a huge burden of metabolic disorders and non-communicable disorders. We know that we have a burden of about 100 million people suffering from diabetes, and a larger number, about 136 million people having pre-diabetes, and these people are the ones who are at very high risk of converting to diabetes, and they also are at very high risk of having the cardiovascular complications of diabetes. And we know that, globally, while the conversion rates may be slightly lower globally, but we have at least 4 times higher risk of these people progressing to diabetes. So it is important that we address this issue and see that we are able to prevent them, from developing diabetes. Otherwise, the burden of diabetes is going to further increase. And we know the burden of diabetes because of its complications, all the complications that happen because of diabetes, the nephropathy, the renal disease, and the cardiovascular disease, and retinopathy. Also, we are going to discuss a little about that in the afternoon also. So I think, the aim therefore should be, and when you look at the other comorbidities along with diabetes, we are aware that there are about 250 million people with hypertension, a larger number of people with obesity, and when you look at central obesity, number even goes up to about 350 million people with all these problems. And diabetes, hypertension, and obesity are probably the major factors which contribute towards the development of cardiovascular disease. And we know that we tend to have a disease burden which is different from that in the Western world. We see that we tend to have diabetes and cardiovascular disease occurring at least a decade or two earlier in our population, and we tend to have certain differences in terms of having these problems at lower BMIs. And with the growing burden of obesity that is adding on to this huge burden of problems that we are facing. So it is therefore imperative that we should focus our attention towards prevention. While we are providing the best care, we should also look at prevention. And so I would like to start off with asking Dr. Santosh about what are his views on what are the initiatives being carried out both by the government and by the non-governmental organizations in terms of these addressing this huge burden of non-communicable disease or metabolic problems that we are facing.
Right. Thank you, Professor Rakesh Sahai. First of all, a huge round of applause and congratulations to IDEA for holding this year after year and then bringing back to our board how important prevention of NCDs is, and also having this topic of towards a healthier nation. So it's not just about treatment, but about prevention. As a public health specialist, our core, one of the most important Bhagavad Gita documents for us is the Family Health Surveys. And the National Family Health Survey 5 data speaks for itself, as you rightly said, that the burden of disease is so huge. So if you look at the diabetes, according to the All India figures, 17.9% of people in urban areas are having diabetes. 26.6% of the people are hypertensive. And apart from this, Telangana has a very rich heritage of alcoholism, coupled with all of this, which is around 43.3% in men. And of course, women also, we score the highest of 6.7% of alcoholism. So if you look at the stats, it's huge. 26% of the population is hypertensive and 18% is diabetic. Probably you have an intersection set somewhere around of 22, 23%. Now, and of adults who are above 15 years. So government can do only a little bit. Now, if you look at the Indian health scenario, 70% of the outpatients come to private clinicians, and 30% of it goes to the public clinics. Now, if you look at the public hospitals, there has been a very aspirational aim and objective that we want to set up NCD clinics, which is according to the NCP-CDS, the vertical of the National Health Mission. But out of the 35 states, we could set up only in 24 states till now. NCD, state level, resource center. And if you look at the districts, out of all the districts, we could set up only in 42% of the districts. And if you look at sub-district hospitals, PHCs, CHCs, we have been able to just touch 14%. So setting up or driving anything through public system itself has now reached somewhere around 14% at the primary level and around 40% at the district level or the medical colleges. So if you look at how much people we are able to serve, if you look at this, probably it is going, it's very minuscule. We are not able to screen even 1% of the population which has the burden. So where do we screen the rest of the people? So I think a bigger chunk of this prevention needs to be taken up by corporate, private, single clinic, and also not-for-profits. All the people together, along with government system, needs to work on prevention. and without taking into picture each and every clinician and also every individual on board who is in the health system, NCDs cannot be prevented. It's not just a government system's job, but I think anyone who is a healthcare worker needs to be a part of the NCD prevention. Otherwise, this is going to be a very, very big phantom in the room.
Yeah. Thank you, Dr. Santosh, for highlighting the fact that prevention is important. Prevention is very easy. Prevention is not that. Prevention is a very difficult aspect. Prevention requires just education of the public towards adopting healthier lifestyles, and screening early screening and identifying problems early, and adopting a healthier lifestyle. I think those are the major aspects about prevention, but I think it is as you have rightly highlighted that it's not just the government which can take care of all this, and it should be taken up by it should be a public-private partnership. Everybody at every level should be looking at prevention, and so to bring in that aspect, I would like to quickly get in Mr. Vikram and ask him to speak to us about. He's been running a chain of dialysis centers which has become very popular across the country, and they have been in a public-private partnership also, and how they have scaled up to a huge scale. So I would like to ask him two things. I would like to ask him to give us a quick brief this thing about his journey so far, how he has, how this was set up, and also tell us whether you are looking at any preventive aspects in this, because prevention is very important while you are providing dialysis services, but you need to look at prevention. It cannot be that you can expand to an extent that you keep providing dialysis. So we need to look at preventive aspects. So I would like to ask him to address both these issues.
Sure. So my name is Vikram. We started Nephroplus about 15 years ago. The co-founder is himself on dialysis for the last 27 years. And he is the central theme of the company on how to make lives of people on dialysis more normal, meaning more traveling, more working, more going out, just like normal people do. So Kamal has been instrumental, and we started in Hyderabad with the first outpatient standalone clinic. Then we kept on growing. We did 6 rounds of private equity. World Bank is a shareholder in Nephroplus. Bessemer Venture Partners Invest Corp. Today we run 450 dialysis clinics across 260 cities in 4 countries. So it's been a phenomenal journey. I think very, very satisfying, wherein you are transforming the lives of these people on dialysis. We do 4 PPPs, large PPPs in India: Karnataka, Andhra, Uttarakhand, and Bihar. And we also do serve PPP projects in overseas markets like Philippines and Uzbekistan. And now this month we are entering Saudi Arabia. So I think from a journey perspective, it's been phenomenal. We have been incredibly lucky, I would say, to keep raising private equity and keep growing. Just put our heads down and keep growing. But I honestly think that India does not have the money to take care of so many people on dialysis. India is 138 in per capita income, while on a GDP, gross domestic product, we are the 5th largest. India is not an affluent country, 138th in per capita income. If many of these diabetics and hypertensive come into kidney disease funnel and then get into end-stage renal disease, India does not have the money to pay for dialysis. And throughout the world, people on dialysis could only get government reimbursement because it's an incredibly expensive modality. So prevention is actually a no-brainer. It's essential. But I disagree with Dr. Santosh in terms of the government's role. Private service providers or any private firm will not do anything on prevention unless it becomes part of a for-profit project. The government, because it's going to look at the long-term benefits of the population, they have the best PR machinery, they have the best access to funds which will help in prevention, while the government should also push the private service providers to invest in prevention. What do I mean by that? For example, if it's a dialysis PPP in, let's say, state of Andhra Pradesh, the state of Andhra Pradesh should force the service providers who are delivering dialysis services to also bundle it with preventive services, do camps at certain volume and certain frequency, identify people in early stages of kidney disease to prevent them from getting into the end stage disease. But if you're expecting any service provider, any private firm to do it out of own charitable behavior, it's not going to happen at scale. There will always be few exceptions here and there, but it will never happen at scale. I believe government has a massive role to play, which it's not playing in India. And I see this overseas as well. It's nothing to do with India as a country, but government has the massive role to play. Firstly, in investing on its own. Secondly, in forcing private service providers to create the projects or initiatives which private service providers have to be forced to deliver. No private service provider will deliver out of its own charitable behavior. I'll pause there.
Thank you, Dr. Vikram. Highlighted the fact that prevention is doable, but needs to be, sort of directed by the government, channelizing all the resources from, from the NGOs and from public-private partnerships that they already have. And I think, we'll discuss more about that. But I would just like to bring in the important role of nutrition today in terms of, in terms of causing these NCDs. We know that it is, nutrition is a very important factor when looking at the changing lifestyle and the changing nutrition habits, the eating habits of people. That has probably contributed significantly to the growing burden of these problems, the growing burden of obesity, and we are seeing childhood obesity also becoming very prominent. And we have a lot of data which has also looked at, we have studies from Dr. Yajnik and his group that have looked at maternal nutrition, and they've highlighted that, and that is also, we all aware of this concept of developmental origins of adult diseases, where we say that, the maternal nutrition has a very significant impact on the, offspring's development of adult diseases which happen, the cardiometabolic disorders. So we are very lucky to have with us Dr. Hemlata, who has been part of the guideline. She led the guidelines, and they were recently released about the nutritional aspects for Indians. And so I would like her to speak a little about that, tell us about what are these guidelines speaking about in terms of the maternal nutrition, how to improve the maternal nutrition during pregnancy, and also about the various aspects of this guideline.
Yeah. ICMR National Institute of Nutrition as one of the important mandates of producing dietary guidelines for Indians. The first one was produced in 1998 and later in 2011. But the scientific evidences and the material that were available those times were different. In the last 1 decade, all of you know how our food systems have changed over the years, including the agriculture, the eating patterns, food habits, right from urban areas, cities to rural areas also. It has changed a lot. If you go to any corner of tribal regions or villages, any remote place, you would easily find biscuits and many processed foods available. But fresh vegetables and fruits will be hard to find, and they'll also be very expensive. So in that context, although we know that there is a clear association between dietary intakes, and dietary intake plays a key role as a determinant of health. However, there is no precise information on how much, what foods to be taken and how much quantities to be taken to promote health and prevent NCDs. That way, the dietary guidelines of Indians have been produced, and it was released on May 8th recently. It was developed over a period of 2 years. About 14 different experts worked on it, and we also took expertise from other parts of the country, like external experts also evaluated this. So this has very beautifully described all the vulnerable age groups. It has covered right from fetal age to young children, infants, young children, across adulthood and old age also. And this, the guidelines also include very beautifully what is unhealthy dietary practices, the meal frequencies, including what do you mean by unhealthy foods. So far, there is no definition in the country. Globally also, there is no proper definition of what is unhealthy food, but we dare to define what unhealthy diet means. So using this, the Food Safety Standard Authority of India also can come up with regulations, appropriate regulations, and define and put conditions to the food industries on how they should label foods. Because, compared to rest of the world, in India, the dietary habits are extremely poor. For that matter, 56.4% of the disease burden that we see in India is related to unhealthy dietary practices. And you will be surprised to notice that even smoking, alcohol consumption, and air pollution come later after unhealthy dietary habits. So unhealthy dietary habits is quite common, and the increasing epidemic proportions of diabetes type 2 and hypertension that we see is all mostly related to unhealthy dietary practices. If you follow a healthy dietary practice coupled with good physical activity, which is, lifestyle, you can prevent almost all the lifestyle diseases, including cardiovascular diseases, stroke, heart attack, and 80%, nearly 80% of diabetes type 2 can be prevented. So it's almost in our hands to prevent these diseases. And as pointed out by the earlier speakers, I would say that there should be a long-term commitment from different stakeholders, government, private, including the communities, individuals also, including the food industry as well. Unless all the stakeholders, different sectors, private and government, all of us come together, it is very, very difficult to come up with a strategy and pull out all the resources and infrastructure to improve the preventive healthcare in India. Right now, at this point of time, preventive healthcare is extremely bad in India. Even the National Program for Prevention of Diabetes, Cancer and all, they focus on screening and early diagnosis, but where is the strategy to prevent?
Right.
So we have a immense scope to prevent these diseases once we get into the community and once all the stakeholders come together and come up with a good strategy.
Thank you, ma'am. Thank you. I think you have very, very rightly brought out several important points, like, that we don't have to focus on only those who are screened and identified to have pre-diabetes. It's the general community which has to be, they should be educated about the eating habits. And she also highlighted that 54% of the burden of NCDs is contributed by unhealthy eating habits, and also she also said that 80% of diabetes could be prevented by just changing the dietary habits. So I think that's very important aspects that have come out from the research that has been done and the guidelines that have been released. I think I would like to now take in the help of Dr. Sarang Deo to understand. Madam has also highlighted that there's need for getting everybody together, getting the government, the non-governmental agencies, the individuals concerned, and also getting everybody together and seeing that they understand this aspect, this importance of prevention. So could you tell us something about how this could be done? Could you give us some insights into that?
I'll try. Can I ask a few questions to the audience just to understand?
Yeah, please.
It's also getting close to lunch, so maybe some some energy interaction will help. Can I get a raise of hands? How many people here come from a medical or a clinical background? Not just doctors, but broadly clinical medical background.
Almost everybody, I suppose.
Excellent.
Almost everybody.
So if there was any way that we could prevent all endocrinological disorders, prevent all of them, what would you think about that? From tomorrow, no endocrinology disorders whatsoever.
a little different perspective about understanding, how you need to drive this aspect, drive this awareness about prevention, because people, they may not be implementing that, and how we need to change their behavior into implementing that. And you also brought in the role of insurance, because insurance today is covering only things that are like managing a problem, that too when somebody is admitted into a hospital, and not even looking at reimbursing the outpatient care. So going into prevention would be a big step for that, and I think that is a important area that we have to look at, and that has to be. We'll have some views from Dr. Sambasivayo, who's into cancer care, because that is again a area which, where there's huge expenditure in terms of treatment, but prevention is possible. So let us hear from him what he has to say about this point. About what we're discussing.
Thank you, Dr. Zahai and Dr. Sham. Yeah, pleasure to be here with enlightened and esteemed panelists. The healthier nation, it means that before developing a disease, so before a society walks into a hospital, how to retain and preserve and protect, that is the crux of the theme and the slogan behind, the prevention is better than cure, is immortal one, right? So, but we have two great examples since independence of polio eradication and smallpox eradication. This being the virus-induced responsible etiological factors, we developed required, you need to be alert. You need to get to the schools, youngsters, and train them, and enlighten them, give them awareness about these things, have the attitudes. That's where they pick up tobacco. So without realizing the tobacco related, it's not just cancer. It causes a plethora of diseases, all of them NCDs, right? So then the obesity, we used to, during
across the population, and to see that we
Two questions you have.
yeah.
One is regarding awareness also. Many people have misconception that all of us are aware of what healthy diet means. Actually, most of us do not know. Even those who are working in NI, 50% would not know what healthy dietary habits mean actually. So here we have laid out certain principles, what healthy dietary habits mean. Like for example, right proportion of cereals and pulses. If you know a cereal, if you take a diet, always it has to be accompanied with pulses, appropriate proportion, that is 3:1 we have made, to get good quality fiber and protein. And along with this, adequate quantities of vegetables. Every meal should be accompanied with vegetables and fruits to improve your micronutrient status and also increase your fiber. Now, if you think that you know everything about good diet, how many of you know how much vegetables one has to take, minimum levels of vegetables to keep oneself healthy? Many of you may not be knowing, and even if you know, many of you would be consuming hardly 150 to 200 grams of vegetables per day. I am telling the upper limit. But we have to consume minimum of 400 grams of vegetables per day to keep ourselves healthy. I'm not saying people with diabetes. I'm saying even if before you get diabetes, and at least minimum of 100 grams of fruit. This has been shown by Cochrane reviews, and 142 studies, meta-analysis also showed consistently that single intervention of vegetables, giving higher quantities of vegetables, could prevent, it has reduced 25% relative risk of cardiovascular diseases and also certain cancers. So when there is so much evidence around the globe, we tend to ignore these evidences and do not follow healthy diets. Coming to other principles, like you asked about pregnancy and young children also. So in this guideline, we have dared to say no sugar for children under 2 years. Because when this is followed by most of the other countries in the world, in India, all the baby food formula makers push a lot of sugar in the formulas. Now it is time we wake up and see that our babies get right food and there is no sugar, because sugar is a highly processed food which does not have any nutritive value except for calories. At least they should not be exposed when they are very young. Even for adults it is harmful, but at least under 2 children should not get any sugar. So we have mentioned this in our guideline. And during pregnancy, for your information, this is very important. Like we have this 1000 days program devised by our government of India, right from conception to 2 years of age of the child. But we from NIM, we have devised a guideline how a woman, before she enters into conception, before she gets pregnant, her health status and nutrition status should be optimal, so that the growing baby in the fetus has good nutrition and does not have higher risk of non-communicable diseases. Because the non-communicable diseases that we see in adult life is a cumulative effect of bad nutrition right from fetal age and young infants, children and adulthood. So right from the age when when the baby is conceived, right from then we need to have good nutrition. Why it is important to have a good preconception nutrition status is all the cells are rapidly multiplying. There is hardly any time for the mother to cope up with the right nutrition. So unless she is properly nourished and healthy, she cannot give proper nutrition to the growing baby. So that way we have given a lot of emphasis for preconception nutrition and young child feeding practices, and we have given menus and all. And as I have already said, we have dedicated a guideline totally on protein, because protein has become a big myth and fancy for many youngsters. Those who go to gym or do not go to gym, they want to take a lot of protein, which is not required and which can cause adverse health risks.
Thank you, ma'am. Thank you for giving us those insightful points about the guideline that has been developed. I think the most important thing is to see that people are aware about this guideline and they are able to use it effectively. And I think one of the ways is to use technology for spreading the information on this guideline. Maybe you should develop an app which has that, which everybody can have it on their phone, because everybody has a cell phone now and they can probably use this. They have so many apps on their phone which may not be, many of them may not be useful. So I think if we develop an app from NIN on this nutritional guidelines, and that is good for the general public more than those who are with the disease, I think that can actually give us more help in following a good eating habit. Dr. Santosh wants to say something. I think he's going to tell us something about how he would propose that this guideline is disseminated to all the people and how we can change behavior. We'll also ask Dr. Sarang also how he feels that we could change behavior of people in terms of healthy eating and following a active lifestyle. Because ultimately, those are the two things that can actually make a huge impact. And other thing I would like to also appreciate what Madam has said about the sugar intake. I think one of the harmful effects of sugar in early life is probably it's very addictive also. So apart from not providing any benefit, it is very addictive and makes people addicted to that, I suppose.
Yeah, so I just wanted to give a disclaimer, though my name is written there as member of National Medical Commission, I don't belong to government and I belong to the private sector. So I'm a part-time member of NMC representing the private sector. So having said that, the other most important thing that I want to flag, and what ma'am also has very eloquently raised, we started a chain of milk banks called Dhatri Mothers Milk Banks. Now currently we are running 12 and we are going to start 37 more this year. Exactly for the same reason is that we need to have breast milk available for all newborn and infants. And we run all these milk banks in government hospital, especially wherever we see formula feeds. That's where we are seeing a lot of childhood obesity, a lot of hypertension, diabetes in early childhood. And this is something which we are working on. And another important thing that I want to flag, which even Professor Sarang has raised, about the behavioral change. Now, there is a very interesting book called Ikigai. I'm sure many of you would have read it. And there's a very interesting study called the Okinawa study, where 600 octogenarians have been studied. I'm sure many of you know that. The 5 most important things that keep these people alive, healthy, and what Dr. Shyam was saying, the quality of life should be very good apart from being alive, is 5 things. Number 1, they have a very, very good social network. They have friends. They talk to each other. They meet every day. And it is really, really important. Second thing, all of them do farming till the last date. They are alive. They are very active. Third thing, they eat a lot of sushi and fish. Fourth thing, they have green tea. And fifth, all of them in Okinawa use chairs which are much, much lower than this. The height of the stool is this. So they sit down, they get up. So the proprioceptive and all those joints, everything are working well. So the point is, these 5 points are the key outcomes of the study. And this is what we really need to bring into the whole system. So it's not just the onus of one system or the other, but the larger community that we are going to. And in Singapore, for example, they have something called the National Health Promotion Board. I agree with Mr. Vikram's point that government needs to take the ownership, but what can be driven is the industry, the for-profit, the not-for-profit, driven by government's will, should actually drive something like a National Health Promotion Board or something. And I'm sure Hyderabad is a great place to set that up. Idea clinics can take a lead, ISB can promote, something where the intersection of data, for example, NCD clinics are doing testing, but all the data is being noted down on papers. We don't know what's happening. We don't know data. We don't have analysis. So the IT which is there in Hyderabad must be married to the clinical system that is there. And then the industry must come together with the government. And then we need to set up something which does a lot of work on prevention, which is, again, out of the box. We need to have marathons. We need to have cyclothons. We don't have a lot of activity on that. So
Thank you, Dr. Santosh. I mean, you highlighted the importance of getting together people and also using technology to sort of drive this. So I would actually like to mention that, many organizations like the RSSD, I'm currently the president of the RSSD. RSSD today is having more than 12,000 members, which is more than what the ADA also has. So it is probably the largest organization in the world dealing with healthcare professionals dealing with diabetes. And we are committed towards improving awareness about diabetes, and we have district coordinators in every district, and we are adopting at least 1 or 2 villages in every district to sort of carry out these activities of screening for diabetes and other NCDs and increasing the awareness and carrying out awareness activities. So this is how organizations like professional organizations also could contribute their bit, and as you said, we should have a single sort of coordination between all these bodies and somebody coordinating that and using information technology. And to that end, I just wanted to also mention one fact that RSSDI, realizing the importance of technology in improving health outcomes. We have partnered with, we have set up a RSSDI Koita Center for Digital Diabetes in IIT Bombay, and we are working with to bring together technology and clinicians and all this to sort of bring about change, because there are so many apps available today, so many things happening in the technology space, but that is all unregulated and nobody knows whether we knew which one to use and which one is going to really set up a sort of group which can certify these apps and tell people that, okay, this is what you can use and this is what is going to be good for making a difference in terms of the outcomes. Audience, one or two quick questions because we are running out of time. Yeah. And then we'll have everybody giving their final comments on that.
Growth of the industry, share market, money. No article of Vikram, only Hemalata article regarding healthy diet, non-healthy diet. For 1 month, all social medias, all newspapers, then think about Indian mind and study. Santosh, you do a behavioral science. After 1 month study, you can see a lot of changes. India is a great country, Bharat is a great country. Only we are not properly addressing the issue. We are making confusion.
So thank you, Dr. Srinivas. Yeah, I think the suggestion is good that we need to focus on health. Yeah. Yeah, focusing on health is important. Yeah, one, Maher Prasad, quickly, what comment you want to make? And then one comment from Dr. Vijay Shekhar Reddy, and then we'll take the final comments from all our panelists because we are running out of, everybody's hungry now.
Yeah,
I think, yeah.
I understand we're all humans, and what I take the point which Mr. Vikram said, what might help, I think, in my view, practicing as a endocrinologist and focusing on behavioral motivation and stuff, incentivizing, healthy habits from the government and also from the insurance people, like reducing the insurance issue.
Certainly, yes, I think that's a very important point about incentivizing healthy habits, and this should be across different sectors. Dr. Vijay, quickly.
I'll make very quick one point.
Yeah,
See,
yeah. No, we want to come back to you for one final comment from all of you. Yeah, Vijay, quickly, your comment.
I just want to make a comment, please. See, many of the determinants of health are not there in the hands of the health
Many of the determinants
are not in the hands of
health, like good housing, good water, good health, space, walks. They're not.
Yeah, so I think that point is made by Vikram.
Of the doctor. So he only thinks he has got intention, but no execution for us.
Exactly.
So the entire environment has to be sort of in a way that it promotes health. That's what he says, that government has an important role to play in, at least in planning this out. So we'll come back and take.
Solve all the problems. The app is going to add very little, even if you create one. The government should take the initiative, incentivize food producers to produce healthy foods, market them, and also put subsidies on that, and prohibitive tax on unhealthy foods. These things, and also they have to, finance and improve the logistics of small farmers and local food business in local small. There are whole lot of dozen strategies that should need to be implemented, and for that it is not just one sector, it should be throughout government, private, food industry, communities, individuals, everybody has stakeholders, and we have to, all of us, come together, understand the perspectives of each other, and then develop the strategy. And it takes time also. It is a coordinated efforts between sectors and a long-term commitment for any behavioral change towards healthy habit and public health.
I think those are the points. Thank you, ma'am. I think those are the points that were being made by Mr. Vikram also. He was highlighting that government has an important role to play, although other stakeholders also may be important, but government has to sort of address this issue. And I think Dr. Sarang also brought out this important point. Yes, yes. So we'll come back to Mr. Vikram and have his views on
I
this.
want to make a second comment.
Yeah. Okay, we'll take your comment and then come back to Mr. Vikram. Yeah.
these are
Meanwhile, may I just announce that our chief guest for today, Mr. Sridhar Babu Garu, who's the Honorable Minister for IT and Commerce and also Industries and Commerce and Legislative Affairs, is just going to arrive, and we'll have him with us on the panel for a couple of minutes when we ask him these issues about what we're discussing and for the lamp lighting. So we'll continue the discussion for a few minutes while we're awaiting him. Yeah, please go on.
Yeah. See, we are telling that we have got a lot of food, but we cannot feed our own people. One of the examples. See, for all these things, what is more important is humanness. See, we are living like animals. We lost these human values. The humanness is what we have to develop among ourselves. That's second. How to develop, how to go about. I think probably some introduction of some programs at each level, right from his schooling, graduation, every 3 years. You go for this training 10 minutes, you'll get 10 marks. You'll get 10 marks. Then everybody will be going. Every 1 year, 2 years, 3 years, for everything you give it. That's enough. I don't think so you should do anything else other than that. Everything is a piecemeal. Attending to each and every problem like a compulsive attitude. No, even if I don't eat for next 6 hours, nothing will happen. But food is kept, I have to eat. See, this is what is the compulsiveness we all have. So
Thank you, Dr. Vijay, for your very good, very useful points that you brought out. I'm sure Dr. Sarang is looking forward to address that point. We'll come to him after we hear from Mr. Vikram.
Yeah, I actually don't believe that human beings can help themselves. According to the famous historian Yuval Noah Harari, he said that there is a primal instinct in human beings from the hunter-gatherers era where you load up. Whenever you get access to food, you load up. That primal instinct is a killer instinct. And human beings like all of us, when we go to a wedding, when we go to a luncheon, there is a primal urge to load up calories left, right, and center. It's wired into our DNA. I think there's other stakeholders, the government, because the government is the one who is going to spend whole lot of money in managing diabetes, in managing hypertension, cardiovascular disease. The government has a vested interest to keep the health at play. But if you are looking at food industry, which is an evil industry of any standard, who are giving extra sugar and Cerelac to infants, right? Expecting them to behave well like Nestle, it's not going to happen. It's the other stakeholders in the ecosystem who are looking at the long-term damage and the money they have to spend to manage that damage. Only they have to act. But it's unfortunate that everyone is looking at it from a short-term perspective. What's the benefit next year? What's the benefit next quarter? What's the benefit in 2 years? Rather than investing in 10 years. And it starts from us. We are not working out the way we should, which will give long-term dividends, right? My term for this is, it's called long-term myopia. Anything that affects us in the long term, we are myopic towards it. Now, the only stakeholder I hope will wake up is the government as a regulator, the government as a spender. They need to run public PR activities where they educate the people. As Dr. here said, a lot of people don't understand. People think Maggi is okay. People think fried food is okay. I think incentivizing good behavior, penalizing bad behavior, investing in general education awareness of what constitutes good health. People are eating at 1 a.m. pizza or a chicken biryani. That's going to lead a whole lot of disease burden in the future, right? But humans cannot help themselves. Primal instinct. We have to look at others. We have to look at other stakeholders.
Help ourselves, yeah, but
Majority of them cannot help.
But that actually gives a wrong message to everybody that, although what you're saying may be right in a way, but
food industry as evil. First, more than the food industry, the farmers will come and attack us because all their food waste, their wastage is, they do not waste more food because of the food industry.
So we have,
all the food.
yeah, we have
and
some.
The second is the government will come running because they make a lot of revenue to the government. So these two factors keep in mind. And the food industry also, yes, it has to be blamed. But then the point is, they are also doing that majorly because they have lack of awareness of good food.
So while we understand these problems, how to address these issues is what Professor Sarang is going to tell us. How do we address it amicably and make it sound good to everybody, and at the same time convey the important message to people to change their habits. Maybe you can use yeah, that's what.
On a lighter note, one way to address it is when you go out for lunch, be very careful of what's kept there and be conscious of what you eat. We'll be able to test the hypothesis here. So, but I want to make a couple of serious points. One is, I guess we have to not treat this as a moral or an ethical issue, because that gets the temperature rising and then a lot of controversies. I think there are 2 or 3 streams of science that we can lean on. Again, I'm emphasizing that this is not common sense. Okay, we just have to acknowledge. So rely on psychologists. They have a lot of understanding of what drives human behavior. Some of economics, and we've now come a long way from saying everything should be driven by monetary incentives. Now we've understood the limitations. So that's what I'm also saying. So I'm just saying that that's not sustainable. There are limits to monetary incentives. But there's also habit formation, and there's science of understanding why habits are formed in a particular way. Unless we understand those, we are not going to be able to address an issue. It's like in medical science going back maybe 200 years and doing empirical medicine and not doing any diagnostic tests. So I would urge all of us to rely on scientific thinking when we are designing these interventions. And the third sort of stream of thinking is system science, because while we want to change individual behavior, we also want to change the system in which individuals behave in a particular way. Market is one kind of a system. There could be other systems of how patients go from one doctor to another. How do they get food? Where do they get food? I can take a small example. Madam mentioned about fruits and vegetables. So we ran a cluster randomized trial in the outskirts of Hyderabad to increase fruit and vegetable consumption in those populations. And we realized that the access to fruits and vegetables is not a given, right? So now you need to understand the food system. You need to understand how those fruits and vegetables arrive. Why is the price in those peri-urban areas higher sometimes than in the urban markets? And unless you devise a system to reduce those prices, you're not going to be able to increase consumption. So I'm just asking for a more multidisciplinary approach to this problem. That's all I'm saying. Thank you.
I just want to add one point to what Professor Sarang said. Very interesting. I think what he spoke about is this psychology. And I think it's very, very important, and also about how habits are formed. We all know some of us in this group itself, some of us like sweets a lot. Some of us like to eat spicy food, some of them. Some of them don't eat sweets at all. Now all this grooming is done very, very early during childhood. And I think if you are used to eat more number of fruits, more number of healthy diet, that's what keeps you going. I think that's what is important. And then the nudge theory of how to nudge what is good and what is bad. So I think. Yeah.
So we welcome our chief guest, Mr. Sridhar Babu, the Honorable Minister for IT and.
Idea Clinics National Conference 2024 represents the combination of knowledge sharing and skill development. To inspire us today, we have our chief guest, Honorable Minister Sri Dudilla Sridhar Babu, one of the senior most leaders in the Telangana Congress Party, who won for the 5th term as MLA in December 2023. Previously, he served as Minister for Higher Education and NRA Affairs, Minister for Civil Supplies, Consumer Affairs, Legal Metrology, and Legislative Affairs. He is known for carrying developmental works in the backward region and is always close to the people. In 2022, he was appointed as All India Congress Committee Secretary and In-Charge Secretary of Karnataka, currently serving as the Minister of IT, Electronics and Communications, Industry and Commerce, and Legislative Affairs in the government of Kerala. I am absolutely delighted to present our chief guest, the Honorable Minister, Sri Sudhakar Rao. Welcome, sir.
Thank you, sir. Thank you for joining us today and gracing the occasion. We were having a panel discussion on preventing non-communicable diseases. As you are aware, sir, that we have a huge burden of non-communicable disease. We have a burden of almost 100 million people having diabetes in the country, and even bigger number of people having pre-diabetes, and also hypertension, obesity, and other cardiovascular diseases are very prevalent in our population. So we are discussing about what should be the strategies for preventing this, while we are addressing treatment aspects, but we realize that prevention is the important aspect towards improving the health of our population. Madam Pioglitazone, who is the director of NIM, also told us about the new nutrition guidelines which have been released very recently on for improving the, which are healthy, which are looking at aiming towards inculcating healthy eating habits in the population. And we also had a lot of discussion from all the other members of this panel who spoke about various aspects about prevention. And we also realized that technology is an important aspect which has to be harnessed towards spreading the awareness about healthy habits to the population, so that we can go towards preventing these problems. So we would like to have your views on a few points from you on what should be, how we can go ahead with using technology towards these aspects.
So I'll briefly speak before the Honorable Minister Saab speaks. First of all, I think one of the most important aspects of today's conversation has been the doctor of the future will give no medicine, but will instruct his patient in the care of human frame, in diet, and the care and prevention of disease. So it is more about how we prevent through good nutrition, proper nutrition, so that we don't have disease, first of all. We have a very eminent personality amongst us today, Sri Sridhar Babu Garu. I know him since my school days. We had a very, very long association. He used to study law in Jawaharlal Nehru University when I used to be in school in Visakhapatnam, and he used to often visit Vizag, and we have a very long relationship that he also belongs to the same, he is our MLA from the same constituency where we also come from, the Manthani constituency of Telangana. And just want to let you know, they're very erudite, very educated, energetic, very, very empathetic towards many, many things that are happening around us, ethical, and is a great enabler. And that's the reason why he is in this position of industry, commerce, IT, and so many other things, legislative affairs, because he is an enabler. So on behalf of the IDEA clinics and this workshop, a big round of applause and welcome to the Honorable Minister, Sridhar Babuji. So I just want to put very quickly some stats that according to the National Family Health Survey data, in the state of Telangana, on an average, we have 21% of all our adult men who are diabetic, and 18% of all women who are above the age of 15 who are diabetic. Hypertension is a bigger burden, where 36% of our men who are above the age of 15 who are hypertensive, and 29% of women above the age of 15 are hypertensive. So if you do a small subset of people who have both these hypertension and the larger union said it will be around 30% of all the population is having either hypertension or diabetes or both of them. So that's the big chunk of population that NCD care has to address. Having said that, there is a very big national program called the NCPCDS program, National Control for Prevention of Communicable Disease, Non-Communicable Diseases. On an annum, the government of India through the National Health Mission is sanctioning around 2,000 crore rupees for this program for all over India. I mean, which is probably such a minuscule that probably to Telangana we might get around 100 crores every year for prevention of non-communicable diseases. The National Health Policy has been created in 2017, but it is time for Telangana to have a state health policy. And I think it is a very, very apt time that under the able new leadership, we have a state health policy for the state of Telangana. For the country like India, we have states which are on extreme like Uttar Pradesh, Bihar, where the C-section rates are around 2%, 3%, 4%. And in districts like Karimnagar, where the C-section rates are 70, 80%. So there's a huge difference between the states. And even in the state of Telangana, difference between Utnur and Hyderabad. So we require a very, very state-centric Telangana state policy. Another big problem that we are facing in the state of Telangana is rampant alcoholism. 43% of our people are alcoholic, so which is a very big problem. Now, if you look at the projections for the urban Telangana, it is much higher in all these things. The alcohol, hypertension, diabetes, and all of this. And the National Program for Control of Non-Communicable Diseases, 100 crore of rupees every year, and the state is giving around 25 crores for the prevention. But we are spending a huge chunk of money from the treasuries on treatment. For example, for treatment of dialysis, for treatment of CABG, bypass surgery, stents. On an average, the government spends, like in Telangana, 600 crores every year for these procedures, but we are spending not more than 100 crores for prevention. And out of these 100 crores, 80 crores of the money goes for salaries. So we are not able to spend more on treatment. So I think there is a huge opportunity where we can prevent the bypass surgeries, stents, dialysis to happen. The government can invest a little bit more in prevention. And because you are at the helm of the affairs for the industry and information technology, and you have so many E's, and one of the E's is enabler. And I think if health and technology can come together, and we can, and Professor Sarang is here from ISB, if the behavior can be changed in the larger population through influence, through technology. The Johns Hopkins study says that a person will not come for treatment if he is advised that you have to take a tablet or a pill for not more than 6 months. So he needs a push, a nudge, and sometimes a shove, even from his relatives, from his neighbors, from his friends. So this communication strategy has to be designed by something like we have in the police on the 20th floor of the new police building that we have. Something like that, a very, very upscale, upfront, a very modern and futuristic non-communicable disease prevention. That kind of a health promotion setup where we can prevent, because India cannot afford or Telangana cannot afford thousands of crores of investments into treatment. I think by next year we will cross the need of around 1,200 crores of rupees for just bypass and stents and dialysis. So if we can invest 15 or 20% of that money in prevention, and especially if through policies, like for example, the industrial policy says that every industry which has a certain number of employees must have a creche or a mother's place. Similarly, if we can have an NCD clinic in every of the industrial networks. So these sort of things can be nudged by the policy reforms that we can bring through you. So these are some of the things, and I will request Professor Sahai to kindly the panel can speak a couple of other suggestions from our side, and then I think Honorable Minister will take the floor. Thank you. Thank you very much.
Thank you, Dr. Santosh, for giving that very beautiful insight. I would now request all the panel members to give one or two comments so that we can apprise the minister of the scenario, and then we can have him give his comments. So, Dr. Samba Sivaya, can you just give us a few insights onto the NCD burden, the burden of cancer, and what are the aspects of prevention that you would like to say? Very briefly, if you can tell us.
Unfortunately, the cancer in India is rising. All over the globe, it is rising. In India, it's rising. Can be implemented if for screening in the healthcare system. And for men and women, stool occult blood and also colonoscopy once in a decade. So none of us, probably maybe 1 or 2% of the people who are assembled here might have got done some screening colonoscopy. So it's such a minimal penetration. So these two things, the pap smear and then a mammogram and a colonoscopy, these three things will at least detect approved screening mechanisms, and these are easily available at district level hospitals, and even mandal level these things also can be implemented. The embracing of these things is very poor. So the individuals, the persons should be enlightened, and they should take responsibility of their health, and they should they should have this time and motivation to go to these clinics and then take care of their health.
Thank you, sir. Thank you, sir. You have actually highlighted the importance of simple screening tools like screening for cancer, cervical cancer, screening for.
So these images can be transported. So from district levels to transported to Hyderabad city somewhere, and a pathologist or radiologist can go through these things and give a diagnosis.
Absolutely, absolutely. So you have highlighted the importance of technology in terms of spreading the awareness in the rural population. To the last mile we can reach and see that all these screening procedures are done. I would now move on to Dr. Hemlata Garu, who will tell us a little about the message she wants to give about the unhealthy eating habits and how they contribute towards non-communicable disease and what can be done towards that. Just a brief
just
comment.
Now I was discussing about how 56.4% of the disease burden that we see in India. Disease burden means it includes everything, complication of diabetes itself, cardiovascular disease, and many other non-communicable diseases. Disease burden, 56.4% has been found to be contributed by unhealthy dietary habits, and even air pollution and alcohol consumption and other risk factors are coming later than that. So our dietary guidelines give evidence-based recommendations to follow how much foods to be taken, what foods to be taken in what quantities to promote health and also to prevent non-communicable disease that I was just mentioning. It empowers and encourages people to adhere to this healthy dietary habits for improving their own health. And if an individual adheres to healthy dietary habits, in a way it will also be embraced by the culture. And in that way, not only the present generation, across generations also, it has a potential to impact. Over a period of time, healthy dietary habits can be. But for this, I mean, accessibility, affordability, availability of healthy foods is must, and governments have to contribute to making healthy foods available, accessible, and affordable across the communities, across different sections. So
we'll now move to Mr. Vikram and take he's the co-founder of NephroPlus, which is a chain of dialysis centers across the country, and he will just give us his message about what should be done towards prevention of non-communicable disease.
Yeah, and just talking from the private sector perspective, I think if you are expecting private sector to do for the greater good of the society, it's not going to happen. I think the government has a big role to play to convene all the stakeholders, as has been spoken about, understand the vested interest of each of the stakeholder, figure out what are the carrots and sticks that the government can provide in terms of eliciting the right behavior from the each stakeholder. On top of that, creating awareness. I think we came to know today that a lot of people are not aware of what constitutes healthy diet and what constitutes bad diet. I think no other stakeholder other than the government is in the best position to communicate at scale to all the masses and also make sure that eliciting of the right behavior from each of the stakeholder, including the private sector. Private sector will not do anything for the greater good of the society. It has to be mandated from a regulation perspective by the government authorities to elicit the behavior that the government wants us to do.
Thank you, sir. I would now move to Professor Sarang Deo, who's a professor at the Indian School of Business, and he is going to tell us about how to bring about behavioral change, because ultimately we are seeing that we can prevent disease by bringing about a change in behavior. The things that need to be followed are very simple: a healthy diet and increasing physical activity. But doing that requires a lot of behavioral change, and he'll give us a few insights about that.
So thank you, Honorable Minister, for being here. I know health is not your portfolio, but portfolio, but I think there are two direct connections that your portfolio can make to health. One of them is information technology. We've been talking about non-communicable diseases. These diseases don't get cured in days or weeks. So you have patients who live long, generate a lot of data, and that data can be useful in managing their health, right? So this is where good new software products, technology products can play a role. But we increasingly see that there is a gulf between those who make these products and those who consume these products on the healthcare side. So I wonder if there is a way by which two ministries could come together and create an environment where you create meaningful products, create sandboxes to test these products, their efficacies, etc. So that's where health and IT could come together. I think that will be really useful. And the second, which Santosh briefly talked about, I'll emphasize, which is the industries and commerce. In this sector, health has an impact on industrial productivity. And I think that's a case to be made, that people who have diabetes, who have hypertension, who have complications arising from those diseases, bring down the productivity of the state. And so what is the role that the employers, workplaces could play in keeping these people healthy? What kind of incentives, carrots, sticks we could provide? So those are two very sort of concrete things I find where you could act as an enabler in conjunction with other ministries, but more active role. Thank you.
Thank you, Professor Sangdev. I'll quickly ask Dr. Sham to give us a overview of, a recap of what Idea Clinics has been doing and
okay, I'm the final
and
one.
the vision of Idea Clinics before we ask the minister.
So I'm one of the founders of Idea Clinics, and we are grateful that the IT minister agreed, because nowadays everything is technology. And my question is completely different. We are looking at health economics. India, we are full of professionals, and how can healthcare industry add to the GDP of the country? So sir is trying hard to get a lot of industries to Hyderabad. I saw recently Medtronic and all that stuff. The missed opportunity is the huge potential for medical tourism. With the advent of technology, if you see the biggest doctor community in US, UK, they are Indians. This is how the healthcare system in Western society, they are struggling to survive. They are dependent on, the options they have is to immigrate all Indian doctors to their country. So I think as IT minister, if we can take some initiative, help spread the word that there is such a here with advent of technology, I think it can add to, alongside what pharma industry has done, what IT industry has done. I think it's time that we take that initiative, and I'm sure we can become a global player for healthcare for the world. Thank you.
Thank you, Dr. Sham. I think before we hear the minister, we would request him to light the
It is the light of a lamp that pervades all existence. A lamp removes all darkness. It is by a lamp that one can achieve everything. O lamp that denotes transition, I bow down to you. दीपज्योतिः परब्रह्म दीपः सर्वतमोपहः दीपेन साध्यते सर्वं सन्ध्यादीपः नमोऽस्तु ते.
It's my honor to invite our chief guest to address the gathering.
Good afternoon to all. In fact, I'm delighted to be here on this occasion, especially on the National Convention, to promote and to create awareness in regarding to non-communicable diseases. In fact, I was happy to see my young brother, Dr. Santosh, who is here, who has a keen nerve to dedicate his time and energy for the society. So, all my blessings to him. And in fact, all the doctors on the days, Dr. Hemlata Garu, Dr. Shyam Garu from Idea Clinics, Dr. Bhavani Garu, Professor Sarang Dev from ISB, Dr. Rakesh, Professor Samasiva Garu, and an entrepreneur who is contributing for the welfare of the people, Mr. Vikram, Dr. Uma Garu, అదేవిధంగా ఇక్కడికి వచ్చేసిన డాక్టర్స్ ఫ్రాటర్నిటీకి సంబంధించిన అదేవిధంగా ఎండోక్రైనాలజీ సంబంధించి అనేక మంది డాక్టర్స్తో పాటు వివిధ స్థాయిలో పనిచేస్తూ ఉన్న ఇతర మిత్రులందరికీ హృదయపూర్వకంగా నమస్కారాలు తెలియజేస్తూ ఇన్ఫ్యాక్ట్ వెన్ ఐ వాజ్ బీన్ కాల్డ్ ఫర్ దిస్ మీటింగ్ ఐ వాజ్ వండరింగ్ why a IT minister has been called. It's absolutely a pure medical convention. When Dr. Shyam was just mentioning about how technology can be fused, can be embraced to further the welfare of the people through intervention by the technology. Definitely, I appreciate what Professor Sarang Dev was just ascribing. Here, I would like to I was entering into the hall. I was just wondering, what is the diet provided over there during the lunch? I was just thinking about maybe it should be a solid lunch today on Sunday, and many people would have come from across the globe and across our India too. And they would be, definitely, the host would be, I think, the Idea Clinics who is hosting this program will definitely see the best of the feast is being provided in Hyderabad. And Hyderabad, as you know, is almost a cuisine capital. Most famous for our biryani, many people would know. So I was just thinking, to start with, we have just crossed this prevention stage. In lighter vein, I'm just telling, because everybody loves good food. Nobody can resist. I don't think God can resist a good food, right? So when we literally think about, and when we study in our schools and colleges and in the universities, always, either it may be back home, we keep saying, prevention is better than cure. This is the common phrase. in real world, are we trying to ascribe to that? Sometimes it is humanly possible, sometimes it may not be possible. Sometimes the great grit and the determination from the individuals or the society can help them bring this terminology into literal action, prevention. Wherein the government, as said by Mr. Vikram and Professor Sarang, government plays a vital role in regulating the policies. I do understand, but the government also goes by what doctors say, what doctors want, what doctor fraternity wants, or what the hospital means to us. Over a period of 70 years, if you look how we have developed our services, especially the medical services, if you have literally viewed many doctors over here who have rich experience in terms of giving treatment or accessing the best medical prescription, would have been known for the past 70 years. It's been evolving. It's been evolving. Evolution, definitely we can't compare with a 400-year freedom nation like US or any other European nations which have the rich democratic political wisdom they had all through that years of 300 to 400 years. Now we've been learning actually. We've been learning how best we can extend our medical services to the people. I can definitely say, if you compare with 1.4 billion population, the size of population, how a doctor here, either it may be from the government side or is it from private side, I can still say that, given the varied, the economic disparities of our people, the quality of medical attention given, and also the time frame a doctor attends to a patient, it definitely is appreciable when you compare with the US nation. Because I had been to a couple of hospitals when my cousins and my mother had a little problem over there in US. It took hell a lot of time to get a simple X-ray done. The same patient from India, if he is being made to sit for 8 to 9 hours, 9 to 9 hours to have a simple X-ray or CT to be done, the patient will be emotionally, will be getting disturbed. So, the time, the energy, and the response time given by any doctor, even if it is in the public sector or in the private sector, comparatively, it is too fast. It's too fast. When it comes to quality, definitely it all depends to doctor. It all depends to hospital. It all depends upon the intent of the individuals or the hospitals or the clinics which they turn to serve their patient. In India, culturally, any doctor we all think, that any patient will always think, who is next to God is a doctor. No other profession comes into being. Whether you are a great public servant or a great political executive, when it comes to doctor, if a doctor goes or the minister goes or the prime minister goes, attends, if a patient sees his doctor, first he'll greet the doctor itself. So that is the value which has been imparted to an Indian doctor. We shouldn't mix that context link of cultural history, what we have, how people look doctor as the next God. So keeping all this in view, what we do for a period of time, I have endured my political journey for the past 25 years. Got into politics in 99, going through it. One of the main key subject for my constituents is medication. When I try to attend to the needs of to their near and dear, I encounter so many doctors. I go to so many hospitals. I always look upon the quality and also their intent to see the patient with lots of interest, and maybe, a very skillful doctor or a success doctor can't even spare half a second to see a doctor. That also sometimes pains a patient. These are all things what I have seen. I'm just expressing my experiences with you. At the same time, the doctor maybe is too confident enough in his skill that in a half a second or a second or in a minute, he could able to really diagnose and he could be able to really give the medication to the patient. The point here I would like to mention here is, when a doctor hears to a patient, with patience for 2 minutes, that will, cure the patient psychologically to an extent. I always believe in the spiritual thing too, and it's all connected. When you're spiritually very, very strong, no diseases can come down to you. But if we see our cultural legacy, spiritual legacy, still, what Madam was just telling about, 56.4% Indian population has a disease burden. This is a huge number. Definitely, if we see, it's a big burden on the nation. How well we can prevent it? The prevention starts when, mother conceives. The day one, when a new life comes into existence in this world, then we should think of something. Before that itself, I think the prevention should arise. From there, then the journey of the new life comes into being. How does the mother, how does the doctor, how does the family, the husband or the family treats the new life is most important. Because of poverty, over a period of time, these things was not at all countable, because the bare existence for the family was the great thing for the family. With the new life, emotionally, they would take and celebrate. But the point there is, they won't have, if they would like to put in their resources for a healthy lifestyle, they won't have had all these years. Certain section of the people still don't have, sorry to say, but still don't have that luxury of giving great nutrition to the new life. That's where we start. That's where the government comes into picture. Over a period of time, the evolution, the government conceived so many policy initiatives with whatever the budgetary constraints they had. The nutritional issues have been addressed. The nutritional issues in terms of mothers, in terms of now, if you can see from the school itself, before the school itself, government has a special initiative through the central government and the state governments. We have so many initiatives to give a healthy diet to all the kids, starting from, age 3 till they finish their degree courses of exam. So whatever the government does is one part, whatever the individual does is one part, whatever the doctors who treats the patient is another part. So as rightly told by the elders on the days, definitely on behalf of government over a period of time, the budgetary spending has also been increased. If you see from 60s till now, whether it is union government or is a state government, the budgetary spending is slightly increasing, but many people won't agree. It is not equal to what is being expected. At least 6 to 9% of the total budget size should be spent on the health. That's what many doctors have been prescribed now in the last budgetary exercise, what we took before our parliamentary elections. From day after we have budget sessions. Already we post 6% of our total budget to be provided for this health sector. Professor Sarangdev, definitely, if you would like to give some suggestions on the part of this budgetary exercise, you're welcome. Because this is the initiative what we would like to take it. And second thing is creation of infrastructure. Not only the creation of infrastructure, we also have to see that doctors are available. In many places, if you see, except in cities like Hyderabad or tier 2 or tier 3 cities, doctors are generally not available. I can say from my remote consciences, if we try to request the doctors to come and serve at the government hospitals with many incentives, many doctors won't tend to come there. And one way of, it all depends. So many factors comes into picture. The economic factor, the social factor, the luxury factor, basic necessities factors for the families. All these things come into factor, and that many doctors would tend to settle down in cities. So if you have literally viewed in the year 2012, then government of ours, trying to create qualitative medical infrastructure, not only in terms of physical. We have prescribed and we have made a mandate and regulated a policy that whoever does their graduation in medicine in this state, then it was a competitive state, they have to mandatorily be doing 1 year of a rural service. So this went on for a couple of years. Our government changed. There was everything in democracy, everything runs on the lobby, right? That lobby was too powerful, and that mandated policy has been diluted, and it has moved away from. So that was the real reason. It would have been a win-win situation for a doctor too, who would have seen so many rare cases of the patients, and that could have enabled them to become a good doctor. They missed that part. And in fact, from the government side, the people would have got the best of the doctors to come and aid in the primary treatment. We missed that bus. But today too, our health minister, who is also a very educated and progressive looking minister, has just been thinking about it. There's huge pressure not to put that. So these are all, what I say, professional difficulties, what we political executive face time and again. But we have to overcome all those things. And coming down to, before I speak about technology, coming down to what Dr. Santosh was mentioning about state health policy. Definitely, it's a good suggestion which has been given by my young brother. We are deriving so many policies which were not there after this new state has been formed. So in the process, we are also thinking about having a health policy too. This national convention of yours, definitely, this session of yours, earlier morning session, which many doctors would have taken part, the best suggestions from your side is always invited on behalf of government. And I would definitely take all your good suggestions too and forward it to our colleague, Honorable Minister, Health Minister, and also to our Honorable Chief Minister. Before we make the health policy, we have to literally see what basically the patients or our people in Telangana require. First is affordability. We always see the welfare as a prime criteria because it's a welfare state. India is a welfare state. We always see the affordability of the people to attain the basic medical facilities. So to extend the affordability, our health policy will be evolved. This is a prime and basic principle what we will try to ascribe to it. And also see that the quality of the if you compare with any other corporate big hospitals medication, that is also the next criteria what we would like to keep it in mind. And in health policy, we would like to ascribe to how best we can use the technology to see that the technology helps to get the medicine at the lowest price. The advent of AI or many disruptive technologies which is coming into picture, the new age technologies, cutting edge technologies, or the digital technologies which will help a doctor, a pharma company, or a paramedic to see that they can give the best medical attention to a patient. So the policy will be all comprehensive. The policy shall look into the best suggestions what you will be giving it to us. And I think this is the right time. May not be in this assembly session, we will try to project our policy, but in next session to come, definitely your suggestion will be seen in a very positive manner. When a doctor on the days was speaking on medical tourism policy, I'm happy to note that, and I am to share the news that we are coming up with a medical tourism policy. And we have been inviting many players from the globe to partner with this state and to invest in this state on a big level. Maybe the next visit of our Honorable Chief Minister to US is going to attract a very, very big player who is into the medical tourism. I know the name, but I won't able to really share before it's been signed. So medical tourism policy, we are going to annual now, and many players from all over the globe will be a part and parcel to sail with us, to partner with our state. This is our vision, and at the same time, our favorite subject and the new age technology right now is everybody speaks of artificial intelligence, AI. In each and every scope of the human life, tomorrow, in one form or other, everybody knows even it be a doctor, even it is an advocate, even it is an engineer, or if it pertains to a government servant, the AI is coming. How shall we embrace the technology? How shall we harness the technology and see that the quality of the life of an individual is being improved? If we don't embrace the technology which is coming, somebody will be embracing, somebody will be harnessing the technology, and we will be pulled backward. That's the real reason the government at the highest level in the state are thinking of. In all streams, in all verticals of our economy, we would like to embrace it, and we will harness it to the extent possible that each and every individual of this state should take the advantage of advent of this artificial intelligence. That's the real reason we have a couple of things on mind, and you would be seeing in the next 3 to 4 months how we are trying to put all those things into action. I had gone to a convention in one of the biggest corporate hospitals in Hyderabad. One of the visiting professor, who is a big doctor in a different country, who harnessed this AI technology, who is basically a dental doctor, he was presenting how AI will influence the medical field. So I was too curious to know, because I am from a different background, not from a technology background, as said by my brother. I'm basically a lawyer. So I was just thinking how it will be helpful for him, how doctors, if they don't try to embrace it, will become redundant. In times to come, may become obsolete also. So when he was trying to show the technology and reflect the technology, he just asked one guy in the convention, what are your problems, what you are facing in specific to your dental issues? Then that young man was telling about he has some problem, that root canal and all those things. So that computer was also recording it. And 3.5 version. He just entered and he told another dental doctor of the famous hospital to write the prescription for it. Before the doctor prescribed, what would be the medication? In the split of second, when he had put what is the best medication for this problem, before doctor prescribed it, the same except 1% differentiate. The same medication has been provided by the AI who has been sitting on the other side. So we're just asking him in a very informal way. Yeah, then, most of the clerks will come and they can occupy the stage of a doctor. Then doctor told, I have already imbibed the technology into my practice. And I've been trying to see that how I can outcome the technology and see that I still exist for the patient. Otherwise, the patient can go directly and take the prescription. But now as such, all over the globe, there is no such, because there were mandated legislations. Until doctors prescribed it, no medical store can give the medicine. But still, in times to come, it's all AI driven now. Once we press the button, the medical shops will also come at the doorstep and delivers. That sort of technology will be evolving. I see, if you don't embrace the AI, either it is endocrinology or different verticals of your medicine, it becomes so difficult to survive in this competitive field. As we all know that, you all go through the rigorous exercise of passing out your bachelor's, then you're doing master's, then you're doing super specialization, and couple of specializations going to different institutions all over the globe. Then only the patient recognizes you. Nowadays, the consciousness have increased. And people keep asking also, are you an MBBS doctor or a PG or does you have super specialty? So when it comes to competition, there is heavy competition, I can see. Lot many colleges are also coming up. The qualitative education and the qualitative management of the different institutions also makes an impact. And the best, the cream, as you know, the government attracts in their colleges. And ultimately, the good doctors are provided by either from the private sector or also public sector. So when I mean to say that, what need to be done? So government has taken all the cues from so many doctors, from your fraternity, and our chief minister and our health minister are thinking of providing a health profile card separately to the residents of Telangana, wherein, you know, each and every individual of this state will be provided with a health card. The technology will be involved in that. We will use all the technologies, the latest technologies, and try to give a health card to an individual. From the day one of his birth till he goes to a doctor or till he goes to treatment, or if it this also will be in our health policy. So these are all things what we would try to ascribe to our new health policy. And coming down to the dangerous levels of, you know, diabetic patients increasing day by day. You know, now as told by doctor, 21% among men and 18% among women. And when it comes to hypertension, 36 and 29% for men and women is highly alarming. At the same time, if you look, you always see the West as glossy, dreamy, and greenery. But, you know, if you see the obesity and high, you know, BP patients over there, they're more in number. They're more in number because when you compare the statistics in percentage-wise, it's about 1.4 billion population. Here, the population is comparatively less. But still, we are not going to take the example of some developed nation. We are still developing. We are putting our technology. We are using our energies. We will try to infuse the budgetary exercise onto that and see that we create a healthy, better citizen for this state, for the nation. This is our policy, and after 10 long years, and also this is the first time after Telangana has been formed, we formed the government. We are for pro-poor. We are for a qualitative healthcare, and we will see that, you know, with the rich and experienced doctors sitting here in Hyderabad and all through Telangana, we will take their expertise into our account and see that a healthy Telangana will be evolved in times to come. And I appreciate and I welcome all the doctors in the days and all the doctors, and the young doctors also I see. I appreciate and welcome all the suggestions, what you would like to ascribe to this government, and a couple of sessions of this will definitely be useful and trying to create a positive environment, not only in Telangana, all through the nation. What preventive steps should be taken by any individual in creating and fostering a healthy life for all the individuals of our nation. I once again thank the organizers, and I thank the organizers for making this opportunity to meet the best of the doctors who are sitting here, the talent who has been sitting there. I thank you one and all. Thank you.
Thank you, sir. On behalf of Idea Clinics, I would request Professor Dr. Rakesh Sahai to felicitate our chief guest. I also request Dr. Srinivas Rao and Dr. Shyam to hand over the token of appreciation to our chief guest. Shyam, sir. I request Dr. P. Srinivas Rao, sir. Now I request our chief guest to felicitate Professor Dr. Rakesh Sahai. Professor Sarang Dev. Professor Sarang Dev. Dhanvantari statue have been awarded to our chief guest from our Idea Clinics. Now I request our chief guest to felicitate Professor Sarang Dev. Professor P.V. Rao, and request chief guest to felicitate Dr. P. Srinivas Rao. Dr. Shyam Kalavalapalli. Professor Dr. Samba Sivaya. Sri Vikram Vipula. Sri Vikram Vipula. Dr. Santosh Kumar. I request our chief guest to felicitate Dr. Santosh Kumar. Dr. Hemalada. Professor Vijay Shekhar Reddy. Dr. Kalyan, Dr. Meher Prasad, Dr. Kalyan, thank you so much, sir. We are very honored to have you with us today. Moving on to the next session. Yeah, now we will have 10 minutes break. And meanwhile, the candidates, those who are interested to participate in the quiz, you can register to my right side of the stage. Doctors, those who are willing to participate in the quiz, please register your names and colleges right side to my stage. And we will be having a last panel session after 10 minutes. And after that, we'll be having the workshops.
help us in its application to prevent or screen for diabetic retinopathy. So I welcome Dr. Padmaja and Dr. Shyam and Dr. Rakesh also please on the stage.
Good afternoon, everyone. At the outset, I would like to thank Diabetic for this excellent opportunity. And last year, we spoke about battle against blindness due to diabetic retinopathy. And I think the collaboration can only be a significant collaboration that happened in the last 1 year, that we could come up and we could actually come up with an ICMR project in this 1 year. I'm very happy to give this update. And also at the end of this session, we also have a workshop where all physicians get screened their retinas without any dilatation, whether they, how is their retina and what is the fundus it looks like. So this was a dream, and this was a dream come true with a significant collaboration. And you can see the individuals who have taken part in this collaboration. So when we look at the numbers, yes, all of us, we know that we are the world's most populated countries, and China has a country which has the highest number of people with diabetes, and we are just in the second to them. And when we look at the diabetes, is a multi-system, but I actually acts like a window to the systemic diseases. So when we look at the current burden of people with diabetes in the world, around 537 million, and 50% of them live in China, India, and USA. So that's how we have very developed. And most important thing is when you have diabetes, called venous occlusions. So all together, that is called diabetic eye disease, and they're likely to have 25 times more likely to blind than the people without diabetes. And 1/3 of them, unfortunately, never know about their disease. And when we look at the nation-wise, how much is the diabetic retinopathy burden? This was a multicentric study that was carried out by 20 sites together. We were also partners, LV Prasad Institute. And what we found is that diabetes percentage in India, in 20 states, when we did the nationwide study, it was around 18%. And 12% of them were having diabetic retinopathy. And vision-threatening diabetic retinopathy, which can affect the vision, was around 3 million people were there. That means around 30 lakh people are there who are can become blind due to diabetic retinopathy. And when we do a hospital-based study, that is what we see in our clinics every day, the complications, because the people reach only when they come with the complication. So what we found in a 9-year electronic medical study is that around 2 lakh people with diabetes entered our hospital, and among them around 66,000 were having diabetes, diabetic retinopathy, and half of them were having vision-threatening retinopathy, 50% of them, because usually when they're blind and when they're going to become blind only, they will reach the tertiary care. So then what the big question is for all of us is, India is having highest number of people, very sweet people, then how do we get screened for whether diabetes or diabetic retinopathy? I think this is $1 million question, and usually the question could be complex, but the solution could be very simple, and that is only possible when we have such collaborations which can happen between physicians and ophthalmologists, where you have a simple tool to screen your retina at your clinic and at the physician clinic. So that is how we envisaged this project called Smart Drop. And as Dr. Kalyan Chakravarti said, the SMART means AA enabled, and DROP means diabetic retinopathy outcomes and pathways. And the idea was that we need to have a first person who comes in contact with the people with diabetes is a physician. And a physician could be a diabetologist or a diabetology-oriented physician, or in a villages it could be even a registered medical practitioner. But what is very important is they all should know how they can actually screen for diabetic retinopathy and outcomes. So the simple solution is to have a non-mediatic fundus camera. That means we don't need to dilate anything, and we can just take pictures, and that can be used in the physician images offices, and then also use AA so that there can be a screening at the first level that the patient has a diabetic retinopathy or not. And the aim of this project was to demonstrate that an AA-enabled pathway can actually detect diabetic retinopathy for the more than 90%. And also very important target that we have kept is that the people who walk into Idea clinics, 80% of them will actually screen for diabetic retinopathy, and establish that there is a current pathway at the LV Prasad where we see patients that definitely leads to early detection of diabetic retinopathy and prevent blindness. So that is our hypothesis. And also we wanted to know the systematic screening, that is whoever patient walks in an Idea clinic or a physician clinic will get screened for diabetic retinopathy. And we established 4 Idea clinics. The fundus cameras has been established, all non-mediatic cameras. And then we do all of them. We also introduced something called vision checking, because many retinopathy screenings all over the world, they don't check the vision. But vision actually can sensitize a patient whether there is also vision problem or not. And so we also introduce a mobile-based application to check the vision. And then we do a non-mediatic fundus photo camera screening. And all these patients' images are transmitted over the cloud. There is an AA integrated in all these 4 cameras, which will tell an AA diagnosis. But also all the AA diagnosis is also validated by the image reading center, which is situated in the LV Prasada Institute. And all the patients who require actually treatment or any problem are actually referred. So this is not just a screening project. This is trying to establish a system of screening and also referral and tracking so that the patients with diabetic retinopathy get complete care. And this is how we have established the fundus photograph established, and then training facility to all the members at the Idea clinic. And we also made sure that there are a lot of awareness materials, making that the patient should get also the screening for the diabetic retinopathy. So this has been established in terms of posters. And this is the progress so far. We have a number of patients in diabetes registry. In the last project actually officially started in 11th March. So we have around 1,000 diabetic patients have been entered. And one thing we need to understand that there are factors that we need to look at, that number of patients screened are around 40%, and there is a monthly increment in the form of patients. So even though you offer a non-invasive simple test, how patients will accept, we are seeing a monthly increment. And then what is very important thing as an ophthalmologist that I find is that the 90% of the images are gradable. So I think thanks to our smart team in the Idea clinics. So this indicates that you need not dilate, because this is a big experience for me, that they need not dilate. With a simple test, the camera screening, you can actually have a gradable image which can tell you whether you have diabetic retinopathy or not. And we also found that there are sight-threatening retinopathy. If you just see corresponding LVP arm, you have sight-threatening retinopathy is more than 17%, whereas here we saw only around 2% sight-threatening retinopathy. And we also, as I said, this project is not just a project about screening some numbers, it is about creating a system. So systematic screening. So I really congratulate Idea Clinic to become a pioneer in this, and then hope that this model will succeed in all over the country. So we have also a target for 80% that all the patients who have been screened, referred for a sight-threatening problem also reach to the next level, and that is also again target we are monitoring. It is also around 44%, and we expect that as we move on in this project, we reach our target of 80%. So this is just one example of a 31-year-old type 1 diabetes patient who has been underwent fundus photo in Idea clinics. The top 2 are images that have happened in fundus photo, and then they have been referred, and in LV Prasad. So this patient has a good vision. He has a 20/20 vision, but because of the fundus fracture, he came to LV Prasad, and you can very clearly see that there is a significant diabetic retinopathy changes which can cause any time the blindness. So this is the example of having a patient screen first at the physician clinic. So how probably our study Smart Drop can make a difference is that utilization of, we are actually testing 2 types of whatever the major fundus cameras that are available in the market, and we can actually give some insight into how they work. And then second is guidance on establishing effective pathway, how it can be, tracking can be done, how referral can be done, whatever the lessons we are learning in the project will also give you the learning. And then also Ayushman Bharat actually is giving the physicians to screen per patient 400 rupees has been done. Many government programs will be there, but many of us may not be even knowing and how to implement. Probably in our project also we will see how we can actually implement those systems so that physician will be interested to establish the system, and it is a simple return of investment which we will discuss in panel discussion. So, and analysis of economic impact and cost effectiveness, and most important is the images are actually validated by manual grading, which are just doing through the technology. So the patients even need not go to the eye hospital. So almost 80% of the patients who are having a fundus photo, they need not even come to, only 2% actually are required. More than 90% can be actually screened and given appropriate care at the physician clinic. So it's like, it's going to a physician clinic, going to act like a one-stop clinic for prevention of all complication, and then retinopathy and also prevent blindness. So thank you very much. Actually, Professor Sarangdio was supposed to be part of, so he left, but he had actually given us some outline in terms of how we can discuss. I request Dr. Bhavani also please come. And he asked us, me actually, what are the surprises you had in this program, and then what are your probably where you can look at the improvement. So here I would actually show one thing, because the whole project is about artificial intelligence, and I'll just show one thing. So if you see, I forgot to mention, if you see there is a discrepancy, we are doing all the images, we are doing grading by the manual grading and validating the AA grading that is done by the cameras, which is around 40%. So we want actually, when we do an AA testing, normally when we do in a pilot testing kind of in a labs and all, it usually will be around 90%, 98%. So then actually even a machine can grade, and then physician need not actually depend on an ophthalmologist to grade images. But here we can see that the level of grading is only around 40%. Still there is a long way for us to tweak these AA models in a real scenario where we are getting the opportunity in this project. And probably next year when we present actual interim updates of the project, probably we can tell about the AA more, whether truly our project has been AA enabled or not. So that is one lesson I would say that improvement can be there. In terms of pleasant surprise, I think last 23 years I am there in the retinopathy programs, but the quality of grading of the images has been excellent at the Idea clinics. So which actually indicates that it is possible to screen patients without any dilatation at the physician clinic. So that is, I think, is a big pleasant surprise, and this should be actually thought for every physician, that you can have a camera and you can do without dilatation, you can screen patients for diabetic retinopathy with simple tests. And all of you should also just check your eyes, how simple it is the test, and see your retina, how it is, it takes a second to do the test. So this is one. And of course, in terms of improvements, I would say that the target we thought a simple test, non-invasive test, and I thought all the patients who come in Idea clinics will get the test done, but it is not so. Around 40% only were at the target, but we are in the initial quarter. So this is again a learning probably for us, how we will improve on the thing. And also the referral, like 4 patients out of 9 patients who have been sight-threatening, 4 patients only could reach. So again, we are also improving on the referral percentage.
Thank you, ma'am. I wanted to ask you one question. So just to clarify that, you said that more than about 90% of the images were gradable, means that they were well captured.
Very well captured.
Well captured, but out of that you said that grading was
done by the AI only in 40%.
Yes.
Means it was attempted in only 40% or it was
No. The
attempted
grading
in
was
all of
done.
them, but it was not
Grading was
matching.
done for almost 90% of the images for the AI.
Yeah.
But the AI diagnosis and the manual grading is what we are keeping
So
as the
it
gold
was not
standard.
matching. You are
It's
saying
not
that
matching.
it was not matching. So was the AI over estimating
Yeah.
this
So-
or it was underestimating?
Yeah, we looked at both. So
Yeah.
we looked at the patients whom we have not diagnosed as a no diabetic retinopathy and how much is that?
I request everybody, please be seated. We'll be giving the certificates at 5 o'clock. Please be seated.
You will get your certificate. Please don't worry.
So we looked at both no diabetic retinopathy and also when they had a retinopathy. So what we found is no retinopathy patients having false positive was much more higher. So which can be actually given an unnecessary tension for the patient that they have some retinopathy, but actually it is not retinopathy.
Yeah. So, but in a way of looking at it is that one positive way of looking at it is that it's not missing out people who have retinopathy.
Yes.
It's picking up, the AI is picking up a few more patients rather than those
Unnecessary referrals.
Yeah, so a few unnecessary referrals, it may mean a few unnecessary referrals, but it certainly is picking up those who have a problem.
Yeah.
So that is picked up easily.
That is picked
so the AI seems to be working well, but it needs to be
We need to tweak.
fine-tune it
Yes.
further to sort of avoid the unnecessary referrals. Thank you.
Is it better for AI to overestimate or underestimate?
See, always in a screening programs, whether it is AA or a person, overestimating is better than underestimating because we don't want, means overestimating, of course, it will create burden on the end user. Like for us, like for example, if they do a more unnecessary referrals and they have to come. See, for example, now in the project.
One more question I want to ask is related to this only.
Yeah.
So now we said that we are having overestimation. So overestimation is, again, your final impression is based on the AI image or you're taking another image and deciding
we are
that?
taking the manual grading result as the final image.
Based on the image that is captured by the camera or you're doing another image?
No. Based on the image that is captured by the camera.
Yeah, so now.
But the manual grading is better than the AI grading in around 60% of the cases
Well, but
now.
now with technology, I mean, we can just transfer the images and get a ophthalmologist's opinion on that image.
Yes.
And thereby that can overcome this problem of.
I think what you are telling is a kind of a semi-automated model. So AI should reduce the burden of, for example, we see that in a physician clinic, around 80% will be normal. So if it can pick up saying that these are all normal, at least 60 to 70% if it says correct, you are actually reducing the burden on the ophthalmologist. So you can actually use like a quality matter of some normal images, some 10% will be used as audit, but all referable retinopathy, any retinopathy image
which is picked up by AI should be
sent. So it's like a
cross-checked.
semi-automated model. We cannot depend completely on the AI.
Yeah. So as the AI evolves, we can use a semi-automatic,
Better.
This sort of model where we get all of the images which are picked up as having some degree of retinopathy to be reviewed by the ophthalmologist and those and maybe 10% randomly picked up from the rest of the.
So I think I wanted to ask one question, is that as a physician, having these cameras, do you think it makes economic sense to keep a camera in the in your clinics? Because
I was a strong believer, patients are looking for quality care. So wherever we use, for us, there is a economic incentive both for care provider and also the patient. Patient takes time and energy to visit a doctor. In one stop, we are screening for all organ damage and retinal screening. My impression is patients love it, and especially when we are using technologies like AI, they are extremely grateful to us that we are trying to, and there is a feeling amongst them that they are also contributing towards research and, so I think we got benefited in terms of the service we provide to our patients. And economically, I think it is extremely, it will incentivize physicians.
Yeah. So Dr. Sahai, I think on the national front, for example, the condition like this, for example, to the project like Smart Drop, it could be a small one example of systematic diabetic retinopathy screening, which is not present in the whole India. So we will have our own challenges and learnings when we do this. So how do you envisage, for example, a fundus camera, we know that it is around 3 lakh rupee investment. So the return of investment, probably I would like both Bhavani and your views, like return of investment of this establishment, how we can actually envisage in our clinics.
Okay, thank you, Dr. Padmaja. You know, the cost of each camera, as you said, varies anywhere from 2 lakhs, which is non-AI, to 4 lakhs, which could be 4 or even 5, and some companies have got 6 lakhs integrated with AI. So initially, a physician may think actually this is a huge investment to start off with, but the return of investment on it is really good. Each funders you take a picture of, you don't need to really do it for free. It is chargeable. And Ayushman Bharat, actually, central government is has sanctioned 400 rupees per each funders captured. So that way you do it, the return of investment will be done in the next 2 years. So, and it is an asset for the next 10 years. There is no way that it is going to be depreciated at all. So,
a protocol for conducting this screening across the country and see how we can, do it on a larger scale also.
So recently we come up with a physician, RSSD and Vitreoretinal Society of India, we come up with the guidelines for the physicians, how they can screen at their clinic and refer. Yeah. And also awareness material, what Idea Clinic displayed, were also VRSA and All India Institute. We have material. So all this can be displayed in your clinics, and you can actually visualize the camera yourself, how it will work so quickly, and then one can take pictures.
So in the next few months, we plan to initiate this project on with VRSA. Yeah, quickly. No. The ophthalmologist is going to validate those AI-based models, and the No, the treatment has to be done by the ophthalmologist.
Ophthalmologist only, but the thing is that
ophthalmologist will do the treatment, but picking it up is important, and seeing that we prevent the progression.
See.
So, I think most of the ophthalmologists are, and we are also moving towards having those who are, having a special interest in retina are the ones who are going to,
Correct.
Collaborate and going to take care. So what we are saying is that we are trying to reduce the burden on the ophthalmologist by, being able to screen all the patients in a clinic with a fundus photo.
Actually, as Dr. Sai said, fundus photo is a very objective measure of grading diabetic retinopathy. Then your capability of whether it is an ophthalmologist or physician will not come into picture. So when you have a retinal photograph and when the patient is sensitized that they need to go for the treatment, So depending on the level of retinopathy. So
No, for further analysis, it has
we
to be
will again
dilated.
dilate.
You don't
See,
have to dilate the 100 patients that you're seeing in your clinic. You are identifying 2 or 3 patients who have to go for a more detailed evaluation. The fundus camera has its limitations. Dr. Srinivas,
no, I am telling that it is
that is a
semi-automated
study. That is a study.
model.
That is a study to look at, enabling AI or sort of training AI. We are just training the AI. Now the AI models have been developed. Some of them are being trained. So every company has every instrument has a different AI attached to it. There are some FDA approved AIs, 2 or 3 of them are there, and there are others which are not FDA approved. So the idea is to use this AI models, train them. Train them means if you are giving a feedback on that, interpretation has already come, then we are giving an expert interpretation on that. So the AI, recalibrates based on that expert opinion, and then so that it's better able to picking up ability of the AI happens. So that's the whole idea of the study and of the project that we are looking at.
So AI is like a garbage in, garbage out. So the way we feed the data, the way we train, it will become better and better.
We'll wind up. Yeah. You can summarize them. If you can
So,
summarize. Sure.
Photocoagulation with injections. And I sent to again our Rajan also. He said no need of it all. Within 2 days gap. There's a confusion going on in the retina clinics. Forget about normal ophthalmologist.
no,
So
there could be, but the more
there
and more
could-
actually we are able to talk in a physician clinic itself is an opportunity, because many times these collaborations doesn't happen.
Yeah, so individually there may be some issues, some instances where there may be some difference of opinion. But generally, what we are looking at is, by and large, this is going to cause a lot of improvement, lot of benefit for our patients in terms of getting better care.
Yes.
Thank you.
Thank you so much.
Thank you, Suman. Thank you.
So those of you who are waiting for workshops, we're going to start the workshops now. I request everyone to gather into 2 groups. We're going to have 4 workshops, but we don't have enough number and time to actually do 4 workshops individually. So we'll split into 2 groups, and you will run through 4 stations, and that will be easier. So Dr. Siddharth and Dr. Rinda, you are ready, right? We can send a few group to your thing. So Dr. Ramarao, I request you to please set up your equipment here, and Dr. Padmaja. Dr. Padmaja, if you can set your things across there where the girls are sitting. And so we'll give you 2 time to set up, and in the meanwhile, half of you please go there to Dr. Rinda and team, and Dr. Siddharth, half of you please come here. I will be discussing about CGM and insulin pumps. So half of you please come to this stage, half of you go there. And we'll try to finish off each section in approximately 20 to 25 minutes, Rinda. Okay.
So CGM, insulin, please come. CGM and insulin pump, please come here. And thyroid and FME, please go there. And then we can switch. Madam, I'll send after this. Until then. Okay, okay. Diabetic retinopathy start. Small dark room. Okay, we'll have a break in between and you can just go. Right. You're all endocrine trainees? Endocrine trainees and some doctors. So I specialize in a lot of insulin pump and sensor care. Within 20 minutes, I'm going to try and tell you what is the So I'm going to first of all tell you what is available, because not a lot of and how do we use it? Simple task. I cannot tell you everything and how, but what is available? Two sensors that are available are Freestyle Libre and Freestyle Libre Pro. Freestyle Libre Pro is a sensor which is the size of a coin. This is how the sensor will be applied. They have got a simple applicator, and the sensor sticks onto your skin. You have a small substance camera inside it. So this is very small, very micro filament that is there. It's just like your IV cannula you take off the needle. Just like that, there's a micro cannula. It sits inside the interstitial fluid, which checks the glucose once every 15 minutes for a pro sensor and every minute for the Libre sensor. There is also a very real-time sensor which do it every second, which will be in the pipe. So this is how, first of all, you have to apply it. On the skin, it's an easy application. A lot of videos online, you can see it's patient actually they can self-apply themselves. The sensor is valid for 14 days. don't have to be operated, but once they cross more than 4 centimeters, we usually recommend surgery.
No, it didn't say that because it just looks a little. If you see now, you learn with comparison, but you see like the homogeneity, like there is some posterior acoustic shadowing here, so it's like not as homogeneous that you would want to see. And in fact, like.
Say I apply this automatic sensor. So sensor actually has, the pump in fact has 2 units. The sensor will be applied on one side of the abdomen and the pump goes on the other side. You can apply the sensor on the back of the hand. So once I apply this, the pump initially does not know how much to give. It will not go to auto AI mode as soon as I start. It will start the AI mode after 48 hours. So the pump doesn't know that I'm putting it on a child or an adult, an obese patient. I don't know. It doesn't know. So I have to give it some idea. So what happens is initially when I start the patient on a pump, you have to start it on a manual mode, just like how we did in the manual mode. We start the pump in a manual mode. I said that, okay, this and this hours you give this much rate, that much rate. The pump says, okay, this is what I'm working with. Then over the next 48 hours, every 24 hours, it's an AI, artificial intelligence. So it will sense that, okay, this much insulin is going, the patient sugar is this much. It put not enough or more. Next 24 hours, it titrates down. After 48 hours, the AI kicks in. Artificial intelligence kicks in. Once the artificial intelligence kicks, there are 2 features that are, actually there are 3 features that are available in the sensor. The one is suspend on low and suspend before low. That activates immediately. As soon as you put the patient on the sensor, it activates immediately. So the patient, the sensor, because the pump starts to transmit immediately, right? The sensor starts to transmit immediately. So as soon as the sensor, the pump is recognizing that the sugar is going down, it will immediately stop the delivery of the insulin. Not on low, suspend before low. That means if the track is that from 100 to 70, it is dropping at a faster rate, it will sense and stop the delivery of the insulin. That will start immediately. After 48 hours, auto basal rate will start. Auto basal means how much is the basal rate that is required. So it might be, and that is calculated every 5 minutes. Every 5 minutes, your basal rate changes. The bolus is not auto because the pump doesn't know that when the patient is eating. When we are eating, all the patient needs to do is to enter something called a bolus, which is a manual bolus.
పోయినాయా ఇప్పుడు అవన్నీ పోతున్నాయా అవునా Freestyle Libre Pro, both look the same, both of the same size. You have Libre 2 or 3 coming up, which will be a little smaller, and that will have real-time recording. Now, the Freestyle Libre Pro is a blinded sensor. That means the data the patient cannot see. It's a blinded sensor because we don't want the patient to see. Which is an average of all the glucose reading over the 14 days. It will give us a median of how the sugars are fluctuating over 24 hours. So if you see midnight, 2 a.m., 4 a.m., 6 p.m., 8 p.m., and you see this 2 lines, your readings should be divided. Now this is not an ideal AGP because I've been changing the reading. If you're putting the sensor on and asking the patient to come back in a week or 2 weeks, then you can say that this is the average. Ask the patient to keep coming back. I cannot assess the AGP. I have to guess and assess individual readings. The individual readings, it's just like your reading these for a while, at a glance you will know what's going on. So this patient has predominantly, if you see the times, 6 o'clock, 8 o'clock, there is a postprandial spike. That means after breakfast the sugars are going up, yellow is high, red is low, gray is normal. This is how it should be, and it should be at least 70% within the TRR. Within the time in target is only 40%. Time below target is 0, time above target is more. But that's coming down. What is coming down? The time above target is coming down is because I have been monitoring this patient every 3 days and I am adjusting the insulin. So as I keep seeing this patient over time, hopefully this time in range will.
Digital section. Nice and clean, homogeneous, I don't see anything. And then you've touched the blood vessels again. Okay? All right. So, of course, ultrasound. So we have everything here, how you can take measures, the calipers are there, how to measure the nodules, the volume, the lobes, and then you can also check for the color flow, right? Moving more laterally, this is the carotid and the IG. For patients with Graves and all, this is important if you're looking for that thyroid inferno kind of feature. But, yeah, that's it. And so let's move on to the other side of color here. So this one doesn't demonstrate, it seems, any vascularity to me. Most likely cystic. I covered her a little bit, so a second volunteer would be helpful. Please take more tissues, ma'am. You want to do it? Make sure you have the chair. Otherwise, you'll take some pictures. Yes, that will be easy. Put a little bit more pressure if you want to, just to kind of make more images. You start from like the bottom. Yeah, so go. Yeah, that's the tracheal shadow. Someone can take the pic even once. Yeah, I will save the.
Can you please take a picture? She wants to see.
Achha, okay. No, she wants a picture of her thyroid.
Otherwise, I will save a video, ma'am. You can take that video.
Oh, okay. Yeah, sure. That's good. So, go ahead.
Can you just take a picture?
And so, yeah.
these will be the two lobes.
Yes,
And
but
this is
how
the
to like,
aesthetics, because your image was very clear and I'm not able to get like that clear.
That's
an
okay.
image.
That's okay. We
So
learn
like
gradually.
do I like put more pressure?
Yeah, so you get that comfort zone, maybe little bit more pressures, turn it around. I mean the
That the node is significant. When you call that the node is significant. True. One, when the node loses its shape, when it becomes round, the fatty head emerges, then you say, hey, this is suspicious. And then if you have microcalcific, it's a cystic component, and then you have a cystic, then you have a suspicious nodule in the thyroid. So this is how we look at the lymph nodes. Just show you. That again is a node. That's a node. If you see in the long axis, that's the node. Can you see this? You can see it's how a long is. That's another like a bean shape. So those are all benign lymph nodes. So anybody else, madam? Thank you. Weight of the diagram. Yeah, we can. We can measure the weight. The benign nodules, of course, don't have to be operated, but once they cross more than 4 centimeters, we usually recommend.
No, I didn't say that because it just looks a little. If you see, you learn with comparison, but you see like the homogeneity, like there is some posterior acoustic shadowing. It's like not as homogeneous that you would want to see. And in fact, like.
Patient, I apply this automatic sensor. We apply on one side of the abdomen and the pump goes on the other side. You can apply the sensor on the back of the hand. So once I apply this, the pump doesn't know that I'm putting it on a child or an adult, an obese patient. I don't know. It doesn't know. So I have to give it some idea. So what happens is initially when I start the patient on a pump, you have to start it on a manual mode, just like how we did in the manual mode. We start the pump in a manual mode. I said that, okay, this and this hours you give this much rate, that much rate. The pump says, okay, this is what I'm working with. Then over the next 48 hours, every 24 hours, it's an AI, artificial intelligence. So it will sense that, okay, this much insulin is going, the patient sugar is titrates down. After 48 hours, the AI kicks in. Artificial insulin kicks in. Once the artificial intelligence kicks, there are spent before load. That activates immediately. As soon as you put the patient on the sensor, it activates immediately. So the patient, the sensor, because the pump starts to transmit immediately. So as soon as the sensor, the pump is recognizing that the sugar is going down on low, suspend before low. That means if the track is that from 100 to 70, the basal rate will start. Auto basal means how much is the basal rate that is required. So it might be, the bolus is not auto because the pump doesn't know that when the patient is eating.
అందరికంటే ఎక్కువ మీరే స్టూడెంట్స్ కంటే ఎక్కువ మీరు చదివినట్టు మళ్ళీ అంతే కదా. అదే అట్లానే ఉంటుంది. ఎగ్జామినర్స్ విల్ హ్యావ్ టు రీడ్ మోర్. అందరూ
అన్న కొంచెం పోయి ఇక్కడ ప్లగ్ అన్న అన్న అక్కడ కొంచెం ప్లగ్ పెట్టావా అన్న.
It's there near the star.
Basically, investigations wise, what we do, do it under diagnostics. So we get all these images.
రాలే అన్న.
The answer is not very easy. It is more of a chronic thing. Short-term vision, other things
వస్తున్నాను.
always a combination of all the 5 nerves, that is deep pyramidal, supraperennial, cephalus and plantar. Sorry, together. All these 5 nerves you can block by injecting around these 3 nerves. So the most usually.
Dr. Siddharth, in thyroidectomy you నేర్పించేస్తారంట ఏదో టిష్యూ గ్లవ్స్ వేసుకుని టిష్యూ శాంపుల్ ఏదో తీస్తున్నారు.
So usually you get a lot of the ulcers are plantar ulcers or trophic ulcers. So generally if it's a small ulcer, because of the nerve loss, they won't need an anesthesia. You need painless to cut. But you need a little bit for closure and flap rising and all that, you need anesthesia. So these 5 points, the 5 nerves. So you use those insulin needles, syringes. Again, you can't injure an artery when you're giving a local anesthetic. You cannot injure an artery. The moment you injure an artery, you will increase vascularity because there will be periarterial bleed, and the compression, even 10% of compression will reduce reduce perfusion by 20-30%. So you can't do it. So the technique is you don't directly go to one point and start giving local anesthetic. Local anesthetics are very potent. Like you really don't have to go exactly to that point and give. So you go anywhere near that, it diffuses all around. So that's why we use low concentration, high volume. So for example, for This is the posterior tube. This is the median arteries. This is the left.
ఇది పెట్టి పెట్టినా నా లైట్ ఇది వెళ్ళి ఈ లైట్ అట్లా వస్తుంది ఈ లైట్ వస్తుంది సెంటర్ పెట్టాలి ప్రొఫైల్
ఎవరు అసలు ఏ స్టేట్లో మంచి ఎడ్యుకేషన్ ఏం స్టేట్ వైడ్ ఎక్కడ బాగా యాక్చువల్గా మీ న్యాచురల్గా పిక్చర్ ఈరోజు ప్యాంక్రియాస్ నాకు మెయిల్ పెట్టాడు కెనాట్ ఐ హ్యావ్ మై ఓన్ కాన్ఫరెన్స్ ప్యాంక్రియాస్ కాన్ఫరెన్స్ ఆయన చీఫ్ గెస్ట్గా వెళ్తూ ఉంటారు ఈ మధ్య డయాబెటీస్ మీద ఇంట్రెస్ట్ ఇస్తున్నాడు ఆయన సో తను రాకపోతే కరెక్టే అన్నారు డయాబెటీస్ రీసెర్చ్ చేస్తున్నారు కరెక్టే అందుకే ఐఎస్బి కొంచెం వెరైటీగా నిర్ణయం డైరెక్టర్గా అనిపించాను జనాలు జీతాలు ఇవ్వదు కానీ
90 అమౌంట్
రెటీనా దాన్ని ఐడియా క్లినిక్స్ ఐఎస్వి కల్పించింది.
సో చెప్తాను
People who have not done CGM and insulin pumps, please come here.
All diabetics can we prevent some of them from going
ఓన్లీ ఫుడ్ వీడియో కావాలి అంతేనా ఫోటోనా చూస్తాను ఎఫెక్ట్ కట్టుండే కానీ అమ్మేసాను ఎంతో విన్నాము ఇంకా ఒకసారి అడిగితే ఎందుకంటే నాకు 11th అయితే 9th
అట్లా ప్రాసెస్ ఇప్పుడు ఎవరికైనా రెటినోపతి ఉందా
చూడు మరి చెప్పు ఇంకా మస్తు టైం ఉంది వస్తూనే ఉంటుంది ఇంకా 15 రోజులు మరి ఆ రోజు ఏమో చూద్దాం అడుగుతాడు ఇక్కడ కూర్చోతాడు చూస్తా కూర్చోండి నాకు
Right, please switch stations, please. So please register for endocrine quiz if anybody has not registered yet. Prize money 10,000. Second prize 8,000. Third prize 6,000. CGM insulin pumps, please join here. Okay, so there are two aspects of order. One first is the sensor. The second is the pumps. So sensors and sensors. And the next time to operate. There will be an applicator which is similar to this. The sensor goes in. There will be a pump inside. Sensor then. Very good gum. Yes, for 14 days. There will be an applicator which is similar to this, not those which actually is the one that senses the glucose and the decision. And the needle will actually come.
So this will have two applications. One is Freestyle Pro and the other one is Freestyle Break. Freestyle Break Pro is the one which is a pro for which is like this. What this will do is, as a blind if the patient cannot read easily, this will be with the pro, which is professional. So we will and once the patient comes here, I scan the data and that will show you whatever the things that you have asked. 1 week, 10 days, 40 days, how much are the patient has. Then I plug it on the computer. There will be a software. First, so it will read something like this. Thank you. So there will be a graph which tells me how much of the 14 days or what is the collected data. How much of the sugar is going to work, the target is 71, target rate, how much does it cover, where is it going? Is it midnight or here? Mainly it is after breakfast and after lunch. So I have to tailor the insulin mainly after breakfast and after lunch. This is like a 14-day pattern. It will also give me an estimated age, which is which weighs something like this. Then the other thing I can do is a daily graph. So this patient came to me initially with a sugar of almost average was 240. His time in target, time and target. This is a daily graph. What you saw earlier was a collected graph. Daily, if you see, there is I think much when is in the grade just 70 to 1. The sugar is high, yellow. Low is 0, low is red, yellow is high, gray means no. So time in target is only 5% of the top and time above target is 95%. So I see the patient every 3 days, 2 days, 4 days. I ask them to come here, I scan and see how his sugars are, how his readings are, and I adjust it over time. Over time I keep adjusting every 3 days, 4 days, increase the distance. And if you see, the last day, 79% within target and only 21% above target with no high. Okay, maybe even a little better than also maybe I can increase the distance. But that is the whole usefulness of this application. Mainly in patients who you are starting insulin. Let's say because of your patient who start insulin, you can apply this and ask them to keep coming regularly so that we can adjust the insulin. It cannot be applied for oral hypocalcemia because oral hypocalcemia actually take a long time for the oral drugs to actually work. So unless the patient wants to say, sir, I want to see how much sugar is, just put the sensor, ask them to come back in 2 weeks. Then at least you will know where the sugar is going up. That way you can tell the patient, but not for a daily. For a daily monitoring, what you want is the Freestyle Libre. Freestyle Libre also is a similar sensor, it's just an advanced sensor. The reader will be black, but you don't really need a reader for now. You only need a software. Only Samsung, iPhone, some which are NFC enabled, they can download the app, and as soon as you scan the sensor, it will automatically show the reading from nothing. And you can have multiple, you can scan multiple times, but you have to, for the reader that's available, you have to scan every reader more than the data is covered. In the advanced sensors, you don't have to do anything. The readings will automatically send to your mobile phone without you having to scan. You just have to open the app and see. Yes. And so for that also the sensor will be similar to this. The software is about 5,000. These patients, who do we give patients who are type 1 diabetes, patients who need sometimes who are having gestation diabetes, patients who are having low sugars in the night. Put this on and give them a reader or if they have to stop
पार्क है ना भाई होटल ఏం బాగా లాల్ దర్వాజానే ఉంటా నేను వస్తున్నా ఒక అర్ధ గంటలు వెళ్తాను టైం నటేశ్వరం నా షూట్ అయిపోయింది అయిపోగానే వెళ్తాను మీరు ఎంతమంది వస్తున్నారు
అవునా వెళ్ళరా మీ వాళ్ళు
But it is not meant for a severe
అవునా వెళ్ళామా మళ్ళా వెళ్ళామా అదే వెళ్ళినావా ఇప్పుడే వెళ్ళలేదు అంటున్నా అట్లా చేసినావు వానికి ఏమన్నా మళ్ళీ ఇప్పుడు ఫోన్ చేసి అంటే అది వెళ్తున్నారా అని చెప్పు మళ్ళీ నువ్వు వచ్చేసి ఏడికొస్తావు నాకు పికప్ తీసుకోమని చెప్పు మన ఇంకా మేము మనోళ్ళు మనోళ్ళు కాకుండా ఇంకొకళ్ళు ఉన్నారు వేరే వాళ్ళు కాకుండా ఇంకా సాంబార్ కూడా పోయి వస్తున్నట్టారు పోదామా పైసలో కూర్చొని వచ్చు సికింద్రాబాద్ చెప్తున్నా కదా పోలీసు వాళ్ళ ఎప్పుడు ఇవ్వాలా సరే ఆరేది నడుస్తుంది పోదాం 6 గంటలకు అట్లా పోదాం నువ్వు వచ్చేసి మళ్ళీ ఇప్పుడే బయలుదేరి నువ్వు 6 కల్లా వచ్చేస్తావు మళ్ళీ రామంతపూర్ ఇప్పుడు వెళ్ళాను ఫోన్ చేసి వస్తున్నారని బయలుదేరి నువ్వు ఆడ వచ్చి పికప్ చేసుకుంటాను ఇప్పుడు వెళ్తాను అప్పుడు మళ్ళీ అప్పుడు వెళ్ళాను వచ్చా మళ్ళీ గంట అవుతాను సరే
a lot of fitness programs understand that there is sensor will be a cost which included there so that but actually speaking of pre-diabetic patient which fluctuations so the usefulness of this generally uncontrolled diabetes on insulin. But you can get a snapshot. Let's say if somebody wants to use it, just say, okay, put it on, you can see how where what food you take is going. There is actually Medtronic applicator. This is CGM applicator. So those are the sensors. Now coming to the insulin pumps. There are two types of insulin pumps. 720G and 780G. Only one company makes it. 720G is a manual pump which is fully both pumps look like this. 720G, 780G, both look like this. But the software is different. What is the one which costs? The fully automated pump will cost around 7.6 lakhs. This is around 2.5 lakhs, which is a manual pump. Manual is basically pumps insulin. Manual one thing which is clear. This is the scale of the patient.
depends on where the patient is. Because the book is same. The patient is taking 8 minutes for each week. Use it by 1. Before meals, patient once you set it, you have to just set the patient once and we ask the patient not to set it. So that is about the insulin pump and the automatic one will have a sensor. This has sensor.
We request the quiz participants to come forward.
Second feature of the AI is based on how much insulin has to be fed. Every 5 minutes, the insulin rate will be adjusted as per the sugar levels. That is the basic. As soon as and then based on that, then correct. It's correction of that. That based on what the sugar is. Let's say the sugar is 200. Let's say that we have to give a correction. Take the from 6 plus 2 and sugar is going up despite 8 minutes. So that I have to tell them that as much as So that's what ICR with our patient. Okay, so you think that we have over given there is something called the same based on the previous responses. What the patient will think if the company stop the sensor.
Good evening, I'm Rohit from Osmania Medical College, General Medicine Department.
Good evening, I'm Dr. Vishal from the Nizam's Institute of Medical Sciences.
Hospital administration. Dr. Aarti Devi and team. Okay, so we'll come to you later. So you yourself can introduce. A lot of time.
I'm Dr. Tanura.
Okay.
I am PG, Department of Pediatrics, Carnelian and
Tanura.
Tahura, sir.
Tahura. Okay, nice.
Myself, Dr. Naresh, final PG, Department of Pediatrics, Government Institute of Medical Sciences.
I'm
Siddharth from KIMS Secunderabad, DLB, first year internal medicine institute.
I'm Tarun, KIMS Secunderabad, medicine institute.
I'm Bhagyashree, second year resident in Endocrinology, KIMS Secunderabad. I'm Tushara, first year resident in Endocrinology, KIMS.
Myself, Dr. Syed Ali, 5-year resident, Department of Endocrinology from USA Medical College.
I'm Dr. Divyashree, DNB Endocrinology resident, NIMS, Hyderabad. I'm Dr. Nandayan, third year resident from Endocrinology and from Yashoda.
I'm Dr. Girija, second year endo resident from Yashoda Hospitals.
I'm Dr. Srikant, DNB Endocrinology, first year resident from KL Banjara.
Good evening, I'm Dr. Rakshika, first year endocrinology resident at Yashoda.
Yashoda.
I'm Dr. Aarti, second year endocrinology resident from Osmania.
I'm Dr. Mahin, first year endocrine resident from Osmania.
Okay, so you will receive an answer sheet. So questions will be displayed on the screen. You will be writing the answers, and we'll collect your answer sheets. We'll evaluate your answer sheets, and we'll eliminate the last 3 teams in this first round. So directly we are going to start with round 3. Yes. So this is the first question. Please read carefully. So 35-year-old female patient presents with fatigue, weight gain and cold intolerance. Her TSH levels were elevated and her free T4 levels were low. So what is the most likely diagnosis? So can I move to second question? So coming to the second question, 50-year-old male with a history of hypertension and hypocalcemia found to have elevated aldosterone levels and suppressed renin activity. What is the most likely diagnosis? So options A, Cushing syndrome, B, Addison's, C, Conn's, and D, pheochromocytoma. So can I move to the next question? What is the confirmatory test used for primary hyperaldosteronism? Option C, dexamethasone suppression test. B, ACT simulation test. C, adrenal venous sampling. And D, glucose tolerance test. If you have any doubts in the question, you can ask. Question 4. A 45-year-old male presents with hyperpigmentation, weight loss, hypertension, his cortisol levels were low, his TSH levels were elevated. What is the diagnosis? These are not so tough questions. Questions are framed keeping in view of internal medicine people also. Can I move to the next question? have any doubts, you can ask. So coming to the question number 5, which of the following is the primary cause of secondary hyperparathyroidism in patients with chronic kidney disease? Low calcium levels, high phosphate levels, low vitamin D levels, and high calcium levels. What is the primary cause? Can I move to the next question? A patient with history of thyroid surgery presents with muscle cramps, tingling in the hands and feet, lab results show low calcium, low PTH levels. What is the most likely diagnosis? Option C, primary hyperparathyroidism, B, secondary hyperparathyroidism, C, hypoparathyroidism, and D, pseudo-hypoparathyroidism. Question number 7. 30-year-old female presents with weight loss, GI disturbances, and palpitations. Her TSH levels were suppressed, and free T4 and T3 levels were elevated. What is the most likely diagnosis in this patient? A, Hashimoto, B, Graves, C, subacute thyroiditis, and D, secure thyroid syndrome. If you need any clarifications, you can ask regarding the question. Question number 8. A patient presents with severe headaches, sweating, and palpitations. Lab results reveal elevated catecholamines and metanephrines. So, what is the most likely diagnosis in this case? A, Addison's, B, Conn's, C, fibrocytoma, and D, Cushing syndrome. Question 9. Which of the following conditions is characterized by overproduction of IGF-1, insulin-like growth factor 1? Acromegaly, Addison's, Cushing's, and Graves' disease. Coming to the last question of the round, 10th question. Which enzyme is deficient in classical congenital adrenal hyperplasia? Most common enzyme. 11 beta hydroxylase, 17 alpha hydroxylase, 21 alpha hydroxylase, 3 beta hydroxysteroid dehydrogenase. So this is the end of round 3. I think you can give your answer sheets. So, coming to this discussion, so I think you can answer this first question. Hashimoto thyroiditis. So, why are you suspecting Hashimoto thyroiditis? So, clinically it is hypothyroidism and TSH is elevated, so which is primary hypothyroidism. So, primary hypothyroidism is the lesion is at the level of thyroid. Okay, so that is Hashimoto thyroiditis. So second question, your team can answer.
Because a patient has hypertension with hypocalcemia and elevated aldosterone levels, we're thinking of primary hyperaldosteronism.
So can you just explain how it causes hypocalcemia?
So aldosterone will act on the the distal renal tubule. On the middle of body surface. Which will cause more and more reabsorption of the potassium leading to
Only to panic.
There is reabsorption, sodium and water, wastage of potassium. So answer is Conn syndrome. So Conn syndrome is Conn is nothing but the name of a scientist. So he has diagnosed adrenal adenoma with hyperaldosteronism levels. So that's why the name was given to that syndrome as Conn syndrome. So I think your team can come with the answer on this explanation.
So confirmatory test is adrenal sampling.
So how? Why?
So after finding out that biochemically proven that hyperaldosteronism is there, we have to localize their conditions depending on whether it is unilateral or bilateral. Accordingly, the line of management will be depending on. So for that to decide, we will do this adrenal sampling.
To be precise, adrenal venous sampling is a localization test. It is not confirmatory. So confirmatory will be saline loading test. So, but anyhow, what are the 4 options? So we can take adrenal venous sampling. So, are you comfortable with the question and can you answer?
Hyperpigmentation, weight loss with hypotension. So lack of cortisol and aldosterone. So Addison's disease.
Addison's disease. So can you just list out the causes of Addison's disease?
So
just 1, 2, 3, 4, 5.
In India, still the infection like tuberculosis is the most common cause, whereas worldwide the most common cause is autoimmune. So others like adrenal leukodystrophy can cause, and other genetic conditions can cause. Then metastasis can cause. Other infections like histoplasmosis.
So the questions was so simple. So out of all the 9 teams, so 4 teams has got 10 out of 10 and 5 teams has got 9. So we could not eliminate the last 3 teams. So because if we have to eliminate, we have to eliminate the 5 teams. So maybe, so endocrine team, internal medicine people are also fighting a lot and competing with you. So what we'll do, so we'll go to the next round and then we'll club answers of both rounds and then we'll eliminate. Okay? So do you want the discussion of remaining questions or can we go to the next round? So next round. So in the second round, so you can see the question on the screen. So 7-year-old child presents with back pain, muscle weakness, delayed growth. Physical examination reveals deformities such as bowed legs. So laboratory tests show low levels of vitamin D, elevated alkaline phosphatase. What is the most likely diagnosis? Osteoporosis, rickets, osteomyelitis, scurvy. So coming to the second question of this round. So patient with hypercalcemia, elevated PTH levels and family history of MEN1. So which of the following is the most likely cause of this hypercalcemia? Medullary thyroid carcinoma, parathyroid hyperplasia, pheochromocytoma, and pituitary adenoma. So can I move to the third question? So what t-score value is typically used to diagnose osteoporosis? T-score less than 1, -1, -1 to -2.5, -2 to -3, less than -2.5. So which is used to diagnose osteoporosis? Next question. Which of the following is syndrome most commonly associated with syndromic short stature? Most commonly. Turner, Marfan, Klinefelter, all of the above. Which syndrome has short stature? Patient presents with short stature to the clinic. I think that's an easy answer. So coming to the next question. So women presenting with headache, abdominal pain, weight loss, multiple brain tumors, with a history of renal cell carcinoma, with elevated blood pressure and palpable abdominal mass. So what is the diagnosis in this clinical scenario? MEN2, von Hippel-Lindau syndrome, neurofibromatosis, and cystic fibrosis. Coming to the next question. 35-year-old female with bipolar disorder presents with polyuria, polydipsia, hypernatremia. So which of the following medications cause these symptoms? Lithium, valproate, carbamazepine, and lamotrigine. Next question. 48-year-old patient with episodes of sweating, palpitations, confusion. So these episodes show glucose levels of less than 40 milligrams per deciliter with elevated insulin levels and C-peptide levels. Which of the following is the most common cause with these symptoms? Hyperthyroidism, insulinoma, Addison's disease, and pheochromocytoma. Coming to the next question. So, a male patient with fatigue, joint pain, brown skin pigmentation. So, test revealed serum ferritin and transferrin elevated saturation levels. So, what is the most common likely diagnosis? Addison's, hemochromatosis, Cushing's, or Wilson's. So, moving to the next question. A hyperthyroid patient on treatment presents with recent history of unexplained hypoglycemic episodes. Laboratory tests revealed elevated insulin and C-peptide levels and history of frequent episodes of hypoglycemia. What is the most likely diagnosis? Insulin autoimmune syndrome, Precocious hypoglycemia, Addison's disease, and hypothyroidism. So coming to the next question. 30-year-old female presents with amenorrhea, galactorrhea, visual field defects. Lab tests reveal elevated prolactin levels. So what is the most likely diagnosis? Pituitary adenoma, hypothyroidism, polycystic ovary syndrome, and hyperthyroidism. So we are ending this round. Please give your answer sheets. So can you answer this question?
So 30-year female with amenorrhea, galactorrhea, and visual field defects. The visual field defects being there and goes to field with pituitary adenoma.
Emphasize that answer.
Pituitary.
So can you explain that? Why can't it be hypothyroidism?
Elevated prolactin can happen in PCOS also, but
So can you explain how hypothyroidism can cause this symptom? That is called as one-way Cronbach syndrome. So what is von Willebrand syndrome? That syndrome will not present at this age, so though it presents in the pre-pubertal age. Okay, so but simple hypothyroidism also can present with these symptoms. Can you explain?
Hyperthyroid patient is probably the methimazole he is taking. So along with elevated insulin and cigarette, probably autoimmune syndrome.
Autoimmune syndrome.
Yeah.
So why methimazole causes insulin autoimmune syndrome? What is the reason for methimazole to cause insulin autoimmune syndrome?
Antibody.
What is that molecule? Can anyone answer? What is that molecule or mimicry of methimazole responsible for activating insulin antibodies? Do you know sulfonyl group of any compound can initiate autoimmunity against insulin? Not only sulfonyl groups, fluorocarbon groups also can initiate the autoimmunity. So this is easy question. I think internal medicine people can answer this. Hemochromatosis. Can you answer this? So everyone can answer. So what is the criteria to say hyperinsulinemic hypoglycemia?
So first is bringing hypoglycemic is to test or to further evaluate results
After we finish biochemical confirmation, what is the criteria?
to say it as hyperinsulinemic hypoglycemia average levels is less than 50 and simultaneous sample of C-peptide more than 0.6 microgram per ml and serum insulin more than 3.2 milli-international.
3.2?
Milli-international.
3. This is according to which protocol? So here, 3 teams got 10 out of 10 in this round. So we can't eliminate last 5. So we'll do another round, and then we'll take the first 3 or 4 teams for the finals. So coming to round 5, round 3. So which of the following describes indication for cabergoline in the treatment of acromegaly? Hyperprolactinemia, GH and prolactin adenomas. It can be used as a surgical adjuvant, or it is contraindicated in this situation. Can I move to the next question? A 16-year-old girl presents with primary amenorrhea with no signs of breast development. Physical examination reveals normal female external genitalia. What is the most common cause in this patient? PCOS, gonadal dysgenesis, androgen insensitivity syndrome, none of the above. Primary amenorrhea and no signs of breast development with normal external genitalia. 52-year-old woman presents with persistent bone pain, muscle weakness, multiple stress fractures over the past year. Lab test revealed severe hypophosphatemia, elevated alkaline phosphatase, inappropriately low vitamin D, and gallium butanol revealed uptake in the lower femoral condyle. What is the most appropriate management for this patient? Tumor resection, oral phosphate supplement, vitamin D supplement, and bisphosphonate therapy. Can I move to the next question? A 45-year-old woman presents with weight gain, moon faces, purple striae on her abdomen, 24-hour urinary free cortisol was elevated, MRI revealed no lesions, but CT abdomen revealed 1 centimeter lesion in the right adrenal gland. What is the diagnosis? Is it a pituitary Cushing, adrenal Cushing, ectopic Cushing, or none of the above? Can I move to the next? So 35-year-old women presents with weight loss, heat intolerance, and diffusely enlarged thyroid. Which of the following antibodies is most likely to be positive? TPO, thyroglobulin, TSH receptor antibodies, and antinuclear antibodies. So next question, a patient with a history of MEN2 presents with episodic headaches, sweating and palpitations. Which of the following test is appropriate for the diagnosis? Calcium levels, metanephrines, thyroid function test, and ACTH. So 30-year-old man presents with symptoms of infertility, gynecomastia, and reduced muscle mass. Genetic testing reveals karyotyping of 47XXY. So it is normal karyotype, Turner, Klinefelter, Android insensitivity. Next question. A 3-year-old boy brought to clinic for evaluation of poor growth and feeding difficulties. Physical examination reveals small triangular face with prominent forehead. Genetic testing indicates loss of methylation on chromosome 11p15. So what is the answer? Russell-Silver syndrome, Turner syndrome, Prader-Willi syndrome, or Klinefelter's? Next question, 40-year-old woman with history of Graves' disease, presents with bulging eyes, double vision, and eyelid retraction. Upon examination, she had proptosis and signs of conjunctival injection. What is the most appropriate initial treatment for her Graves' orbitopathy? So this is thyroid eye disease, who presented in.
It is an active eye disease. Initially, we go with metformin 500 mg, like 6 doses weekly daily for 6 weeks, followed by 250 mg for 6 weeks. That with we can club it with LMFs. After the active eye disease is settled, then only we can club it. So decompression.
directly we will go for decompression surgery. So you won't give 1 gram of methylprednisolone, alternate days or consecutive 3 days. You will give, right? So 1 gram of methylprednisolone consecutively you will go for 3 days. And then you will give, if there is no improvement in the activity or severity, so then you will go for orbital decompression. So can you answer this? How?
Triangular, there are criteria for preference. One is the triangular faces, and then the relative microcavity that they will have, and feeding difficulties that they have, and also they will be known as STLs with chromosome marker.
What do you expect in growth hormone stimulation test in this patient?
Resistance.
Is all the patient will have resistance mechanism? So what growth hormone stimulation test do you expect in this patient? No. So patients will be short, but they will have normal growth hormone stimulation test. I think this is easy to answer. So this is also easy to answer. This is also easy to answer. So this one, adrenal Cushing's. Good. This one. So what is the diagnosis? Tumor-induced osteomalacia. So what is the most common cause of lesion where you will find in tumor-induced osteomalacia? Complete gonadal dysgenesis. Growth hormone, prolactin, adenine, mammosomatotropinomas.
తినాలి రెడీ అప్పుడు తెలుసుకున్నాను వాడికి
So we have got the results. So 4 teams got selected for the. So 4 teams.
పైకి ఎక్కండి సార్ అట్లా కష్టపడి ఎగ్జామ్ రాస్తారు.
So much difficulty. So we have eliminated 5 teams out of 9. So 4 teams got selected for the final round. So how we selected these 4 teams? So we have taken the last round, which is a difficult round. So we have taken that much as a priority and have filtered the teams. So first team, team number 6, Dr. N. Divyashri and Dr. Syed Ali. So they have got 29, scored 10 in the first round, 10 in the second round, and 9 in the final round. So the next 3 positions, they are sharing together with 28 marks. So you can see. So team 5, Dr. Nanda and Dr. Girija Kalyani. So they got 9 in the first round, 10 in the second round, and 9 in the third round. Congratulations. And team 4, Dr. Bhagyashree and Dr. Tushara. So they got 9 in the first round, 10 in the second round, and 9 in the final round. Congratulations. And team 3, Dr. Aarti Devi and Dr. Sheikh. So 9 in the first round, 10 in the second round, and 9 in the final round. So congratulations to all the team members. So So now we are going to conduct rapid round. So we will be calling each team, one team onto the stage, and we will be giving 8 questions. So that's a rapid round question. So only 5 seconds will be given to you to answer the question. And if you can't answer in that 5 seconds, so then you will lose the mark. So we have 4 sets of questions. We have 4 slips in our hands, in my hands. So each team can choose one set of questions. So team 3, Dr. Bharti and Dr. Sheikh, please come onto the stage. So choose. Okay, so you will have 5 seconds for each question. So the moment I finish the question, so you have to answer within 5 seconds. So first question. So what is the cutoff used in basal and ACT, CRH stimulated test in IBS? More than 2 and more than 3. So give them one.
Put mic.
So what is the mechanism of romosozumab? Human monoclonal antibody for sclerosis. So when you go for FNA in PRAS classification, PR4, 1.5 centimeters, more than or equal to 1.5 centimeters, correct? So what is the TIR cutoff you use for old age patients?
More than 50%.
More than 50%. What is the cutoff?
70 to 180.
70 to 180. Good. So what is the triad for Meckel-Norberg syndrome?
Carefully, precocious puberty.
Good, correct. What is the ketone body measured in capillary ketometer? Beta hydroxybutyrate, correct. So calcitonin is used as a prognostic marker in which tumor?
Medullary thyroid.
Correct. So what are the bone derived hormones you know? So name 3. FGF23. Okay. So we are stopping this round. So I think you have got 7 out of 8 questions. Cytosis.
And cytosis.
No, each question has got only 5 seconds to answer. Each question will have 5 seconds to answer. So 8 questions, 5 seconds you have got, and you finish the round. There is no 40 seconds. Each question has got 5 seconds to answer. Okay?
There is a question raised. Because they have written, no, see the key given is this one. We don't know what is Klinefelter's or what is the other.
Everybody got money because of that. Yeah.
Question number 7, right? so you have got 1 mark, but you are not qualified for finals.
There is no change in the final.
No change in the final result.
All of them got 1 mark. So the first 4 are first 4. There is no change in the.
Ma'am, can you call second team? Team number 4. So Dr. Bhagyashree and Dr. Tushar. Each question will have 5 seconds for you to answer. So, question number 1. So, PTEX2 mutation causes which hormone deficiency? PTEX2 mutation causes which hormone deficiency? Second question. Describe the T-zipatide action. Describe the T-zipatide action. What is the mechanism of action of T-zipatide?
It is GLP-1 and GLP-1. So it is GLP-1 and GLP-1.
GLP-1, correct. So, question number 3. So, in Bethesda 3 classification of histopathology, if you do a molecular testing, which mutation confirms more than 95% malignancy? And? So, just only one answer we have answered. It is BRAF and RET. In RAS, it is only 60%. Okay. So, number 4. TIR cutoffs used for good glycemic control in pregnant women.
70 to 120.
No?
95%.
Yeah. So, question number 5. What is the new nomenclature given for NAFLD?
MAFLD, metabolically associated.
Elaborate.
MAFLD, metabolically associated fatty liver disease.
Good, correct. Can you describe what is non-binary gender? Non-binary gender. Next question. So name 2 peptide hormones which are used as performance enhancing molecules by athletes. 2 peptide hormones. Peptide hormones. So next question. So what is the most common inheritance of vitamin D dependent resistant rickets type 2A? Inheritance. VDD or type 2A?
Autosomal dominant.
Recessive. So next team. So thank you for answering and trying from your end.
Team number 5.
So team number 5. Dr. Nanda and Dr. Girja Kalyani. So set 3 they have got. So we are starting the round. What is the name given to the sinus which is inferior to the pituitary gland?
Sphenoid sinus.
Correct. What is the mechanism of tolvaptan?
So it will inhibit the T2 receptors and
Correct. Next question. For an ATA intermediate risk thyroid cancer, what is the initial TSH suppression recommended? For an ATA intermediate risk thyroid cancer patients, what is the initial TSH suppression recommended?
intermediate risks.
Intermediate risk ATA.
0.1 to 0.5.
0.1 to 0.5, correct? Question number 4. What is the model name of automated insulin pump available in India? This is only pump available in India, model name.
Medtronic 470.
But time has been lapsed. So next question. What is the nomenclature given for latent autoimmune diabetes in 2019 WHO classification?
Type 1.5 diabetes.
No? Wrong. So which is the ultra long acting insulin recently got approved by FDA? Wrong.
This is for pregnancy diabetes. No,
Ultra long acting, yes. Anyhow, the question has been cancelled, so I can't get marked for this. Okay. So, in a biochemically diagnosed insulinoma patient, so in a negative non-invasive radiological localization study, and you got negative in endoscopic ultrasonography, what is the invasive test you use to localize this tumor?
Surgical exploration.
Wrong. Selective arterial calcium stimulation test you use. So the last question. What is pyridinolin? What is pyridinolin? It's a bone formation marker. Okay. Thank you. Thank you for answering my questions.
Team number 6.
Team number 6, Divyashri and Syed Ali. Welcome onto the stage. And we got one set of questions. Okay. So, what is post-bilateral adrenal pituitary tumor syndrome called as?
Wilson's disease.
Correct. What is the mechanism of action of aspartate alpha?
Thyroid hormone beta.
Next question. FNA of thyroid suggests fertile cell adenoma. Under which Bethesda classification it comes under?
Bethesda 4.
Bethesda 4, correct. Correct. So, what is AGT stands for in CGM? Continuous glucose monitoring. What is AGT stands for? AGT. Ambulatory glucose profile. So next question. What is the new name given for diabetes insipidus?
AVP deficient. It can be central to AVP deficient disease. AVP resistant disease is the nephrogenic diabetes.
Correct. What is the cutoff taken for growth hormone threshold in glucagon stimulation test in adult growth hormone deficiency?
10.
Wrong, it is 3. So, what is the familial autosomal dominant thyroid condition with normal TSH but high T4 and T3 levels?
Familial dysalbuminemic hyperthyroxemia.
Correct. What is the most common non-functional involvement of endocrine organ in von Hippel-Lindau syndrome? What is the most common endocrine organ with non-functional involvement in von Hippel-Lindau syndrome?
Adrenal.
Pancreatic cyst. So adrenals, they are present with pheochromocytoma, which is a functional endocrine disease. Yes. So thank you. You can take questions. So, how you felt about the quiz? How is the difficulty level? Is it tough or easy? First
two rounds are easy, remaining rounds are
remaining last rounds are tough, right? So first 2 rounds are made easy for internal medicine. Okay, and last round is also, I think it's not that much difficult. I think endocrine residents can answer. So actually we have made, that's why we have asked you to pump your cortisol levels and adrenal levels. Okay, accurate assembly. But rapid fire round is the toughest one. I know that. So we have equally divided the questions across all the 4 sets. Okay, so one mechanism of action of drug, so FNAC or histopathology findings of the thyroid nodules, and new nomenclature of different syndromes in all the 4 sets. So questions has been distributed equally, and I think so. You are okay with your performance. Okay, so if you did not perform well, so don't think bad about that. Maybe the difficulty of the questions are very much high. Maybe you have to read some more. Okay, so Williams and practical questions, ESA, and read the professor books. So all these books you can read for the recent advances and recent new diagnosis. Okay, so I think you can get all the material from online also. I think ESA. So go through the ESA and read the professor books. Thank you. So now the results will be announced by ma'am.
Very well done. I think I'm really glad that all of you really done well, especially it was very difficult to eliminate in the first few rounds and all. So I think the rapid fire was the deciding round. Okay, I think the third place is Team 5. Who is Team 5? Third place is Girija Kalyani and Dr. Nanda from Yashoda, Secunderabad. Congratulations. They got 3 out of the 8 questions right. And the second place is Dr. Divyasri and Syed Ali. Congratulations. And we got 5 out of the 8 questions right. And the first team, the team that won is Team 3. Aarti Devi and Sheikh Mani. And they got 7 and 1/3. I think that one question that you were asking, you did get 1/3 of that mark for that. Okay, congratulations to all the 3 teams. I think we request all the 3 teams to come onto the stage, please.
వచ్చేసాం.
Please come on to the stage, all 3 teams, please.
ఓకే అంటున్నా చెప్పు ఏమైనా అంత టైం వేసుకోవాలి. మైకుడు పోవాలి, చాలా ఇన్ఫార్మ్ చేసింది తప్ప తప్ప. రండి ఫోటో గురించి ప్యాక్ చేసాను. క్లాసులు తీసుకొని లైట్లు ఆఫ్ చేసాను. గ్రూప్ ఫోటో ఓకేనా?
వీడియో వద్దా? గ్రూప్ ఫోటో వీడియో వద్దా? గ్రూప్ ఫోటో ఏం గ్రూప్ ఫోటో?
ఎగ్జామ్ ఉందా?
Okay, CS.
సార్ అందరు గ్రూప్ ఫోటో మేడం మధ్యలో పెట్టు. సిరన్న మేడం మధ్యలో మన అటు ఇటు. తమ్ముడు తమ్ముడు ఆడియో. మేడం మేడం వాళ్ళందరూ నిల్చోమను. అక్కడ కాదు ఇక్కడే మేడం. అక్కడ జరుపుకోండి. మేడం మధ్యలో ఉండండి మేడం.
Wait, see it. Wait. One second, madam.
మేడం ఒక గ్రూప్ ఫోటో మేడం వాళ్ళందరితో గెలిచిన వాళ్ళతో. వాళ్ళందరూ క్రాస్గా నిలిచినారు. ఎస్ రెడీ. ఓకే రెడీ. ఒకసారి కెమెరా లొకేట్.
చెప్తా.
Both team, can you please come on to the dais?
ఇంకోటి
వెయిట్ వచ్చేసింది పైకి. వెయిట్ వన్ సెకండ్.
ఒకసారి అందరికి కొంచెం క్లోజ్గా ఉంటే ఫోటో తీసుకో.
ఎస్ రెడీ.
వెయిట్ వీడియో.
ఓకే థ్యాంక్ యూ.
అన్నా ఇక్కడికి వచ్చేసి అక్కడ ఏం రాదన్నా అది పైకి రావాలి బ్యాక్గ్రౌండ్ బ్యాక్గ్రౌండ్ ఫీల్ పెట్టాను.
Sorry, my name is Sistan. One of you give me the correct spellings, no? You'll come with me. Congratulations.
బ్యాక్గ్రౌండ్ చేంజ్ చేపిస్తుంది. బ్యాక్గ్రౌండ్ చేంజ్ బ్యాక్గ్రౌండ్ ఏదైనా ఐడియా క్లినిక్స్ ఏదైనా ఉందా బ్యాక్గ్రౌండ్ ఏదైనా లోగో ఇదే ఉందా? మరి చెప్పు మనం ఓకే. ఫీడ్బ్యాక్ 2 minutes మీరు టీమ్ అంతా నెక్స్ట్ వాళ్ళైతే రెడీ. మేడం మేడం చెప్పు.
Quite an informative session right from the morning, and I had been watching it through online actually in the morning session. The concept of online streaming as well as offline session was very good, and the workshops were also useful. But one small concern was that I couldn't attend the thyroid workshop actually. I really wanted to attend that, and the quiz was really nice and like really it was the rapid fire round especially. It was so adrenal like we had it. And thank you once again.
అట్లా అందరు సార్ మీరు వచ్చి చెప్పండి. మేడం మేడం వెళ్ళండి మేడం. వెళ్ళండి మైక్ అది పట్టుకుంది. మైక్ ఏదండి? మైక్ ఎక్కడ ఉంది? ఉందా? ఇక్కడ మేడం ఇక్కడ రండి. మిడిల్ వచ్చేసి
First time I am attending this program. It's very good. Actually, for endocrinology people also it is very good. Morning sessions are very nice. Even the workshops are good. But maybe because of lack of time, we could not attend all the workshops. But this is really, really good. Thank you.
నెక్స్ట్ మేడం మీరు చెప్పండి. 1 minute మేడం. 30 seconds. మేడం రమ్మని మైక్ అక్కడ ఇవ్వండి పోడియం దగ్గర మేడం వెళ్ళండి శ్రీకాంత్ ఇచ్చేసే
So the morning sessions were very informative, particularly regarding the thyroid test implementation. I enjoyed it a lot, and also the insulin pump session that was demonstrated. That was also good. And the quiz is really boosting up us to actually upgrade our knowledge as well. Thank you so much.
మేడం కొంచెం అయిపోయి మేడం ఎస్
So the whole conference was really very nice. It gave us a lot of updates, the current advances that are going on. It was very informative. Even the workshops were very helpful. The hands-on workshops were really very nice and fun. And the quiz was indeed very adrenaline stimulating. So we had a lot of fun. Thank you so much. Thank you to all the organizers.
అన్న అయిపోయింది గ్రూప్ ఆఫ్ ఐడియా క్లినిక్
Thank you for all the.
మేడం పైకి మేడం
Thank you for.
మేడం పైకి వచ్చే ఒక
No, the whole idea team needs a great applause. No. I think, and then the whole team of Park, thank you for giving this nice menu. And the food was appreciated by everybody. Thank you. It was a nice food as well. And a special thanks to Purushottam. Thank you for giving this such a wonderful LED screen and seamless projections with a good console people there. There was no glitch at all. Thank you, Purushottam. And thank you, Srikanth, for the wonderful photography as well as the live streaming. Isn't it? I think it is done by you. There are, I don't know how many, 1,200 people joined online, which is really good. Plus, all the delegates that who participated and all the faculty, they have taken their time out for a Sunday. And I think it's a great conference. Thank you. And, two people, special appreciation, Raghav and Ram, I have to say. And I think the whole team really did a good job today, but the background work was done for a long time by Ram and Raghav. I think Sirisha, you have done extremely well in anchoring actually. Comparing Chalavaga Desavu. I don't know if you had done this before, but you had done very well. And thank you, Rishika, in spite of you not being well. I think you actually ran around and got a lot of things. And of course, Dr. Perlin, she was not well in the last 3-4 days, but still I think she managed to come early in the morning itself. And the quiz, thank you, Perlin. Okay, I think I will name everybody: Sujata, Padma, Pavitra, okay, Navneeta, Anusha, Usha, Lokesh, Mani, and Vinod. I think there was a huge Abhilash. Yes, Abhilash. Thank you. No, the thing is, there was a huge crowd here, and then I think biologically you managed very well. When the smart drop discussion was going on, there was a huge disturbance here, but I think you managed very well by taking it outside. Very good. Thank you all.
Group photo. త్వరగా ఏ వద్దు అన్న జల్దీ నా గ్రూప్ ఫోటో సినా సెట్ చేసే సినా ఎస్ ఎస్
ముందుకు వచ్చేసాను.
ముందుకు వచ్చేసి అది కొంచెం వెనక్కి ఉంటుంది, మరీ ముందుకు వస్తారు.
నువ్వే సెట్ చేయాలి. లేకపోతే కొందరు కింద నిల్చోమని
అల్లా ఇప్పుడే కాదు.
ముందు గ్రౌండ్ ఉన్నారు మీరు కూడా
తిన్నా రెడీయా? ఎస్ రెడీ సార్. ఒకరు కింది రెడీ. ఎస్ థ్యాంక్ యూ సార్. రెడీ ఎవ్రీవన్?
వెయిట్ 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 ఓకే. స్మైల్ స్మైల్.
ఓకే వెయిట్ 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 వెయిట్.
థ్యాంక్ యూ.
ప్యాక్ చేస్తున్నా.